Ladies and gentlemen, welcome to part one in the series, we're not sure how many yet, in combat medicine. It's a new territory for most of us, or probably all of us in the country. And Chuck will tell you why. Our guest speaker is Chuck Fenwick, the instructor from Minnesota, from our old stomping grounds. We'd like you to hold your questions till he asks for questions from the audience. If you have questions, we furnished you with a notepad and a pen. Also, we'd ask that for purposes of protecting people's identity, that you do not refer to other people in the audience on tape here as by name, actually, just to protect them from what they may be involved in. I appreciate that. At this time, I'd like to present to you our guest speaker, Chuck Fenwick.
My name is Chuck Fenwick, and I'm from Minnesota. I'm an ex-Navy corpsman, an ex-Air Force medic, Army medic. I have, I guess you could say, extensive emergency medical training, although that is not all that this class is about. First, I'd like to just relay a warning to you that what I'm going to try to teach and impart to you is not complete. You would have to go to school for months, if not years, to learn just through the experience of some of this. And that if you were to think of yourself as some sort of emergency medical technician after you get done with this, and you go out and you ride around looking for people to help, that if you use these techniques and you're not acquainted with them, even if you are acquainted with them, you are liable for what you do. You can, will, and should be held accountable for the mistakes that you make, because you will make mistakes. Medicine is like that. In other words, don't be doing this unless it is an extremely dangerous emergency, life-threatening. And then it shouldn't stop you no matter what the cost. We're here to save lives. We're here to prevent further injuries and cripplings, things like this. But this does not make you a doctor. It does not make you an EMT. It doesn't make you a corpsman. It doesn't make you a medic. All you are is someone who knows something that will give you an edge if problems arise. Medical problems, emergency problems. I have some notes I'm going to read off my computer here to try to explain exactly what this course is, which is combat medicine. This is, well, it's emergency medicine. It's not first responder. It's not even second responder, whatever that would be. This is not ER technology, OR technology, or any of the other types of emergency medicines that we run across all the time. There's a time and a place for all of that. This is combat medicine. There are no ORs, no ERs, no long-term care unless you can get them past this point right here. We have no medevac. There's no helicopters going to come in and help you. No ambulances. You're right there. It's a down, dirty situation. This is the darkest side of medicine that you'll ever see. There's nothing worse, nothing more profound than going through a situation where you have to use these techniques. And it should not scare you into a point of saying, I'd rather not deal with this, because you may have to deal with it whether you like it or not. And there's no way to get around it. Or you may never even run across a situation like this. But if you do, you at least have some sort of foreknowledge. And it principally comes down to your best friend, which is your brain. And actually, his bloodthirsty companion, which we'll be addressing, especially in this first class. I have some notes here, and maybe this will help further in trying to explain. This is combat medicine. All modern medical emergency treatments are based on the assumption that further medical help is available. You know, like do this until the ambulance gets there, do that until you can medevac them or get them to a hospital, accomplish this until transport gets someplace or you can get them to an emergency room. You know, this is why it's called first aid or first responder, first response. This isn't first aid, it's not first response. This is only aid and only response. Now, when you get to natural medical treatment, it's based on the assumption that the person attending the patient has time. You know, they have time to range, find, and identify and treat medical problems. And another aspect of it is natural healing. It's for healing purposes. We're mechanics in combat medicine. We're not healers. I cannot heal you. I can just keep you together long enough for you to heal yourself, and that's all we do. Natural medicine is also based on pharmacology. There's not a whole bunch of difference between penicillin or a natural herb that you find out in the woods someplace, because they both do roughly the same thing. Some of them are better, the natural medicines, or some of them are better than antibiotics you may use. I'll try to get into this more later on. But in a battlefield setting, can be downtown Minneapolis, it can be LA riots, it can be a bank robbery, it can be a car wreck, because the principles are the same. The end result is not always the same, because once again you have no place to take these people. If you do, that's great. That's really fine if you have a hospital to transport to. But you have to think of this and put it in your mind that when you're in one of these situations, and it could very well come up, that there is no transport. So forget that part of it. So what do you do after that? So both these approaches are non sequitur. They do not compute in the long range. You'll use principles from both of them, but combat medicine is not either one of these right here. The first subject I'd like to cover on combat medicine is pressure points. I'd like to explain that I can get into medical terminology, but it is not always a good thing, and it's not something you can easily remember, long words. It's better to call something a bruise on the bone than a subperiosteum hematoma. We can get into the Latin all day long, but it really doesn't do you any good out in the field, because you don't do that much talking anyway, and you don't do that much explaining to someone. I have someone that will help me demonstrate where the pressure points are. Come on in. For a definition, a pressure point is where the artery, or a main artery feeding an injury, lies near the surface and over a bone. And there are about 11 of them. Some of them are split up into doubles, so I guess that makes it 13. Let's see here. Here's the way that an injury works where you have massive bleeding. An artery is under much more pressure than a vein. An artery radiates from the heart to the extremities of the body, and the veins carry the blood back up to the heart. When you see arterial bleeding, it is usually, or it can be sometimes pumping, sometimes it's just oozing out. This is probably the most dangerous of all type of bleeding. And you have points on the body that are called pressure points where an artery actually crosses a bone, and you can put pressure on it. For instance, if the man had a wound up in here and you wanted to stop bleeding and slow the bleeding down other than putting a bandage on it, which is what you'll be doing also, you have to remember that the heart is right here. So you need to find a pressure point that's in between the heart and the wound, always. If you have a wound up here, you don't be trying to look for a pressure point up on top of the body. It just doesn't work. Everything radiates from the heart. If you have a wound in the hand, leg, then your heart is here, so you find a pressure point in one of these areas. The first pressure point that I'll cover is, it's right at, we'll just call it the temple. It's the superficial temporal. Yeah. Now, when you're finding a pressure point, you can actually feel a pulse. Well, sometimes you can feel a pulse. It depends on how much blood the man has lost. And if he had a scalp wound, we'll say, up in this area here, then this pressure point right here might be feeding this. And if it's pumping out, squirting out, you want to stop the bleeding. So you apply pressure at this point right here until the bleeding stops or slows down. If it doesn't stop or slow down, then you have your fingers in the wrong place. You would apply pressure until the bleeding gets under some sort of control, and then you would bandage it. And I'll get into bandages here in a minute. This is one pressure point. Another pressure point, this would just be above the jawline, and there's a fissure right around here. You can feel this, but your artery crosses this prominence right here, the jaw, and you can feel the pulse right here. Anyone want to reach up and grab your jaw? Can you feel the pulse? That's what you check for. You have one up under here, like this. You have what is called a subclavian, or actually on the collarbone. Yes, right here. You can feel around for pressure, for pulse. You want to go ahead and take the shirt off? This is where the artery actually goes up under this. But you can actually use the pressure, the prominence of the bone and the artery, and push it up against the bone itself to help reduce the pressure. You have another artery right in here, the carotid. And this is a dangerous one to mess with, because when you cut off this particular artery right here, the blood flow through it, it cuts it off the brain. I can take this man and put pressure on both of these arteries right here, and he'll pass out. Or I can keep it there longer, and he'll do more than pass out and have brain damage. So you can't, it's obvious you can't apply tourniquets to areas like this right here. You have another pressure point right in here. This is the one when they take your blood pressure. This is where they put the stethoscope. You have two more pressure points right here. One on this side, one on this side right here. In fact, the easiest way to stop the bleeding in the hand is to grab both of them at the same time. You know you've got the right one, no matter what you do. You have another pressure point, which is is called the iliac, or it's just in the groin area, and you have your carotid, you have your femoral artery, it comes up through here, and you have bone prominence, and you can feel the pressure right here. In fact, if someone has lost a lot of body fluid, a lot of blood, you may not be able to get a pulse anywhere else except for right here or up in here. Because just because you take someone's pulse from their arm, they might not even have an arm, but because you don't find the pulse the first time doesn't mean that the man's dead. You can, here's a major pressure point. Then you have another one, which is it's called the femoral, well, this is right up against the femur. And this is probably the most, let's step out in front. Yeah, let's step out front here. These arteries, like this major artery right here, and this major artery right here, are the most life-threatening. If you're going to, if they're severed, the man is probably going to die. There's not much you can do about that in a combat medicine situation, because this takes vascular surgery to repair this. If it's just split, you can do some things about that. This one right here is especially dangerous because it's very elastic. And if there's been a wound that has actually stretched the vein, I mean the artery, into an unusual position, and then the artery severed, it will go right up into the body like a rubber band, and the man will die. There's no tourniquet in the world that will help anybody on that. And even if you could stop the bleeding on a severed artery here, then you're still going to lose a leg. And that's if you could even stop the bleeding. But here's an artery. Right in here. Veins are kind of unusual too. Veins and arteries, they're not always where they're supposed to be. You have to hunt for them. The body is not built like an engine where you can just look at a diagram and say, okay, this is where it is. There are some people that have their majority of their heart might be lying in the wrong plane. You can never go by, okay, well, this is supposed to be like this. It's actually a best guess situation. All right. I'm referring to notes because this is a very important subject, and we need to get it right the first time. There's arteries that run behind the knee. An artery runs behind the knee, and this is for controlling the blood down in this area. And it's called the popliteal, but we'll just call it the knee artery. And if you right in here, you can feel the pulse, and that is another pressure point. This is an excellent pressure point for anything where you have any damage from here on down, even in the foot. A lot of times, when you have damage in the foot, the pressure points that's down here, which I'll get to in a second, are damaged. You can't even get to them anyway. So you go for your best guess. You're another pressure point. Let's take this off. Okay. You have two prominent arteries that come in this area right here. What you should do to learn pressure points is investigate your own body and find the pulses. There's no way I can actually show you the pulse on any kind of video. And after you learn that, then you can go to a subject and check for pulses on their prominent pressure points and learn the pressure points there. This is something that you have to study, and it's something that you have to practice. Combat medicine is not a subject where you write this down, because you can't even carry notes with you. When people go out and play, say, splat ball, they should be playing medicine too. They should be, okay, this man is wounded. Okay, he doesn't get to drink a beer until it's time to go again. He's an actual patient. It doesn't hurt to put all your knowledge into practice, because when you get in the field, it's too late to practice then. If someone wants to go play soldier, go play splat ball, do the macho thing, they have to understand that if they are wounded, if they're hurt, they're out of the game. In real life, they're out of the game. Attrition, just small things, even tiny cuts on the skin can devastate a human being sometimes. And I've seen men that had a small puncture wound, just a small puncture wound in the leg, and it took them out of a combat situation for a month. So we had to be prepared for these emergency situations where we had to employ combat techniques. Now, these combat techniques were learned the hard way at the beginning of World War II, actually. Up until that time, the triage, which I will also cover, was, you treat the worst hurt first, and that is not the case. That's one of the heartbreakers, and I'll be showing you that a little later here. Okay, you can put that back on. Any questions on pressure points?
Are there pressure points on both sides of the body? You were just showing us one
Yes.
side. So there'd be just the opposite for each one.
Yes, and your body's symmetrical.
And I have one more question. Can you feel the pulse? Can you feel the pulse at each one of the pressure points?
Yes. If you can't feel the pulse, you're not in the right place. Unless the man has lost so much body fluid. But then again, you probably won't need a pressure point then. You'll need a chaplain or some bandages and some IV solutions. Any other questions?
Isn't it also true that on an arterial bleed that the blood is spurting and usually bright red?
Yes, but it's even bright red in venous bleeding sometimes, because blood does not care where it gets its oxygen from. And when you come upon someone that has been wounded, your first training in EMT, I'm sure, is to check for an airway, to check, do a superficial checks, all this. But in a combat situation, if you have someone that has been wounded and blood is spurting out of the wound, you don't have to check for an airway. One, you know that they're still alive because it's spurting because the heart's beating. And it might take you a long time. A long time in combat is 1 minute, but it might take you several minutes to establish an airway. In several minutes, a man that has arterial bleeding will die. That is the first and most important aspect of combat medicine, is to stop the bleeding. If you have more than one person with you, someone can check the airway, someone can check anything else they want. But your first concern is bleeding, because it's very difficult to treat shock. You have limited supplies. You might not have any supplies on how to replace the fluid in his body. And if his fluid's gone, even from a small arterial wound, then instead of something being, oh, it's not that bad of a deal, you have a patient who's going to die on you, or worse than that, be sick for 30 days and use up all kinds of medical gear and then die on you. Bleeding is number one, always, in combat medicine. If he has venous bleeding, which I'm getting ready to get into right here, even that's pretty bad. You know, you have to think on your feet. If a man's blue and kicking around and trying to breathe, well, you want to try to clear his airway. But if he's kicking around blue, at least he's kicking still, plug up the wound first and then go for his airway, because it only takes a few seconds to put a bandage on. It takes a long time to put an airway in. You might have to do we'll just call it tracheotomy. You might have to do a trach on someone, and that takes a little bit of time. And if he's bleeding to death, what good is that? If he has, if you're trying to put an IV in someone and establish an airway and all of this, and the blood's leaking out faster, and you can possibly put any kind of fluid in, then you're wasting your time and supply and equipment.
Isn't the general rule of thumb 3 minutes or less for life on an arterial bleed?
I'm not sure I understand the question.
In other words, they can bleed to death, bleed out in 3 minutes or less on an arterial bleed.
The kind of wounds that I have run across sometimes on arterial bleeding, we're talking seconds, not just minutes. If a man has severed a femoral artery, carotid, he's dead anyway, just about, but we're talking seconds. And a crushing wound or even an amputated limb is not even as dangerous as a severed artery. Because a severed artery is going to keep on pumping blood. The body thinks it's okay. When you have an amputated limb, the body knows it's not okay, and it's doing things to try to repair itself. It's a pretty marvelous machine.
When you have an upper head wound and you have to put a pressure point on the neck or on the temple, you said it didn't dress it. But when you let go of that pressure point, isn't it just going to start bleeding again? You can't put a tourniquet on the neck.
True. I'm getting ready to get into dressings, and I'll explain more on this. But you have two hands, and you can apply pressure to a pressure point, and you can use your other hand to be undoing the dressing.
Well, when do you let go of the pressure point?
Slap the dressing on. Now, like, oh, you can't stand there all day and hold on to a pressure point. I mean, if you only have one patient,
The dressing then will close off the bleeding.
The what now?
The dressing will help stop the bleeding.
Yeah, it contains blood long enough and lets it coagulate, clot. And of course, once you put the dressing on, you don't take it back off. If it bleeds through the dressing, you put another one on. If that doesn't work, then you maybe have to go for the pressure points again. You have to let the body, you're a mechanic, that's all you are. You have to let the body try to repair itself. Yes?
How about elevation of the affected areas on the heart? Is that important?
Yeah.
Secondary?
Yeah, I will cover that on attended procedures here. I'm sorry, any other questions on this?
Chuck, I'd just like to say that if the patient is conscious that you've treated, like Ben was asking, that has the head injury, allow them to use their hand to hold pressure on it. You've got something else to do. Put them to work. They're capable of helping make their body work.
Yes. Your patient can help you. And here's a caveat for you. Don't tell the patients what's wrong with them. That will kill a patient. If you don't even know why sometimes. You let someone look at their wound, they'll pass out. You don't want a passed out patient if you can possibly help it. So you do your best not to let them look at their wound, especially. And if they say, "How bad is it, Doc?" you say, "Well, it'll be okay, don't worry about it." Instead of saying, "Well, you got about 30 minutes to live." There's some things you just don't do. Your patient can help you as much as possible, and because they do have sometimes two hands and two arms. Now, when I get into different types of wounds up in here, sometimes you don't want the patient's hand near some of these wounds, because if it's a fracture where you have some sort of missile has penetrated the cranium, then the last thing you want is for him to touch it and be digging around in it or you'd even touch it and dig around in it. Maybe later, but not right then, because this is combat medicine, and you just want to stop the bleeding and protect the wound. This aspect of combat medicine, first aid medicine, anything else, is by far the most important thing that you'll ever learn. If I cannot get this across to you, then I failed in that. And if you don't take this to heart, then you're exceedingly foolish. It doesn't matter what kind of gear that you have in the field. You can have the best IV solutions, the best needle, the best suture material. You can have paddles for someone if their heart quits beating. You can have traction materials. You can have cast wire, all of this. But if you don't have this little thing called a bandage right here, you're going to die. Because we're talking about bleeding and wounds. Because this is called combination dressing or battlefield dressing or a Carlisle bandage. And I would suggest that you call these things not blood stoppers, not first aid bandages or anything else. They're battlefield dressings. That's what they're used for. They're used for applying, this will apply both pressure, and it will also soak up the blood and allow a medium for the blood to clot in. You have another type of dressing called a triangular bandage, and this is just as important as this bandage here when you're talking about small wounds, because the triangular bandage can be used for everything from cravats to slings to headdresses. You can use it for a hat, and all they are is just a piece of muslin shaped like this right here. I'm sure everyone's seen one of these before. Okay. You have another important bandage would be your roller gauze. This right here, you can use this for everything from splinting to subduing a patient when he's kicking around. Someone has a bullet in their spleen, they're not exactly happy, and they're in great pain. Not just the spleen, any place in their body. It hurts. It's terrible pain. They're screaming, they're yelling. You can't tell them to shut up. You might have to subdue them. You might have to time down, especially when you're out in the field, because if they can damage yourself even further. There's certain surgical techniques you use in the field. You better be subduing that patient, because if you don't, he's going to wind up dying just by hitting something when you're cutting on him. There's two types of bandages, of pressure dressings, pressure bandages, these combat battle dressings that you need to carry, get a hold of. You have small ones, and we'll just say medium size. You can get large ones too, but large ones are used to cover wounds that will most likely kill you. And it's nice to have some on hand, but there are some wounds that I will cover in triage that you can't treat. You can treat, but not right then. And their chances of living through it are quite kind of remote. You can imagine the type of wounds that you run across in a field. This is just a medium-sized dressing. We'll cover the exit wound of probably 3/4 of the bullets if you're ever hit by a bullet. So when a bullet enters somebody, we'll just say a 308, you have a small entrance wound. That's really not a big problem with the bleeding, unless it's through a lung, and then you have a problem with air. And when it exits, though, it can be anywhere. It depends on what it hit on the way through, because it takes a lot of goodies with it. It can be anywhere from, say, this size to this size right here, and it can be several different shapes. So A medium-sized dressing is a very important size to have, plus the small ones. The small dressings, yeah, you saw this. I'm going to have to demonstrate. I'm going to demonstrate some of these dressings right here. Okay. I'll give you some definitions first. A dressing or a bandage is anything used to cover, protect, and control an injury, especially an open wound. It doesn't necessarily have to stop bleeding. It could be just to protect it from outside air. It could be if someone has very sensitive skin from, say, sunburn, that you still put a dressing on. And that's what a dressing is. There are several types of dressings. There are field dressings, and these are used to cover uncomplicated open wounds. A field dressing can be a Band-Aid, it can be a piece of duct tape, whatever. You're going to cover the wound with this. These are just like what we would call incisions. And that's an uncomplicated wound. In fact, an incision, just a straight cut in someone's skin, that's good stuff compared to what they could get into. It's clean, it bleeds, it's not going to get infected. You can suture it up later on. If you don't suture it up, it's still going to heal okay. They'll have a scar. Don't worry about the scars. That's the least of these people's problems. When you're in a battlefield situation, you have lots of adrenaline flowing, a lot of fear. Your valves turn to ice. This is not a good time. And when a man or woman becomes wounded, steps in front of Mr. Bullet, there is a lot of times incredible pain. And on top of that, you have fear of dying. They don't know what's going to happen. They're calling for their mother, their daddy, the corpsman, preachers, and someone who's treating them. All of a sudden, you know, I am the corpsman, and I am the mother, and I am the daddy, I am the preacher, I'm the girlfriend, you know, up until you get to the kissing time. I'm all of these things. You're father confessor, you're the loan shark, you never get your money back. Being in medical is very telling, because people come to you, tell them their problems, on and on it goes. But on the battlefield, when a man is wounded, you are so important to him all of a sudden, because he thinks that you are a walking God and everything you do is going to be correct. And at the same time, he's screaming around and kicking because it hurts. Humans are made to make noise when they get hurt. And there's no way, you can't tell somebody, hey, shut up, would you? It doesn't work like that. In fact, that'll actually make things worse. I tell them, hey, scream all you want, I know it hurts. Okay, pressure dressing. Let's say I applied he has an incision, or say some sort of grazing injury where it ripped the skin open right here, and I've applied a dressing to this man's arm, and complete with tape. This is it. You know, be on your way. I'll look at it later. Combat medicine is right then, right there. We're not, you know, worried about long-term care. We're not worried about if he's going to have scars, or even if he has a headache. I could care less about that. I want to get to the next person. But it fails. You don't want to be using expensive bandages or irreplaceable bandages when just a hunk of cotton will do. You gotta hold it. This is your bandage. It's not working. You have a lot of fluid coming through it. So you go to what is called a pressure dressing. And for that, you can use the gauze that I just wrapped this with, or you can use your triangular bandage, and you can fold it into something called a cravat. You do not have time to make fancy folds. You can either do it before you go out in the field, or you can just make some real nice, real quick folds where you have a more or less square situation here. and you're going to bandage it like this. However, you're going to take another piece of bandage, put it over the wound, and then tie your pressure dressing. You usually tie the knot on a pressure dressing over the wound. If it's not a pressure dressing, then you tie it beside the wound, because you may not want pressure on this. But if it keeps on bleeding, you want some sort of pressure to slow the blood down, to give it time to clot, so the man doesn't lose too much fluid, so he doesn't go into irreversible shock, so you don't have to bury him someplace. When you're in a hurry and you're ripping bandages out right and left, you don't have time to fold the bandage. You give it one of these and throw the thing on there. That is one thing about combat medicine that you never have enough time. Ever. You just don't have it. And the more patience you have, the less time that you have. And the less time that you have, and the more patience you have coming in, changes the scene, changes the face of everything. Where your triage, which is normal, you know, here's a sick guy, let's treat him, becomes to, oh, this is a real sick guy, let's don't treat him. Okay, pressure dressings. They will work on any small size wound that you still have trouble controlling the bleeding. Doesn't matter if it's up here, on the thigh, down the foot, on the calf. You don't ever apply pressure to the cranium if there's even remote possibility that there's a fracture. Up in here, that's all right. But inside here, I'll explain this later, these are places that are forbidden. From right here up, there's pressure. Especially on the neck, that's kind of obvious on that one. If it isn't obvious,
Chuck, what if you had a impaled object?
oh, you need something, an object still in the body. If you can get it out relatively easy, it depends on where it is, but if it's in the femur, something like this where you can actually slice through an artery, then you don't want to be doing that. However, if it's just when you make your examination, because you will run your hands all over the body, smell of them, listen to them, then you'll, if you see an object sticking out of the body, if it comes out easily, take the thing out, because that will cause problems later on. But in combat medicine, your first job is to take care of the bleeding so they don't die. And if there's an object inside of somebody, they're not going to bleed to death. And you always have to think of, oh, boy, if I could only do this and I could only do that. No, you better stick with always stick with, let's do the bleeding first. Then we'll get, if you have time, then you get to the rest of it. Because you have, and this will be covered in triage, but your job, especially in a combat situation, is to get as many people back online as you possibly can so they can get killed good and proper. Not a happy time for you. That's just the way it is. Or so they don't get worse, because you can have someone with a small injury and they will die from it. Now, if you're over here treating someone with, say their intestines are hanging out and they have a sucking chest wound and this part of their leg is missing and they have burns, and you're doing heroic things to save this person, and here's a man over here, he's got a broken thumb, and here's a man over here, he's got maybe just a grazing wound and he's losing a little bit of blood, and here's a man over here like this, and here's a woman over here, she's got her ear missing, this and that. Okay, and you're working on this person here, these people all of a sudden turn into terrible casualties and you will lose them. So it comes down to a point, and as crude as it seems, what's better? Losing someone who's going to die anyway, or saving some people that you can.
That's where you have to go through and do your quick triage
Yeah,
and just categorize them 1, 2, 3, or red, green, blue, whatever, black, green.
absolutely. In fact, triage, especially triage in this instance, is a whole new ball game, because even triage says get them someplace. And you can break it down to 3 categories in this, and you still have too many categories. Okay, excuse me. I was on questions. Any other questions?
It's not so much a question, maybe a comment. How important is it in your mind that, say, an individual, one of his partners down, and he's applying first aid to try to stem bleeding? How important it is in your mind that he utilize that injured individual's dressing, first aid equipment on his person rather than grabbing onto his own pack?
Oh, you always use...
I thought it should be
the corpsman carries his own gear. I used to split my gear up also with extra gear, and everyone carried certain items. They all carried dressing, always. All of them carried dressing. Some of them would even carry IVs. I wouldn't give an IV solution to a radio man because they usually shot him. I wouldn't try not to give IV solutions to, say, a point man, because he's probably going to get shot if you get to that type of deal. And myself even, we carried an outfit called a Unit 1, and I'll show you that later. It's a medical bag that goes right on the front of your combat gear. You do your best not to look like you're a medical man, because you take out the medical man and either the patrol's over with or any other wounded, they're all over with. So you do your best not to look too medical. That's why any extra gear you have, which you should carry extra gear, is split up amongst your people. And you always use that person's first aid gear and his bullets and his gun. And if he's got food, take his food too. Leave him his clothes. He might get cold. And because the man that's severely injured, he doesn't need those things. This is, it was an unwritten rule, or maybe somebody wrote it down, I don't know, that if someone was wounded, we got their stuff. I was shipped out 2 or 3 times, 3 times to different aid stations and in a couple of different countries to treat things that had happened to me. And then I'd get back and I had to start all over again, getting pictures and money and everything else. And this was, I didn't mind, that's just the way it is. If someone is injured in a situation, they don't need what's on them. You don't leave them defenseless, but you're not going to leave them behind anyhow. You're going to be if you transport out, if you move out, you're going to be taking them with you. And if they're mean enough, they can always get it back. But you use their medical gear. Yeah, you use their clothes.
One thing that we did in our group was everybody had their individual immediate med kit, which included small, medium, triangular, a couple 4x4s, some 2x2s, and then some gauze and wrap. And the unwritten rule was that if you sustain a wound that is not life-threatening or major that you can still be in combat with, you would secure your wound, if possible, yourself, leave the corpsman open for their important wounds. And you can always get with the corpsman later and make sure everything's okay, or somebody else who has collateral training, make sure everything's okay.
Right.
And I would suggest that for everybody.
Oh, yes, absolutely.
You do have your own little immediate care kit. They have like small, medium, 4x4s, 2x2s, Band-Aids, whatever. But keep it simple and keep it in the same place on every person.
Yeah.
So that when you go to help somebody, you know exactly where it's at every single time. And keep them, like I said, collateral, all the same. Except for, like, if the person's diabetic, have a small diabetic kit. If they have potential problems with bee stings, something like that, keep an anaphylactic shock kit there.
Good point. Your medical gear should be standardized so that anyone picking it up will know what's in it. If you have extra in there, all the better. But at least you should have some standard bandages and medication. just for instance, even in natural healing, if I was to pick up a bag and it had different leaves and herbs and spices and things like this in it, I would be lost because I do not know the intricacies of herbal medicine. I just don't. But herbal medicine does not apply to combat medicine in the down and dirty part of the situation. Your aid bag should be standardized. Your men should be carrying standard gear. They should treat themselves if they possibly can, always. Corpsmen always treated themselves, and who are we going to go to, a Marine? It just doesn't work like that.
You squids are all the same.
I know that, but squids are like that. When I got shot, they had to get directions off of me, and I'm laying there. It's like the end of the world for me. Well, how do you do this, and how do you do that, and where's this, and where's that? And I'm giving them directions. I can't even open my eyes, and finally I was going into shock, starting to go into shock. And it was a kind of a bad situation. You don't want to give morphine if you want someone to remain conscious or fairly coherent. And then again, if you don't give them morphine and you wait and they start going into shock and you give them morphine, then that'll hasten the shock and it'll kill them. And the man's worried, well, what do I do now? Tie it tight and all of this. And then he says, finally I said, I think you better get the morphine out. And he says, okay, where is it? And I said, it's in the cigarette package. And he says, oh, that's where you keep it. Someone's been through my medical gear before, huh? And they couldn't find it. Anyway, that is important of combat medicine, is that the more people train, the less attrition that you have, and the safer that you feel, and the more aggressive you can be. And like my friend here he and I were talking about, and the way he was trained, and we're talking about Marine Corps training, is that your job in the field, in a field situation, is not to look out for yourself, but to look out for someone else. And if you look out for someone else, always, they are more important than you are. You do not leave wounded. You do your best not to even leave dead people. They are far more important than you ever were. That means someone's thinking about you like that. And it's not a selfish, self-centered way of thinking if you're thinking about someone else. And this is so ingrained in people that in a combat situation where a man rolls on top of a grenade and soaks it up, if he lives through it, or if you ask him, why did you do that? He's not going to say, because I thought it was a good idea at the time. He didn't even know why, but it's in his brain. And he knows that. I'll explain to what it took me 20 years to figure this one out, is that men in battle are not there to wave the flag. This is not some sort of heroic, let's charge into battle, banner streaming, and take on the evil empire. We're there to fight alongside our buds. And that's what we're there for. And to take care of them, and they'll take care of us, and to die for them, if need be, and them to die for us. And it took me 20 years to understand why men are drawn, that have been in combat before, are drawn back to it as mercenaries, as security, things like this, is because this is the greatest love. So you have a man that has a wound. Right here. When you do any type of, you just have a few seconds anyway, or a few minutes anyway. You don't take and start from this side and walk the germs into the wound. This is not a good idea. All you're going to do is infect it, because this doesn't kill, instantly on contact when it hits germs. You go around the wound and you work your way out. And that's just about as good as you're going to be able to do, in a situation like this. You can irrigate the wound if you have time, and you use a normal saline solution. You can use peroxide, a very low percentage peroxide. If you put a lot of folks have a lot of faith in 35% peroxide, but you still have to cut it, because if you squirt 35% peroxide in someone's wound, they make rocket fuel out of peroxide, so it's not a good idea to do that. Okay, pressure dressings. Anyone? Why don't you open that up and pass it around so you have some hands on here. This is a type of pressure dressing as well as a field dressing. It's just a combat, it's a combat medicine dressing that you'll be using most of the time. And you have a cut here. The reason you're using this is because most likely you're going to have to apply pressure to the wound to keep it from bleeding. Now, what a bandage does, it covers the wound, protects it, it helps to close it, and it allows the blood to clot. And it also keeps, it reduces the patient's pain, etc. And remember, you don't have a whole bunch of time. And it doesn't take a rocket scientist to tie on a pressure dressing. Now, there are some problems that you can run into by using one of these bandages. You can get it, I won't do it to you, you can get it way too tight. And if you get it too tight, it's not good for the wound. You're still going to have swelling in your wound. The wound is going to be swelling all the time, and you're still going to have to check the stressing. You want to stop bleeding, so you will have to apply pressure to get it to stop bleeding. But as it swells, then you're going to have problems with circulation. You can check circulation by mashing your thumbnail onto his fingernail. And it's called pinking. And if it doesn't change color, then, or if your fingernails are cyanotic, your fingernails are a very good indicator of what your circulation is like, and also the temperature of your hand, as opposed to his other hand. Anytime you check the body, by the way, you check the good part and the bad part, and that gives you an indication of what you're running into. You don't have to worry about nerve damage, things like this. There's nothing you can do about it anyway. But the circulation, the reason you check for circulation, temperature, is to know if you have the bandage too tight. Your bandage cannot be a tourniquet. You don't want it to turn into a tourniquet and end up causing a man's arm to go gangrene. If he goes gangrene, he loses his arm. There's nothing we can really do about things like that in the field. Long-term medicine, natural medicine, those we can use to treat that, but it doesn't take very long to destroy an arm if you pick the wrong procedure, or if you tie something too tight. That's one of the problems we're going to get in on tourniquets, but that's a little problem. Now, when you come to a thing called a square knot, I'm not always that up on what a square knot is. And in the field, you're sitting there trying to think, well, I do it. Did I loop over this way that time? Or did I loop over this way that time? You tie a granny if you can tie nothing else. You want the knot to be secured and not come untied, because you're not going to be taking this dressing off anyway. You may have to loosen it later on, but if that's the case, you have 6 to 7 feet of tails here, and you can cut this tail and retie it if you want to loosen it up. In fact, that's the only thing I ever did. I didn't try to untie any bandage. Even a square knot, when it gets wet, you can't untie it. You go ahead and tie your bandage up and get it tight, and then on these particular tails, you can split them like this and secure the tail part of it like this, with another knot. Yeah, let's get right here. I'm sure this is right here. Maybe it's a square. I don't know. Maybe I got a lecture this time, huh? In minor surgery, with an instrument tie, it's real easy to get lucky and get a square knot every time. Now, here's something that I do just for special insurance about the knot, is if you ever tied a bow onto a present and you say, would you put your finger and hold this? Because when you tie the first knot, it slips out. Well, if you take the first part of your granny, okay, that's how you start tying it. But if you just go one more loop, it doesn't slip. This is the beginning of what you might call a surgeon's knot. And then, if you're tying with instruments, you can get it down to a square knot. It's a weird reading. Hey, that is a square knot. I got lucky. Your tails, you want to tuck these out of the way, tape them up, pin them up, whatever you can. You don't want to cut them off completely right up to the knot, because the knot may loosen and all of a sudden you have a bandage falling off. But if you have these Irish pins here, then if the man has to go someplace and it catches on a vine or a bush, it's going to hurt him real bad. He's going to be mad at you. So you want to try to keep these tucked out of the way as well as possible. Now, you never cover a bandage unless, of course, it's some sort of color that sort of sticks out like a bright light. If the man is unconscious, you definitely don't cover a bandage, because the people that receive him next have to know he has a bandage on. When I was working in Great Lakes, we received patients from Vietnam. And I have actually taken field bandages off of patients, and they had been there for 2 or 3 weeks because no one knew that they were there. And what I found under them made me kind of ill, and I can take a lot of things. I can wade through blood and guts all day long. It's not real pleasant, but it doesn't make me sick. And that was one of the few times that I told the patient, would you excuse me for a second? And then went someplace and emptied my stomach. Because a wound that's 2 or 3 weeks old is in terrible condition and has maggots in it and a bunch of other things. So you want to cover, you do not want to cover a bandage, ever. Get your arm off. All right. Don't go away yet. We're just getting started on this one. I'm using a small bandage here, right now, and it's easier to work with. I'll get to a larger bandage here in a few minutes. Your bandage can be used for in a hand wound in the palm, or smashing it in here, and like I say, you don't have to be extremely neat about this. No one's going to check your work. You're not going to get critiqued, and you can wad up. But I would take a turnaround at first, like this, and then you can wad your hand up, and you might even have some broken bones. That's the way it goes on that one. And then you can secure the bandage. Tie it in a knot. There's no special technique for bandaging these type of dressings in every type of body, because everyone's a different size, every wound's different. There is no book someplace that says no, this bandage has to run long end up. It might, and this one has to run long end sideways. That's where your thinking comes in. If you can't think about it, if you don't have the imagination to be handling things like this, well, I can't even put it like that, because I guarantee you, when you have a friend down that's hurting, your imagination takes over, and you'll be able to do it. It's nothing magical about it. There's no mysteries involved here. You have to stop the bleeding. There's nothing mysterious about that. If a man loses too much blood, he's dead. If you can keep him from losing too much blood, at least he will live for a while longer. Most likely for a long while longer. 20 years from now, he'd be sitting on the front porch with you, and you guys would be bragging about something. If you do not stop the bleeding, he's not going to be sitting on the front porch with you. And you're going to be hurt for the rest of your life up here because you didn't think right. Now, I'm teaching you things you should be learning, but thinking is not learning. A dog can learn. Dogs can't think. When you're in the field and you're working on someone, you shake like a leaf, you're scared, through the whole mess. Most of this comes from adrenaline. And yes, there's a lot of fear there, but most of it comes from adrenaline. And it's not necessarily you think you're going to make a mistake. It comes pretty much natural when you're working on another human of what to do. The body's very self-explanatory. Bleeding, the body's saying, close me up. But never mistake that the shaking and what have you, if someone's working on you, is because they don't know what they're doing. Because, which is another point, you must always, even if you don't know what you're doing, but you should never, ever let the patient doubt that you don't know exactly what you're doing, because that will kill them just as dead as a bullet. Every time. They have to have utmost confidence in you. They have to think that you will turn them in to Robert Redford if they have a face wound. They have to count on you. And the same goes for childbirth, or same goes for any of this. That was one of the first classes that we gave, was on childbirth, because if you can't take care of your own community, you have no business going on to the next step. All right. When you get down to leg wounds, you have problems with things called boots, and you have to make a decision. Well, if you have a wound down here and it's a flesh wound, no bones broken, the missile went through your leg and followed some soft tissue and went back out the other side, took a McDonald quarter pounder with it, then you can patch the wound, but you don't necessarily have to take the man's boot off, because you can put your feet down if you have to, even when you're wounded, and it's not a broken bone. I've seen really amazing things, even from myself, when I was, injured. So you don't want to be throwing a man's clothes away. He might come visit you later on looking for his clothes. But boots are constrictive. They're up to here. You have a wound here. You're going to have swelling, maybe up to the groin, but you're going to have swelling like this. You can take a bullet or a flying hunk of bark or a rock or something, piece of metal off of something that exploded. It makes no difference. And it goes through here and just hits the tissue. The patient's leg will eventually swell up like this. And the wounds will open up and everything will be nice and gaping. Now, if it's swollen up like this, right here, and you have a boot on that you haven't unlaced, then you have a big constriction right down here, and he has no circulation. And if he has no circulation, he might get over his bullet wound in the leg, but he'll lose his toes. If he's lucky, most likely he'll lose his foot. So you loosen up the shoes and or socks, lousing in the down here. You can have this demonstrated to yourself just by windbreakers that have the elastic cuffs on them. I don't know if anyone ever worn these things long enough, but you notice that the wrist swells up behind the windbreaker, or sometimes up in here. It's because you have a restriction. Now, if you have a restriction from major damage up in here, and you don't get circulation to your foot, you will have two injuries to deal with. This one right here you can deal with. All right, that's what you're doing. This one right here, how do you deal with something that turns black? It's going to fall off. And the patient's going to die. If you're fortunate, the patient will die, and you don't have to have several months of suffering and then he dies. This is not a good situation to get in where something you do causes gangrene or something you don't do causes gangrene. You're going to have enough problems with that anyway. That's the last thing that you want is for you to make a patient worse. And bear in mind that you will go to your grave thinking that you could have done more. You will go to your grave wondering, well, if I hadn't done this, would have happened? And I'm telling you, you'll be right, because there's always something else you can do. There's always things you're going to do wrong, and it will eat you alive. But that's the price of liberty, is living with your mistakes long enough to get your job done. Because medicine, after all, is a practice, like I said earlier, and it is not a science. It never has been, never will be that I know of. You can't. There's no such thing as a book that big. All right. Anyway, loosen the boots. Any other kind of constriction down in here, loosen it as best you can. When you put your bandage on, if you have a chance, do your sterile technique where you clean the wound. Now, unlike the arm up here where I just covered up a cut, we'll say this is a bullet wound. You have an entrance wound. And there might be a fairly large wound there. I doubt it, but it might be a fairly large wound. Most likely it would be a hole. You really don't have to worry about the one on the front that much unless it's huge. But when a bullet enters, like I say, it goes in small, comes out big. Your wound is going to be on this side. Unless, of course, he was fired at from behind, then the wound's going to be on this side, the one that you have to take care of. Now, I've heard different scenarios, and I've even given examples. Yes, you can use Kotex, you can use Tampax. Those are not pressure dressings, though. They will stop the bleeding of maybe a 22 entrance wound, and that's just about it. And some of these wounds, if you were to try to use Kotex or Tampax on it, you would have to pound them in there to get the bleeding to stop. You have to cover with either a battle dressing or a pressure dressing of some sort. Now, what's nice about these battle dressings, as opposed to a pressure dressing, is it takes care of all these steps in one. You can, like I said, you can even use it on a small cut where you have to use a Band-Aid. If you don't have a Band-Aid, then put one on here. All right, we'll say that the exit wound, or the larger wound, the worst one, is on this side. Now, you bandage the wound the same way you did with the arm here. However, you do have another wound on the other side. If your tails will cover if these tails right here will cover the wound, you can, and the wound is, say, just an entrance wound on the other side, then you can take small, these 4x4s and put it on this side here, and then you have one pressure dressing, or one, you have a pressure dressing, one combat dressing type set up here that's covering both wounds at once. If you have a situation or a wound where you have large wounds on both sides, then you're going to have to do some thinking about it, because even a medium-sized dressing like this here will not cover entrance and exit wounds. It's just not made to. And when you start using a large one, which you don't have that much of anyway, it's still not going to cover it. You know, this only covers half one right here. And a large one, maybe twice the size of this one, and you still you have gaps in it on the other side. So you have to use two dressings. You can put the first dressing on, and you can actually either put the other dressing on this side here and use this tail. You don't even have to take the tails off the other one. And use this tail right here to secure the other dressing. Or if it's at an angle like this and you have a wound up here and a wound down here, you can put one dressing here and one dressing up here. Now also when you have that much damage, you are going to have to check these bandages more often, because unlike an incision wound, you'll have much more swelling when you have damage from bullets or missiles or anything along those lines. Let's see here. Dumpy, you'll live. When you elevate when you have a wound to a lower extremity like this, and you elevate it, if you have a broken leg, then it has to be splinted before you can elevate it. Let's say you don't have any fractures, and you elevate this. You can put something under here, but actually you want to try to flex the knee a little bit if you can, because I don't know if you ever propped your legs up before and left them. It hurts, and you can actually do damage and have someone limping around for quite a while just from the nerve damage and the joint damage that you've done by making him lay here for 12 hours with his leg like this. That's another way that you'd want to keep the swelling down is by elevation, right here. In fact, if you can get him on a board, you can put him in a position, I think it's called the Trendelenburg position, where the feet are up. You can use that position for a lot of other procedures, everything from moving the intestines up this way and all the other internal organs. Use it for shock, use it for, it's just I think it was invented way back when, or discovered. When you have to deal with a wound to the intestines, you enter into an area where, depending on the damage, and most of the time the damage is pretty bad and pretty grim, you enter into an area where your patient's going to die. And you may get fortunate and maybe for some reason, like you have secondary care, or you take them to a hospital, that you can actually get there, or there's other types of medicines and heroics and life-saving measures that you can get them someplace where they can be helped. Then that's a different story. You still use the same procedures. If I was to come upon Randy in a very to-the-wire situation, a very grim, down-dirty, we're in big trouble situation, and I looked down and he had some sort of blast wound, missile wound where a bullet went through him, and or maybe an incision crossed here, maybe a knife got him, maybe his own ammunition blew up. It makes no difference. Man has a gut wound, and his intestines are out of the body, partially. If they're out too far, he's probably going to be dead anyway, because it jerks everything loose. And by the way, there's no nice way I can put these things. Anyway, he has some intestines out like this. Now we get down to a point of, do I want to treat him or not? And here is a determination in my own mind, in any kind of situation of, do I treat him, say, in category 2 as opposed to category 3? I check his drawers to see if he defecated in his pants. If he didn't defecate in his pants, then I know my nose is not going to get confused, and I smell of his wound. If I smell bowel, feces, caca, whatever you want to call it, then he's had his intestines penetrated. And if he's had his intestines penetrated, then he goes into a category 3, or the last category there is in combat medicine, which means they have no hope, and they're the last people you work on. And after you treat everybody else and take care of who you can actually, you can save or have a pretty good idea, then you go back to this one and you look for someone, maybe you just made a mistake, or maybe you can do something further for him. If you don't check his britches, then, and you smell of the wound, and you smell bowel, caca, you don't know where it came from. You might be wrong anyway, but if he hasn't fouled his britches, then chances are, good chance, that the bowel that you smell will be his, and then he's in extremely big trouble. Now, how do you treat a gut wound? When you have a wound to the abdomen and you have intestines here, they always say, do this till you can get them somewhere. Okay, we don't have anywhere to go. You have a clean wound. There is no bowel loose inside the wound. You hope. But you do have the intestines there. You want to try to get him to a place of medium safety, but it's still battlefield medicine. But just to even get him there, you have to do something with this very unusual situation of intestines hanging out of the body. They're supposed to be on the inside, not on the outside, ever. So, you can surround the wound like this. You don't want to put any pressure on the bowel. Surround the wound with, why don't you roll to your left just a little. I know you're wounded, but yeah, a little bit more. In this area right here, you have your intestines hanging out. You surround the edges of the wound as close as you can to help control the bleeding, like so, like this. Now, you can't put a bandage over the wound, over the bowels even. In fact, if there is no major damage to the bowel, or even minor damage to the bowels themselves, and you can get them back into the cavity, it's best to do that, because you don't want something this delicate getting caught on things. But when you do put them back inside, you can kink a bowel and cause problems later on. But like I say, your first obligation is to save the man's life right then. Now, in World War II, they started out by using, absolutely use wet dressings. Okay? Now, I agree with that. You should. But they went one point further, which got them in trouble. They went to the point of, okay, if you don't have any water, you can urinate on the dressing and put it on the man. And then they had people with problems with syphilis after that, because the guy that urinated on the dressing or urinated on the wound passed syphilis or gonorrhea onto him, and it's systemic now. And penicillin was just first starting to come in, but not only does the man have a wounded intestine, he's got some other diseases, whatever else this crazy sailor gave to him, or another Marine. But anyway, you should have water on hand to put on a dressing. The reason you do your utmost not to put on a dry dressing is that it will adhere to the wound. And when you take it off, you can do a lot of damage to the colon. And I imagine, even though I've never run up against that, because I made sure I had wet dressings. In fact, saline is the best, but a saline solution, I'm sorry, that's salty water, like the body, is the best thing to wet a dressing down. But urine is not one of the things you put on a wound. And my own personal feeling on this, and I understand that we have a lot of medical, especially natural medical information out there that says, well, you know, urine contains a lot of antibiotics, natural healing properties. My own feeling, if anyone urinates on my wound or the wound of one of my people, I want their address, because I will look them up even if I live. That is, if you don't have water, then go ahead and patch it dry. But don't be putting something from your exhaust system on a wound, because urine carries poisons out of the body, for one thing. And granted, it may be sterile under a lot of circumstances, but who knows what circumstance it is? Who knows what we've been infected with out in the field? Who knows who has AIDS in this room, or is HIV positive? I don't know. They don't carry signs. They might not even know for years. Syphilis can go dormant in your body for 20 years. You don't even know, unless you've had a VDRL or a blood test. Gonorrhea is kind of self-explanatory, but even that can go into a smoldering infection in the pelvis, and you don't know. You haven't the faintest idea what kind of diseases are floating around inside the human body. So you do have to be careful on this. So you want to get this man first aid, get his intestines out of the way. You tuck him into the body as best as you can. If he has, say there is a bowel smell, but you can actually see a wound right there sticking out. It's on the intestine, it's outside the body. You don't want to be putting dirt back in this man's wound, because that may be the only break in the intestine. If it is the only break in the intestine, you just killed him if you took fecal material and put it into his body cavity, because then you have a thing called peritonitis that sets in. It's a massive infection, and you're dead. And there's nothing you can do about it in the field, unless, of course, you have access to truckloads of antibiotics, or maybe a diving bell somewhere, a decompression chamber that you can pump pure oxygen to their system under a low pressure to where they're supersaturated with oxygen, and then they have a chance at it. Because even in modern medicine, if you have a ruptured appendix and it's right in the hospital, they're there for a couple of weeks. I mean, if they're lucky, it's only a couple of weeks. And it still kills people. Medicine is not the wonderful thing everyone thinks it is. You take a large or a medium dressing, depends on the size of the wound, and you tie it around the body as best you can. He may have other injuries, may have a back injury. You may have to use tape to secure this, because if you have a gut wound, you may have the missile go all the way through, and that will hit his spinal column. And there's other symptoms to check for in that, and I'll go into that in a minute too. But right now you're concerned with this gut wound. You have the time. You think he's going to live. So you put on a dressing. You have to be careful about spinning a patient, looking for other things that are wrong with him, because most likely there is, and most likely you'll make it even worse when you spin him around. Tie your tails, square knots, granny knots, bows is not a good idea. But secure the tails, get them out of the way, leave it open, and you have to keep on wetting the dressing if it's wet to begin with. Now, some dressings have a small layer of plastic on the inside. There we go. This is actually supposed to be an improvement, and in a way it is. These are a battle dressing, the new kind. But underneath this, there's a small sheet of plastic. That way you use less bandages, because when a bandage leaks through with blood, you don't take it off and put another one on. You just put another bandage right on top of it. If you take it off, you break the blood clot, and he's in trouble. All right, now these right here have a plastic coating on them. And the larger ones will have the same thing. It makes sense that you can't pour water through plastic. So you'll have a problem with trying to keep your dressing wet. If you pour it in from this side over here, then you're running dirt and skin and dead, what have you, inside the body cavity. That's not a good deal either. You can take a pair of scissors and take the plastic out of bandages and just have one or two strictly for gut wounds. If you have a chance to use sterile technique, clean around the edge of the wound. This is an intestine wound, though. and especially if it's been breached, then sterile technique is not that, it's less than important. You're wasting your time, because you have one of the most unsterile things in the world, just a few microns, millimeters, silly things, right away from the inner lining of your body. You bypass all of your major filters, because your body is one big protection device to keep infections and matter, things like this, from reaching the areas that can't protect themselves. And you have a major breach here. So sterile technique is not a big concern unless you know for sure that it hasn't been cut, that the intestine has been breached. When you have a head wound, you can't put a pressure dressing on it if the skull has been breached. If you put a pressure dressing on it, then the brain damage that's already been done will be infinitely worse. Instead of someone maybe having a lisp for the rest of their life, they will be stacking BBs for the rest of their life, if they're fortunate. So how would you stop a bleeding up in the head when you have massive bleeding and you actually have a penetration of the cranium? This is something that was worked out, fortunately, not by me, but by the foreman that came before me. What they do is you make what is called, now we're talking about a penetrating wound. Lots of bleeding, brain matter sticking out, hunks of bone showing. You got chunks of bone sticking up like this, like this. Don't be reaching there, pulling out the bones. That's actually secondary care. I mean, if one's getting ready to fall out, that's all right. Don't be cutting things away. Don't be trying to debride it right then. If he's fortunate, his scalp will still be, some of it be there that they can use to close over this. But you have an open wound, and it's bloody, bleeding more. And not only that, it is being stimulated by all of its environment around it, so you have to cover it up. What they do is make a donut and put over the wound first. Okay, here's a penetration wound. Say there's a BB bullet, rock, whatever is in this man's skull down inside here. You'll worry about that later. But you have an open wound. This is open to the, right here's brain. You can see the brain sticking out. You can see the veins in it. You can see them pulsing. You can't put a pressure dressing on it because it takes these little sharp pieces of bone and mashes them down in there further. Not only that, it puts pressure on this brain matter that's trying to expand because it's swelling too. It's not a shot to the brain, which usually kills a human. It's the attendant complications that go on with it. The brain swells up, it cuts off blood circulation, the brain dies. You have convulsions, grand mal seizures, people talking to things that are not even there. They're crazy as a Betsy bug. You can't even give them medications. You give someone with a brain injury, say some sort of barbiturate or even morphine, you've got yourself a real strange fellow on your hand. They talk to the animals, and there's no animals there. However, there is something that you can do. You put around the wound, say this is the wound right here, and you make a donut, a bandage that looks like a donut. You can use cravats, you can take bandages, tear them apart where you have you take your this bandage right here, the triangular bandage, and you roll the cotton, rags, whatever, up inside of it. preferably something sterile. And then you take the donut, we'll just say this one here, and you put it over the wound like this. Now this takes time, doing stuff like this. You put it over the wound, and then you put your dressing on top of it. And you can secure this with whatever your imagination comes up with, things called Barton bandages or Barton way of bandaging something. The pressure dressing has tails on it. You know, the battle dressing has tails on it. And you have to be careful that you don't cut off his air supply, that you don't cut off his blood supply, that he can still get his mouth open. He's going to be throwing up. And if you have his mouth closed, the vomit has no place to go except into the lungs. That's one of the primary things about just keeping an airway open is not necessarily that you have swelling down here. A man is not made to breathe vomit, or a woman is not made to breathe vomit. You have to take this into account. Even when you have broken jaws, you have to pull a tooth out so they can eat sometimes and so they can vomit sometimes. Although usually you carry a pair of pliers to cut the wires so they can open their mouth and throw up. Anyway, you apply your pressure dressing over the donut. Even then, you don't push that hard. You're not going to have great amounts of blood loss from up in the head unless you've had the larger vessels have been severed, penetrated, damaged. In that case, the patient is probably going to die anyway. But he's alive. He's okay. He's even coherent. You press it. You bandage it as best as possible, and he can actually almost be walking wounded. Normally, you wouldn't even think about something like that, but he has a few hours before, or a few minutes at least anyway, but you have time before the brain becomes so disabled that it'll down a human being. And the more people that you can get out of the area, the better off you are. And you don't have to take up stretcher space or, say wounds like this, any wounds like that, arm wounds. It takes manpower, it takes stretcher space, it takes time. It's dangerous to transport people even out of the area. And even a head wound is as exotic as that kind of wound is, because most people look at a head wound and it's like magic. Oh, what do we do about this? I've never even seen anything like this. This is terrible. But if you bandage it with a donut, that is a combat dressing. Hopefully we have some questions and comments on this part of it here. Or maybe not. For the EMTs in here, is this the way you would do a dressing in a situation where you could not transport? Has anyone here ever treated head wounds?
When you do the dressing over it, how do you know if it's too much or too little pressure?
Well, the pressure, you're not going to be applying. The pressure on this bandage up here is actually to seal the edges of the donut. It's not to seal in. Yes, it's not to seal in the juices. It's to seal the edges of the donut. And then the dressing itself is to cover the area and protect it further, because you really can't put pressure on an open brain. That's something else you have to watch for. If that fills up with blood and fluid, that can cause pressure. Because the brain goes berserko after it's been shot, after you've had a head wound. And it tells the body to do all kinds of things that the body has no business doing. I saw a film one time, not a film, I saw some newscast. It said so-and-so shot so-and-so in the head and it killed him instantly. Well, I saw a picture of a man who'd been shot in the head, and his face was swollen up, all of this stuff. He didn't die instantly. Because you get a shot to the brain, you're not dead instantly. And brain damage, where you have massive amounts of brain tissue missing, is not the end of the world as far as injuries go. I have seen men and treated men where they're walking around years later, and this is a little exaggerated, well, not really. Through his nose, let's bring here like this. And he's missing that much of his head right straight back. You could set a can of pop-up on it. And he's not dead. He's walking around. He might have trouble, depending on what side of the brain it's on, with certain functions, but he will survive. They have to do skin grafts. If they're fortunate, they might be able to rebuild a skull, which is what they do, put plates in. If it's too much damage, then the guy's going to look kind of strange for the rest of his life. But a brain damage, a brain injury, while it's usually fatal, life-threatening, it is not the end of the world. They can recover from things like that. Sucking chest wounds are probably never going to be like what you think they are. You figure, okay, the bullet goes in here, and here's little bits of blood and air, and it's going, making a sucking noise, maybe even like someone getting down to the last of their milkshake. So you have this very distinctive noise that is, it's a sucking chest wound, and you have symptoms like this guy looks like a fish out of water, having problems breathing, and we'll just say you're real fortunate, and all you have is just an entrance wound. But that's not real fortunate because something's inside of his body, but that's all you have to deal with right now. Any kind of plastic, credit card, gum wrappers, tin foil, anything that is airtight, you can put over a wound, and you can secure it with tape, or you can actually secure it with a bandage. However, I prefer to use tape because you don't want it slipping down. You might, if you have a bandage over the top of a piece of plastic material right here, and then you have a bandage over the top of it, a larger one, and it slips away from the wound, then you have a sucking chest wound again. But if this is taped in place right here, then it's usually not going to go into place. You go ahead and bandage it, and you always, well, it's one of those times where I used the wrong word. Most of the time, you lay him on his wounded side. And the reason you lay a man on his wounded side, he would, go ahead and lay down on his table and I'll show you what I'm talking about. His sucking chest wound, now roll up on your left side. Okay, the sucking chest wound is here. Your heart will say, oh, let's get the wound off of there because that hurts like the blazes. Well, so what? It's pain. It's not dead. If he's feeling pain, he's not dead. So you lay him on this side right here. Don't worry about the pain right now. You can't even give him morphine because that slows down the breathing. And you bandage this wound right here, and you put you put the plastic or whatever on this, bandage it, lay him on this side because you'll have air that's gotten into the lung, and later on you're going to have bleeding and swelling. And what happens is this lung will fill up with fluid, and if the man is laying on his back or he's laying on the other side so you can spare him a little discomfort, the lung that's filling out will crowd out the other lung and he will die. He will not be able to breathe. That's all she wrote. I asked one of the EMTs, well, what if you had, and this is a good question, what if you had a double sucking chest wound? And the answer is, it just depends, because I'm not real sure on this one. I've had people tell me everything from hang them upside down or thumb their eyes closed. And it depends on what kind of exit wounds you have. There may not be an exit wound on the other one. It depends on what kind of bleeding you have. If it is primary right then care, then you stop the sucking chest wound aspect of it and go on to someone else. When you come back, if they're not having problems, if it ain't broke, don't fix it. But if they're having major problems and they're still alive, then there are surgical procedures that you can get into if you have the time, resources, etc. Now, go ahead and sit back up. If you have an entrance wound in the chest and it didn't hit the heart and it didn't hit the aorta and it didn't hit any other vital organs, which you're probably going to die if it does, especially when it has to do with the heart. And most of the time, bullets go in and they come out the other side. Now, sometimes this will be a sucking chest wound too. Sometimes it won't. Personally, I always treat them like you got two sucking chest wounds here. And however, you've got a big, giant wound on his back like this right here, and you have a lot of damage to it, and you have a lot of bleeding, and if you put a big piece of plastic on this, then you have the blood, and then you cover it with a bandage. The bandage can't absorb the blood, and so the blood runs out the edge of the bandage. It doesn't have time to clot, and you've wasted a bandage for one thing, and a bit of plastic, because the man's probably going to die. If you can find a channel that is actually a sucking chest wound type affair, then you can get it small enough to restrict and stop the sucking aspect of it, where you're taking on air on board the wrong place. Air is supposed to go through your nose and mouth, not through a hole in your body. You bypass all kinds of natural defenses. Of course, that's the least of your problems. Your problem right now is staying alive. If you're fortunate enough, which you probably won't be, because this is combat medicine, and things just don't happen like that, you can stop up this hole, right? Now we're getting into the realm of Easter Bunny and Santa Claus, because that's just probably not going to happen. If you can find something to cover this entire wound that will seal it, we're kind of out of the Easter Bunny stage here, but you still have problems with that. Best guess scenario is you take something like saran wrap, not saran wrap, but no, not tinfoil. Wax paper. Yeah, not wax, not even wax paper. It's microwave, plastic, saran wrap. Yeah, saran wrap, and contour it to the shape of the wound, and then put your dressing on. If your wound's this big here, put your dressing on where it covers way past the wound here. Don't have to use an extra large one, because this will be where your clotting factor and all of this comes in right here. Sucking chest wounds, but usually what they show you is one in the front and one in the back. Okay, we'll just put a bandage on it. The damage that's done to a body in the field is never anything like it is in a book. And you probably never even see the same wound again twice. Sometimes you're lucky, and I know how to do that. It takes me half the time now. But there are other ways that you can do it, but you have to play it by ear the entire time, and you have to be thinking on your feet. You can take and plug a sucking chest wound with bubble gum if you have to. I don't recommend that, but you can do it. You can do it with the tongue out of your shoe. You can do it with a baggie, a sandwich bag. There's I really don't recommend the bubble gum, but it is airtight. And for an entrance wound, you can do that. Of course, however, you do have problems with someone sucking bubble gum into their lung, but you have to use your imagination to feel. Not that you're probably not going to see any bubble gum anyway, but there are many things that you can cover up a sucking chest wound, especially on the front, on the entrance wound. And there are many things that you can cover up one of these wounds with. And you've got 100 in your pack. You've got dozens of different things. The cover off of the bandage is airtight. It better be. Or else you've been carrying around something real dirty for a long time. Tourniquets are applied to a wound that you cannot stop the bleeding on with pressure dressing. But tourniquets are always applied, and then you get the patient to a different care facility where they can take the tourniquet off and get blood supply back to whatever is below the tourniquet. May I use you for a second? There are some do's and don'ts on tourniquets. First, I'll go through those. If you have someone that has their hand shot off here, it's very rare that you should have to apply tourniquet above the wound. Because limbs that are blown off, shot off, crushed off in this area here seal themselves relatively well. And if you apply tourniquet, yes, there's going to be a lot of bleeding, a lot of pain, and it's going to look like the end of the world, and it may well be. But from right here, you know, on these joints down, this is almost a rule of thumb in combat medicine. You really don't need to put a tourniquet on. When you get up into here, you have larger veins and arteries that you have to deal with. And now you have to start putting on tourniquet. From, we'll say, here on down, even the knee, but we'll say that the shin, middle of the shin or upper part of the shin on down, that you really have to apply tourniquets. Even when the limb is blown off, because injuries like that do seal the wounds. I know it seems almost silly to even think like that, but a man, I believe one of our congressmen, had his arm shot off, and he made the German pick it up and carry it back to the battalion aid station for him. And I think this was Inouye. He was overseas. I mean, this is not uncommon. Your limbs don't bleed the way you think that they would, because it's not like a giant pipeline opened up. The damage seals the wound, the shock seals the wound, and that is what you will actually take care of itself down here. Now we come to some problems. If you can't get a patient to a hospital or to an aid station, and if you put a tourniquet on and you're not supposed to take it back off until qualified medical help can work on this tourniquet, what do? This is something that everyone should run over in their mind is, what are you going to put the tourniquet on for? If you stop the bleeding and the man's arm falls off and he dies of gangrene, then you're better off bleeding to death. There has to be like a rule of thumb for applying tourniquets. And actually the rule of thumb in my own mind and a lot of people's mind is don't put a tourniquet on unless you do have a primary care facility to go to. I mean, like a battalion aid station, underground facility, an ambulance someplace that you can have a follow-up on how to take the tourniquet off so the man doesn't bleed to death, because once you take it off, he's going to start bleeding. Or that you can actually close up the wound while you have the tourniquet on. And we're talking about major surgery here. Sometimes, if his arm is blown off here, and you have bits of muscle and bone sticking out, the tourniquet is not for the bones and muscle. It's for the veins and the arteries that are also sticking out. Now, if the Romans could fix something like that, and which our earliest indications, this is how they did it, they tied off the veins. If you have a tourniquet on here, and you know you can save this man's life, and you see the problem, his pipeline is exposed, which carries his cooling solution and his feeding solution, everything else, you can tie off that vein, then do it. And then you can take the tourniquet off. Because even a tourniquet that close to the wound, you still have tissue damage here from the lack of blood supply, because you do have a lot of blood going in here. Of course, you'll want to bandage this. You'll want to protect as best as possible. Because the only alternative to tourniquets is cauterization. And cauterization means you have to have a fire. You have to have something to transfer the heat from the fire to the body. And you have to have somebody to hold him down, because he's not going to like it. Or you may have to have bubbling tar to put on the wound. And yes, we could very well be reduced to this. It does work. Cauterization is a good resort for infections as well as bleeding problems of this profuse nature. Now, tourniquets should be applied thusly. You use a cravat, or you can use a rope, or you can use your belt. And it should be as flat as possible. That's why a belt is a good thing. You can use a blood pressure cuff. Just pump it up. That stops the blood. That's why you can hear somebody's blood pressure. When it starts, that's when the blood's flowing. When you can't hear it, that's when the blood's not flowing. But the way a tourniquet is put on is you find, we'll say, a place where you can apply a pressure point. See where I got you marked here? Okay. You want to put it as close to the wound as possible. Sometimes this is not feasible because if you can actually get it off again a little bit later, then you can put it up where the pressure point is. If you put it up where the pressure point is, and you can't get the tourniquet off later to get, for instance, you tie up his exposed vein, and you have the tourniquet up here, and the wound is right here, then you've lost this much of an arm that you didn't need to lose. That's better to lose than life, but you've done something that you really don't need to do. All right, but we'll go this route. It works the same whether it's down here or not, but you put something over the pressure point, and you put your bandage around here like so. Now you can, any kind of improvisation that you want to come up with, but a tourniquet is like a Spanish windlass. I'm not sure if you're acquainted with the term, but you put a tourniquet in this open part of the bandage here, and the reason you want it flat so it's not too constricting, so you don't crush the rest of the vessels in the arm, or you don't have nerve damage. However, I really don't care about all of that stuff if the man's going to die, and I don't think he would either. But you put your lever, your stick, a wrench, anything right in here, and this is tied in a knot right here, and you apply your tourniquet just enough to make it quit bleeding, and that's it. Anything tighter than that, you have damage. Anything looser than that, the man bleeds to death, and you wasted your time anyway, and a bandage. And after you get it tied, then you have a tail that you can run around this, and it holds it.
and gentlemen, welcome to part 2 in a series of 5 of Combat Medicine. Our guest speaker and our instructor is Chuck Fenwick from Minnesota. He traveled a long ways to put this together with us. We hope that you'll enjoy it and continue on with it beyond this. Thanks.
Fractures are difficult to diagnose sometimes. Sometimes they're pretty obvious. If a man has 2 elbows, something's broken. If a man has 2 knees, something's broken. If a bone, all right. Here's a man, and he's had a strike to his arm, and he's having problems moving his hand. Everything just really hurts. He's calling all kinds of names, and he's got a giant bump here. But what do you do? Well, let's see. Is this a fracture or is it not? Oh, we can't get the X-ray machine. And you can't always feel a fracture site because I feel things right here and it feels broken. I can feel a break in the bone. I really can. You can feel up your bones and you can feel breaks in the bone, but it isn't. At least I hope not. And it could be a bruise on the bone. That acts like a fracture. So how do you diagnose one? Well, if you don't have X-ray and it's not completely obvious that it's a fracture, then you have to treat it as a fracture. A bruise on the bone should be treated as a fracture anyway until you find out different. You can take the bone, and we'll say that the break is right about here. Right? One indicator, and it's not 100% so, but is you can take any kind of instrument, your finger, and you tap here, and you can tap here, and if both times it hurts right here, that means you have a break right here. Because the break breaks the nerve sheath, sometimes breaks the nerve sheath that's on the bone, and that's where you get your pain. Because your bone, after the bone itself isn't painful that I know of. It's the nerve sheath that surrounds the bone. And if there's a break in that, or if there's a piece of jagged bone touching it, or broken bone touching it, then if you tap here, and you tap here, it's like tapping on a bad tooth. When you tap on all your teeth and you come to one that hurts like crazy, you have a bad tooth. Or you have a fracture in your tooth. All right, now, a rule of thumb, and of course it depends on a situation, but we'll just say this is 99% of the time. If you have a fracture right here, we'll just say right here, if you have fracture, both of these bones are fractured, even one of these bones are fractured, you always splint above and below the break, the joint. Because if you have a fracture here and you only put the cast up to right here, or the splint up to right here, when this man moves, these bones pivot. I mean, this is a flexible machine you've got, and it's made to rotate, all of this, and you need to cast above and below. You also, it's best to, anytime you cast or splint, to have it in a more natural position, which is with an elbow bent. Because having it straight like this, that's okay if you're going to go to the hospital, but having it like this for 6 months, even having it like this for 6 months, or 3 months, or 6 weeks, can damage the patient just from having one unnatural position, because straight is not natural, ever. It's not even natural for your legs. If you stand up long enough in a straight position, you're going to pass out. That's why when you stand, I don't know if any of you ever taught that, you should flex your knees on occasion. Depending on the fracture that you have up in here, but we'll just say if it doesn't cause too much pain, when you talk about a natural position and it's more or less a permanent splint that's going to have to stay on for a while, then you need to splint in a position like this. There are different types of fractures that require different, some of the strangest looking casts you've ever seen. On the fractured humerus, you know, they'll have a body cast all the way up in here. They'll have a cast from on both sides. You look like you're wearing armor all the way down to your waist, sometimes all the way down to your knee, and then you have a big pole sticking up here to hold in this position, and this is what you look like, you know, in a cast. Just for a broken bone up here. Sometimes you're in what is called a hanging cast, and you can even do this with a splint, where if this is shattered from here, up in here, then you splint or cast the arm in this position and make sure this is nice and heavy, and you put a support around the neck to hold this part of the arm where it pulls straight down, and your arm acts as a splint, and it pulls the fracture straight or keeps the traction on it so it can heal more or less naturally. You can't carry around splints in your Unit 1. You've got one piece of wire up there to use for a splint. And if you have a situation where you're receiving a lot of wounded, your one wire splint will disappear in just a few seconds and it's all gone. And it might even be for something else, you don't know. But any fracture has to be splinted. And as far as what you use for a splint, for combat medicine, right then, is whatever you can think of to keep it from moving. You stand right here. This may look dumb, but this is a splint. This is an excellent splint for the leg, if that's all you have. This is a splint. Anything that's stiff. Magazines make great splints. And it's almost like wearing a cast. If a man has a fractured wrist or even an arm here, you can put a cast on. They look like a magazine, but that's a cast. You wrap your bandage around it. He can't really bend it unless he really tries to, and if he really tries to, that's his problem. You want to get him out of there, and then this is the splint, and this is how you immobilize it. All right, with a sling. This magazines, of course, we can't carry magazines in the field. However, well, you might. However, it's whatever your imagination comes up with. This also makes a very good subdue your patient weapon, because you put a kink in it and you have yourself a hammer. And I'm not kidding on that one. That's you can really knock somebody's shoes in the dirt on that. Another bit of casting material. Excuse me. I know everyone thinks this is a recorder or a flutophone, but this isn't. This is a splint. And it's a good splint, too. This, I'm not sure what these things are in the first place, but this is it's a what?
Rhythm stick.
Rhythm stick. No, this is a splint. Actually, this is a pretty good splint. And especially for combat medicine, if you have a fracture in here, well, actually, you want to cast it all the way up in there, splint it all up there if you can, but then again, you can splint it across the body, too. But this will splint. If you have a broken bone right there, it's not always a good idea to lay the splint right across the break, because you're causing the patient a lot of pain. And if this bone is intact here, that's a good splint in itself, and you just need a little bit of help. And you can put this anywhere, because this is not going to bend if you have something like this here. If it does, then he's going to have more broken bones anyway. This is a good splint. It's stiff, doesn't bend. Limbs out of the wood are good, just a limb off of a tree, a nice stout one. An ink pin's a good splint. This ruler is a good splint, although I'd break it in half. Unless, of course, for some reason I wanted to put it on the wrist to further splint this. If you had broken bones up in here. Like, for instance, if you have this particular bone broken, I would splint this, especially in a field situation where a man needs his hands. I would splint this from here to here and splint these two together. If it was broken down here, on this, broken right up next to the knuckle, I would splint it here also, but then you got a problem with this being able to bend, so something like this would come in, and you would splint it, and you would keep this immobile. See, fingers make very good splints for their own counterpart. Of course, you don't want to try to splint this finger with this finger, it doesn't work. You have to get the one right next to it. Sometimes, though, there are no fingers next to it. You've got one broken finger, and that's it. Same with your toes. A lot of folks, and even Corman, they tend to look at the simple explanation and the simplified approach to everything. Oh, well, yeah, he's got a broken finger. Well, that might be his only finger. There are always other wounds. Blast injuries produce a lot of things other than just broken fingers. So you really have to think on your feet. You can't go and look, oh, I've only got one finger down here. I can't splint that. You know, what do you do? You have to think on your feet constantly, where just anything that you can pick up. And I actually enjoyed this part. I just walked around the room and everyone was wondering what I was doing, and I was picking up things like axes and wrenches, and because that's what you have in the field. You don't carry around a big bag full of splints. You can, but you look silly and they get in the way. In a combat situation, you really don't have that. Now, if you're real fortunate, you get into a situation where you have this is out of the truck. Ben, would you go out in the truck and get the air splint if it's out there? Let me look in here real quick first. And
What's it look like?
never mind. I'm just explaining. I don't want to blow one of the things up anyway. All right. There is something that you can carry in the field that we didn't have, or I don't know if they didn't exist or we just weren't that fortunate. It's called an air splint. Now, I hardly ever see air splints anymore because there are problems with circulation and other conditions that an air splint can cause. An air splint is like a britches leg, and it goes from your ankle. Here, let me show you. See, an air splint for a leg will go from about right here up to about right here, and it's clear plastic, and you inflate it, and it makes a splint on your leg. The nice thing about air splints, one, they're very light to carry. You can use them over and over. You can see wounds through them. They're easy to sterilize. And something that has been going over in my mind quite a bit is when you get to shock, you have to help the body sometimes. And that means getting the fluid out of the limbs up into the cavities to where it can pool like it's trying to do anyway. They have a device called a shock suit that weighs many pounds that you can never carry in the field, and it's nice to have. I sure like them, but you can't walk around with them in the field, and they are dangerous.
A lot of complications also.
Absolutely. You take a shock suit off somebody after you apply, put a shock suit on, and you don't know what you're doing, they are dead.
Or internal bleeding and pumping blood out to an internal hole.
Sure, absolutely, yeah. However, I'd run this past you. Doesn't it seem that if you could get a air splint to inflate from the bottom up, which you can do with wrappings like you do in surgery, you know, like you take the, in surgery, you can take the fluid out of the hand by wrapping it like this and then unwrapping it. Would that not also serve as a makeshift shock suit if you had two of them? And I'm thinking it wouldn't be nearly as dangerous, and you wouldn't.
But it wouldn't really fit the battle medicine, because in order to take it off, you have to replace fluids. So if you're not replacing fluids, why are you going to compromise the circulation?
Okay, because I'll be getting to replacing fluids in a later class, because we do have IV therapy even in a battlefield situation.
But for the common people, you know, for people that aren't EMTs or not paramedics,
right?
How are they going to gain access to?
They probably wouldn't have access to air splint either. But we have to. This is, if you come across something like this and you can actually use it, then it would help. But this is no subject I can give you particulars on, or anyone else here, because you see, battlefield medicine brings up a whole new can of worms of, okay, let's try some experiments here, folks. Well, we don't have anybody to experiment on. And but that's how you save lives, is you have to take chances. If they're going to die anyway, which is a rough way to look at it, you do have to take chances. Sometimes you really do. I'm not saying that we should go out and experiment on everybody and put on inflatable splints just to see if we can keep them alive a little bit longer. And it's not just about inflatable splints either. It's about anything that we do, any kind of combat medicine that we are engaged in, is that we are taking a chance every time we do it. And it shouldn't really slow you down when you're doing this, and you shouldn't be thinking, well, should I really do this or not? No, it's not one of those situations, because you should make a decision, stick with it, and like I said, you're going to go to your grave saying, boy, I wish I hadn't have done that, because that happens. But if you just sit back and you never do anything, then you might not go to your graves thinking that, but there's a whole bunch of people that will have gone to the grave that you could have saved. When you splint broken bones and separations, AC separations, where a bone actually breaks loose from another bone, that you have to treat like a fracture, or you have to immobilize it. You get into areas that this makes sense. You can't put sticks on a guy's jaw. So the best splint for a broken jaw, for the lower jaw, is the upper jaw. And I know that sometimes the jaw is not even there, but we're just going to go with his jaw's intact. All right. Now, in a combat medicine situation, your first intention is to just keep him alive till he can get to secondary medicine, or you can get back and do some follow-up on him. If you're going to splint someone's jaw, he has to be able to breathe. If he can't breathe through his nose, don't worry about splinting the jaw the way it is, teeth to teeth. Give me a smile. Okay. That's a good splint right there. In a longer term situation, and you had to splint this jaw, and the only thing you could do was his upper jaw, you actually do have to, in a secondary care, in even a long-term care, you actually have to remove a tooth sometimes so the man can at least eat through a straw, especially if the jaw is wired. There's also, if jaw is broken, oftentimes there's a wound associated with it. When you have to splint a jaw and put on a wound at the same time, you will use a cravat. You can actually just use the bandage, but for that you have to split the tails all the way up. But there's a take this off. Now the jaw has to be in such a way that it is splinted up against this. And you would actually take the bandage and you would have two of these tied together, or actually rolled together. And you would have another bandage going around, the tail would go around behind the head thusly to help hold it on. One thing, a problem that you do have with any type of jaw fracture, any kind of fracture actually, is you have nausea and vomiting. If the man cannot get this thing off in a hurry, he's going to die because he'll inhale his own vomit. And a jaw fracture is not that critical an injury most of the time. But if he's sick to his stomach, which he will be, especially if he's shocky, then you have to be able to get this bandage off right then, or he does. And let's face it, we can't sit there and be an attendant for him just because he has a broken jaw. If a man's jaw is dislocated, you can replace those relatively quick, but you do have preparations which keep you from doing it right then on the field, because you have to, you have to protect your thumbs, because if a man's jaw is dislocated and you go to reset the jaw, his mouth will slap shut and he'll take your thumb down real deep and it'll hurt you very much. And then you're going to be a patient. The cravat, which is made from triangular bandages, it can be made from anything. A triangular is the cravat and triangular bandages are some of the best bandages you can get for anything other than a pressure medicine. This makes a sling, like so. This is what you use for splinting. This, and you can run around the other way too. And this goes hand in hand when you have fractures, that you should be able to immobilize it, because this is the second stage of any time you immobilize fractures. Is you first have to splint the bone to keep it from slipping around, doing more damage to the tissues, and you also have to mobilize it up against his body until he can have some sort of follow-up medical work done and follow-up care. But even so, this may be his only follow-up care. There are two aspects of fractures that I wish to cover. I could spend days covering fractures because that is more or less a field that I'm quite acquainted with. However, the two most important ones I wish to cover for reasons other than just that they're bad stuff is that there is some misinformation on how to take care of these. The two types of fractures are damage or fracture to the vertebrae, and the other fracture that you should be concerned with is fracture of the femur or the thigh. Okay, on the vertebrae. Vertebrae are surrounded with muscle tissue. They're connected to ribs. You can push them out of place just by hitting somebody in the rib cage. They can sustain unusual injuries, and they're not life-threatening unless they cut the spinal column. If there's swelling or internal bleeding that chokes off the spinal column. Now, I'm not talking about shock here. I'm just talking about the injury itself, which there's a point is that in the long run is that shock is what kills you anyway. But this, we're going to stick with just the fracture because this will lead to shock, which leads to death. When you have a fracture of your spine, your body will splint it. It causes great pain. And most of the time it's just from the splinting that your very strong back muscles do, and your neck muscle. In a combat situation, some of the common fractures will be if you break a spur off of the actual, we need to turn to this, to the bone section.
Somebody turn that for me.
Yeah, would you find the bone section? If you break a spur off the back of the spinal column, you have a spur that comes out that muscles and different tissue attached to. That is something that will have to be dealt with later on, but it's not super life-threatening. Another fracture is called a compression fracture. Voila. From here down to here, even this part in here, but from here down to here, you have vertebrae that can become contracted, or they can be twisted out of place. They cut off circulation. They cut off your nerve response. You do have symptoms that will come up from nerve damage. But in a compression fracture, get down here like this. I'll just draw a simple vertebrae here. We'll just say that's a vertebrae. Not a very good one, but this is a vertebrae. In a compression fracture, what usually happens is you have a sudden jamming of the spine. You might get thrown in the air, fall down a mountain, jump out of a helicopter, which we don't have, fall out of a tree, which I've done, jump out of a tree, which I've done, car wrecks, anything, and it compresses like so. This part here is smashed down flat. You still have your spinal column, your nerves running through the middle of it. This will not kill you. It should be splinted if you have a chance. Put a back brace on if you can do it. But I have walked around, and a lot of people walk around with compression fractures. It is what's life-threatening about it if you twist suddenly, or if you're extremely stupid and go about your business and don't treat it with a little bit of respect, because pain is something to respect. It means something's wrong with your body. Then you can actually have where this top vertebrae right here slides this direction, and you have a pinched spinal column. Pilots, when they eject, if it's a rocket seat, it's not too much of a problem. If it's a cannon seat where they have a 40 millimeter or 60 millimeter cannon, we'll say shell, that throws them out of the plane, you always have a compression fracture. Almost always have a compression fracture. And what we would do is make them lay down in bed, give them morphine or Demerol or some sort of painkiller, and that's just about it. It's almost like a broken rib. Now, you can get braces to wear to help immobilize this fracture site, but carrying around a full back brace in combat is not practical. It takes up an awful lot of room. There's not too many things you can do about that. You can splint as best you can with sticks, little boards, axes, whatever you can. But even an axe or a rifle strapped to somebody's back is not a good thing. One thing that it is not a good idea to do, and I know because I've done it to my own self and caused some damage, is if you have broken ribs and you don't even know you have a back problem, or you do know you have a back problem, and you try to ace wrap the ribs, you can shift the ribs and shift the vertebrae, and you'll know something's wrong because one of your legs starts going numb. This is a definite signal that you do have back problems. That's a hard way to diagnose things, but if you lose feeling, sensations, maybe just a skin sensation, maybe you have unusual feelings on the inside of your leg, maybe a big toe goes numb. And one thing you do is have the pain back here. That is a clear indication that you have some sort of shifting of the back, of the vertebrae in the back. Now, another fracture is where the vertebrae, one of these vertebrae here, is broken into several pieces. It's pulverized. If the vertebrae, and this is the outside of the body over here, if the vertebrae shatters and blows out this way, you're going to lose your leg. If it shatters and goes in this way, where the pieces are crushed to in this direction, right here, then you have less chance of nerve damage or spinal separation or spinal damage. And but although that is not your problem at the moment, I'm just telling you what's going to happen. Now we get down to symptoms. If you are in the field and a man has a gut wound, or he's been thrown 30 feet by a blast, he has a broken back. He may not be able to feel that he has a broken back, or he may have a pretty obvious one. He may have a gaping wound there with vertebrae sticking out. There's an indicator that tells you that a man has a spinal injury. If in your examination, because you are going to feel his body, if he's conscious, you ask him questions, oh, I have a wrenched back. If he's unconscious, then you can't really, you might be talking to him because he can't hear you. However, he can't answer your questions. Sing him a song because he can't hear you. Tell him that he's going to be okay, work on him. But a man often has an erection if he has a back injury. That is not because he's glad to see you. That's because he has spinal damage and he will get an erection from it. All right? And this is a clear indication that, a fairly clear indication that he has a spinal injury. As far as treating spinal injuries, there's not a whole bunch of treatment you can do if you have the time, manpower, and materials, and you're not faced with an overwhelming force where getting overrun will kill you all anyway, then he can be transported on a litter. Now this is one of the cases where putting him on a drag is not a good idea, because even at an angle like this, you still have kind of pressure on your spine rubbing up and down that you don't want on a brake. You see, you don't want any kind of pressure on this. A man that's good to use you again. I'll forego any funny comments here. Let's lay down on this table here. We'll say you get real lucky. The man's on his back, and it's kind of obvious he has a broken vertebrae. You can splint. Especially if the vertebrae is blown out in this direction. He probably doesn't have any legs. He's probably not going to walk. But maybe you can save his life. Maybe there's it's toward the end of something. Who knows? You're going to try to save his life. You can put a roll underneath his back right here to help support him. And we're not talking about a roll that lifts him way up in the air. If a man has this is his back, this is the small of his back, and the fracture on the spine is in this area here. Your body tends to settle down, and this opens us up even further. Or maybe by doing this, maybe he hasn't lost his limbs yet. Maybe what you do will keep his nerves from getting damaged even further. You put a small rope underneath this right here as you put him on a stretcher, or if he has to lay right there on the ground, make him as comfortable as possible, and put a small rope right underneath the back. And I'm not talking about a roll like this where the man's back is arched way up here, because that hurts you even if you have a good back, much less a bad back. When you get up to spinal injury, to injuries in the neck, might be a compression fracture, and it's dangerous up in here. Might be just a crack, might be, maybe it's just dislocated a little bit. I have seen people try to set these as breaks like they would set a bone. You can't do things like that. This is above and beyond something that you should be doing. If you splint, anyone have a pair of boots on? Here's your boots for a second. Knock yourself out. Thank you. You want to immobilize this man's neck. You get him onto a backboard or a stretcher or homemade stretcher, something that's tight, something that gives him support. You have a roll under the small of his back, and that's if he's down in here. If he has an injury down there, he might most likely, or it's a good chance he has an injury up here. We don't have cervical collars out in the field. If you do, oh, that's grand. All right, here's a cervical collar. I personally would fill these with sand or dirt or anything else I could put them in. So much for your boots, huh? Anyway, and they can be placed around the man's head to keep it from rotating. And you should actually put cravats across here around the boots to immobilize the man's neck. Do not try to manipulate the vertebrae in the neck. This is dumb. You should not do this. The way you manipulate vertebrae is with a thing called traction. You can't do traction in the field that easy. That's where cervical collar does. It does put a form of traction in there. And if you have a cervical collar, what it does, it pulls, it keeps the neck in this direction and pulls just a little, and it's comfortable. And by doing this, it keeps the pressure off of the spinal column that may be damaged along with it. It keeps it from further damaging the discs or the cushioning in between the vertebrae. And this is about all you can really do for injuries of the neck. This is just about it. There are lots of lifting techniques for getting a person onto a flat surface where you can transport them. This is good transport right here, good flat surface, but we don't have tables out in the field. It might be a board. It might be a stretcher is probably the best thing you can come up with, an army stretcher, or even an army cot. That's a very good transport. If it's wintertime, you can take a blanket, spray it down with water, it freezes, and it's nice and solid. It's a good transport. Of course, it has to be Minnesota cold, or maybe up in the mountains in Idaho cold. You can't do it in certain climates, of course. But this is where thinking on your feet comes in. You have to improvise some way. If you're going to transport this patient, get him to a safe area, you have to find some way to mobilize him on this stretcher. And first of all, you have to have a stretcher to mobilize him on. There are, if you're by yourself, boy, this is a big one. You can use his clothes to get him on there, because let's face it, if I grab right here, I'm not pulling him right on the leg, I'm pulling all of his pants at the same time, which is like maybe 3 or 4 people pulling at once. The shirt's a little bit rougher because it only pulls in just a little area. If you have to, you can put cravats, bandages, belts, anything you want, around here, over here, and here's where you actually need help to do all this. I mean, this is, you can't transport it unless you have more than one person anyway, so you're not going to be trying to move a man by yourself onto a backboard if he has a broken or a damaged neck. The back, maybe you can get him on there by yourself. But after you run these cravats around the body in loops like this, you can run a pole through here and grab one of the pole and pull him onto a stretcher. If he has a damaged neck, these won't be here until you get him on the backboard anyway, or if he has to stay on the ground, then these will be here. But it doesn't matter how many wraps you have around him, you go to pull this, and you're not going to get it right because his head is not going to move at the same speed as his body. And unless you're very symmetrical, you're going to have these things tied at different tensions. And if you go to move this, his head may be traveling faster in his body or maybe traveling slower in his body, then you have more damage. So you really need to wait on someone who can support him when you move him. And also, time is of the essence. You need to get the man out while you have a chance to a safer area. And there are multiple moving techniques. Rolling. If a man is on his side, you can roll him onto a flat plane. If you have several people to lift, they can all grab onto everything from shoulders, hips, under this part of the body here. This is not the best place to lift, unless someone's supporting that, but still, hold on to both things at the same time. Now, hopefully someone has some suggestions on something like this here, or some questions.
Log rolling is probably the best way to do it if you got a couple of guys. It's the best way to do it. The person at the head controls the command on the move. Always, everybody pays attention to the guy at the head. Whoever's holding that head.
That's in any medical procedure when you have more than one person working. It's just the same thing it is if it's in a rifle squad or playing a game. Someone has to be in charge. Hopefully it's the person that's best trained and not someone who has the IQ to shoot. You want to get this done and save the patient's life. So only one person calls the shots. And that's a very good point. Log roll was the one I mentioned where you can actually roll the person onto a stretcher. Although sometimes, depending on what you use for a stretcher, it may be up here and the patient's down there. So you may have to use a lift technique. The more people you have, the better off you are. And especially if they know what they're doing. And you impress upon them the importance of not moving faster and actually go through the motions and the countdown as you're going along. Before you move, I mean, not as you're going along. And then you do it again as you go along. It's not just 1, 2, 3, ready, go. All right. You have a fracture of the femur. Femur is very easy to break in a blow from this direction. Very hard to break in a blow from this direction. It doesn't take much of a missile hitting the femur to break it and turn it into a compound fracture. Or, although even in explosive falling down the mountains, you're caught in an explosion, car wreck, you can actually jam this femur and telescope it into each one and into each other. However, I'm going to cover just splitting the femur first. I am going to use it.
Did you tell him what the compound fracture is?
Yeah, I would.
Everybody had that confused.
Yeah, on the back, there we go. Any kind of bone can break, but the long bones of the body, and even your digits, ribs, things like this. What the kind of breaks that you run into are what is called a simple fracture, where the bone is not broken all the way through. It's in fact sometimes like a green stick, where just the skin is broken. Then you have a kind of break that where the bone is broken in two completely, but it's not displaced, it's still together. You have a break there, but it's still together like this. When you have a compound fracture, it can be sometimes where they're overlapped, like this, or worse than that, where this bone actually punctures the skin. Then you got big problems, because you have to treat not only wound, but you have to reduce it. And you have to, it's like, okay, do I stop the bleeding first and then treat the fracture, which will start the bleeding again, or do I treat the fracture first? And this is where thinking on your feet comes in, because there is not a whole bunch of rule of thumb other than if the blood's spurting out of him, stop the bleeding, and you can deal with it if the blood starts spurting out again, then blood first, then the fracture. All right, but with splitting a fracture of the femur, you have to immobilize from here up to here, because the femur is, even if you don't have a compound fracture, you can turn it into a compound fracture in just a second. There's nothing worse than having you've done a pretty good job, you've taken care of the guy, he's got maybe even a simple fracture of the femur, and you don't do it right, and pretty soon you have a compound fracture. You made a big mistake, and he's in big trouble because of it. Might even die because of it. So no matter what the fracture on the femur is, you're going to splint it the same way if you can. You take a long rifle, 2x4, axe, this is my rifle. Actually, you'd want something quite a bit longer than this. But what you're going to try to do is immobilize this rule of thumb that you've come into. This joint, this is below the fracture, all the way up in here, and this is above the fracture. However, in an ideal, or even less than ideal situation, you want this all the way up under the arm. And I know they don't make axes that long, but they do make trees that long. And you want it to come down to right here. And if you're really fortunate, which is past the foot, if you're really fortunate and you have the time, which you probably will if you're working on a femur, because he's not one of the people that you work on first, then you might even have a Thomas splint, but you will have a way that you have a right angle at the bottom, like this. And what you do is put a cravat around the man's ankle, and remember, you have him. You start right here, and you tie your splint here, like this, all the way down, like this, where this splint is solid against this man. In fact, you even actually tie this leg to this one here. But if you want to put traction on it, you put a cravat around the man's ankle, and you can run it around an improvised splint, like so, and you can put another windlass on here to make traction, like I did with the tourniquet. But this part right here, the part that you're going to put the tension on to make a traction, it won't work unless you have it long enough and secure enough that it's not going to draw up into the bottom of the man's foot. Ideally, they do make special splints for these type of fractures, and they run all the way up the body. The one that has a half ring here that only goes up to right here is not ideal for splinting this. Although I'd use it, but I wouldn't use that half ring to put up in the man's crotch. It looks like a full leg splint. It's actually for splinting down in here, because this, even though you could in an emergency situation use a splint that only goes up to this far, and if you have nothing else, that's what you go for. You won't try to want to get this all the way up here. Rifles are real good for this. Rifles with bayonets are even better. They extend even further. If you have an axe bayonet or something like that, cut yourself down a tree, split it, find boards. There are a lot of splints laying around that you'll notice as you go along. Now, this leg that's whole over here makes an excellent splint to help splint this one here, because you're going to need actually two immobilizing splints. You're going to need one on this side, and you're going to have one on this side here. And then also, the man needs to lay still. And so he'll be on a stretcher. You're not going to have him up walking. You can drag someone like this, but if you do, you have to have this splinted in this area where it doesn't do this on you. Because not only is you're going to have a lot of pain, but the man's going to go in shock, and the shock will kill him. This is a major bone that's broken here. If you do it wrong, if you do not splint this the way it should, this bone can come loose and cut this artery on the inside of the leg. And if that happens, he's dead. That's all she wrote. There's nothing you can do about it. So that is the importance of splinting a leg to make sure that it's not going to go anywhere. Now, for traction purposes, or for resetting a bone on a man's thigh, this is one of the strongest muscles in your limbs, in all of them. Right after the break, there's less pain, and the muscles haven't had a chance to do their job, which is what they're supposed to do in splint is, and they're not that tight yet. And you will probably have to have another man to help you. You can do it without it, and he's not going to like what you do. But you can set him between the trees, or where the trees are under his arm, because when you pull on this right here, it's going to pull his body too. So you have to find some way to keep his body still. There is a method that men don't really like to have done to it, and you put your foot up in his crotch, because I guarantee you that you're not going to pull your foot through his crotch, and it does hurt him, but that is the way you can apply traction. There's no other way to do it. And when you apply traction and you're trying to reduce a fracture, there's none of this jerking stuff where like you see on television, where they, whoa, and they pull the fracture out like this and it slips back in. Your muscles are vibrating like a banjo string anyway, and they're tight. And if you wait 30 minutes, then you might not even be able to get the job done, because it's going to be swollen up, and the muscle's going to be hard as a rock, and you're not going to be able to do it unless you're really strong. But leg muscles are stronger than arm muscles. And so you start applying gentle traction until you can get the bones to start separating and moving. If you have another man with you, he can place his hand on top of the wound if he's not trying to hold this guy to keep him from sliding towards you. The patient is not going to be able to help much on something like this because this is very painful stuff that what you're doing. You're stretching muscles back out. He can hear every time the bone moves. I mean, you have a broken bone, it's scraping. It goes right straight up to your ear. You can hear this. It makes you sick. And you want to apply gentle traction and not fight it, because if you pull it too hard, the muscles will resist and they will rebel and slap it right back together. And then the man will probably have to be in traction in a bed with 15 pounds sitting at the end of his bed with a pin through his leg for the next 6 months trying to get those bones apart so they can start mending. All right? You slowly move it out and it will slip together. Be ready to splint it right then. Now this is a combat situation, mind you. You're just going to get him to transport in the first place, which you really don't have a bunch of, but you want to get him just good enough that he doesn't have 2 knees for the rest of his life. You just want to get him to secondary care or to mobile surgical. And also with this muscles up here, it's almost like a one-shot deal. Granted, you can reset this if when you have bones come together and you're underneath the skin. I'll leave this one on the outside. Well, I'll just do it like this. You have bones come together, and that's fine. That works real well. But sometimes the tissue is in between, and the nerves and the vein is in between the break. And when they come together, you have this. Now you got big problems. But it's better than having a floppy leg. And you don't have the time, and you don't have the equipment or x-rays or fluoroscopes or anything else to guide you through it again. You've just gone through one heck of an ordeal just to get it to relocate in the first place. You got the bone together, and you splint it exactly the same way it was if it was not a complicated fracture of any other kind. Exactly the same way, and transport the man. If you have to stay in that particular place and you can't transport, and you are also mobile surgical and secondary care, and you have problems with circulation, nerve damage, you go like, can you feel this? No, I can't. Or I can feel it on this side, I can't feel it on this side. He doesn't have a spinal injury. Okay, you know, you might have a nerve pinch in there. Or if you look down and this is a different color, it might be white, it might be a darker color, then this foot over here, then you may or may not have a problem with circulation. If you have no pulse, any of your pressure points, then you know you have a circulation problem. If the pinking is not where you mash on the toenail, and you don't have a reaction that shows that you do have proper circulation to your thumbnails, to your toenails, then you will have to do this again. Now, you can actually do this surgically when you enter into the man's system, but this is invasive surgery. It's not combat medicine at all. But if you do have the time, you may get to that. And this is something that will be covered not in this course, but later on in different courses. All right, the man is splinted exactly the same way as it was before. However, you do have to keep the wound that you have bandaged accessible because you will either have to add bandages or check for circulation around the wound, because this is a bad place to have a bone broken. And if you get infections up in here, you get right back into problems that you don't even want to get into. And it's not combat right then and there type of medicine and surgery. The wound up here, sometimes you get lucky, and the wound right here is a window so you can see that the bone gets back together. And that's not that often, but go for it. If you can actually, it's going to hurt the man, but if you can actually look inside his body and see that his bones are together, that's good enough for me, and it should be good enough for him. And you may have to medicate him. You may have to put him out, give him some whiskey, whatever's going to help him out of the situation while you do things like this, because this is a very painful situation with not only this bone, but any of the long bones up here. Same technique. Nice, slow traction until the bones separate, and then they click in, check for circulation and nerve problems. And even on these bones up here, you can do it again on these up here. This is harder because when this stiffens up, you're lost. Now, do you have any kind of questions, suggestions?
I would like to add something really fast. What usually you can tell a femur fracture almost most of the time, one foot's going to be shorter than the other foot.
Yeah.
And so when you're pulling traction, a lot of you might know, well, how do I know where the bones lined up? Well, one of the best things is this guy's going to be in a lot of pain. You're pulling traction, and you tell him, hey, bud, tell me when you feel a relief of pressure. Tell me when you feel a little bit of relief. So you're pulling and pulling. He'll tell you, whoa, leave it there, leave it there, leave it there. That's all right, that's all right. Well, you you stretched it, you pulled it back, and then when he starts going, he's going to feel that relief. The muscles are where they're supposed to be. It's still going to be hurting him, but he's going to feel a lot better than that bone jagging and the other bones are all stretched out.
Yeah.
So that's the best indication, and the feet should be about level. You'll be able to see it, and you'll feel that relief. So that's a good indication that you're where you're supposed to be.
Yeah. However, keep in mind that a lot of your patients are not always coherent, and they may be unconscious, and usually you have other wounds other than just a fractured femur. If something's bad enough to fracture your femur, then you have other wounds too. But you should always be talking to your patient anyway. You're getting input from your patient and reassuring your patient that it's going to be okay. Even if you don't think it is, you need to be telling them that you think it's going to be okay.
If there's not circulation, you got to do it all over again. Well, what if you got these bones lined up now? What do you mean you do it all over again? You just stretch it further? Or?
I said you should do it all over again. In these bones up here, you pull the bones back apart, and sometimes you can actually see where the tissue has gotten caught in between the bones. All right, you can manipulate with your hands on your bone and your humerus and down in these other long bones, even in here. You should do this again, but chances are you're not going to be able to, because by then your body's the patient's body's going to take over, and you're pretty fortunate you got it the first time. Muscles are very strong in the leg, and you might be able to do it again a second time. It depends on the immediacy of the situation. You might not even want to set it in the first place. You might just want to splint and get him out of there. Anything else?
If you have a femoral break and you plan on using some sort of traction, would you still apply traction if you have a 10-foot break also?
That's a good question. I would start with the femur first, because you don't necessarily have to hold on to the lower leg to set the femur. You want to set the femur first, then you splint it, and then you can go to your lower leg. If you try to set the lower leg first, then you might mess up the upper leg. Or if you try to grab down here, and here's the man's the two lower bones on the body down here are fractured, and you grab onto his ankle and his knee, and you're trying to manipulate him, you're doing a lot of damage right down in here. And this is okay. So he might have a limp for the rest of his life. Who cares? Right there is the one you go for first, and then you go for this one down here. That is best guess scenario on that.
Isn't the normal rule of thumb too on a femoral fracture that once you pull traction, you don't release traction. You set it where you've reached the secure zone for that Memorial break.
Well, that's for if you're taking them to surgery, though. But out in battle, you're not. You want that traction so they go to surgery. You're not taking anybody to an OR.
Well, even in the field, it depends on what kind of traction that you put on their femur. But yeah, you want to keep the traction there.
You're gonna
However,
pressure there so it can heal. And
yeah, however, you want to splint the bone, and you may not be able to get them into fracture. I mean, into any type of traction. That may not be an option. One of the reasons of traction in the first place is actually to take some pressure off the bones and keep them apart a little ways till they start getting mushy. It's like they're making their own glue, and then they release the traction. It's over a series of weeks, and the bones come together, and the patient doesn't like you very much because he's not feeling real good when they come back together, and then they start knitting, but in combat medicine, if you can put them in traction, that's great. If you can't put them in traction, you got to splint them. Anyone else?
So Chuck, the time factor on the large bones in the leg versus the arm, we're turning them mushy and putting them back together. What are you talking about?
Okay. When bones are broken, I'll just put it real simple, and I really don't have the medical terminology, or I don't remember all the wonderful stuff that some people really enjoy, but your bones are solid. When they're broken, they become soft at the break.
They decalcify a little bit, which makes them a little bit more pliable to stick.
Right. They become pliable, mushy on the end, sticky. I had a fracture of the proximal end of the humerus from here down to here, and it was in maybe 50, 60 pieces. And I could reach up like this and sort of make shapes in it. And I could go like this. It didn't hurt that much. And until it was trying to knit real good, it got tired of me playing with it. And it was like this for a pretty good while. And it's mushy. It's like a soft-shelled egg. And it's simplifying things to call it glue, but a bone will mend. Your body is designed to mend itself with or without help. Granted, it may mend you in very funny positions, but your body will mend you, whether you like it or not. So our job is to make the bone back as close as possible as we can, because it's going to knit, and here she comes, and you better be ready. And it's mushy, and we cheat it a little bit by putting in traction and keep these bones apart, and then let them go back together to where they mend properly. Another thing for traction, sometimes the bones might shrink a little bit, and you can use the traction on a bone in long-term care to get one leg the same length as the other, or close to it. Or close to it, we're talking within an inch or so. Sometimes you get lucky and get it right there.
So back to time again. What time frame are we looking at that we should release traction?
Oh, on a splint, right. on a traction splint. Two reasons that you might have the man traction, even if it's not a compound fracture, is to keep it from becoming a compound fracture, take stress off, because the muscles can actually break the bone. I mean, can cause it to turn into a compound fracture. These are, it's not that hard for a human to get on a weight press and press, 800 pounds with both his legs. So that means one of them is using at least 400 pounds, and 400 pounds on a broken bone will break it. Now, I am used to hospital setting for the healing time of fractured femurs. By all stretch my imagination, I can't imagine a man laying out in a field for 6 weeks to 6 months waiting for his femur to get ready to heal. It depends on the health of the man, the age of the man, what he's eating, everything in the world. By then, he's transported to someplace where someone who understands fractured femurs and is set up to deal with it. But I wouldn't mess with traction at all for, I don't know, we'll say at least a month. I mean, that's just the beginning. But you are going to have to keep traction on it, some sort of traction on it. When I say you are going to have to keep it splinted if you take the traction off to work on his foot, because anytime you have a band around someone, something that is tractioning someone, anytime someone lays in a position too long, you have cravats on them, you have a condition come up, it's that where your skin rots, decubitus ulcers, bad circulation. So you do have to remove bandages one at a time, and the traction is a good thing. If you take it off, it's just not going to go flannel and go right back. I mean, if you do it in the next, say, 24 hours or 48 hours, or when the muscle's nice and tight, yeah, it might do that. But when the muscle finally loosens up, then you can take the traction off and do other work.
I know we're talking about being able to keep a hold of it and line it up. I've been in an emergency room with a doctor with a little girl that had broken her lower part of her arm here. She broke one bone, but not the other one. After 5 pulls of trying to set that, and now him being a professional man and having had x-rays, you have to understand it's very complicated if we're out in the field taking care of this. So you can't get frustrated because you can't get it lined up. It happens where they've got all the accessibility to all kinds of emergency equipment, x-rays, whatever else. So he finally just said, "Do you believe in God? I'd like to say a little prayer to be my next pull," and that's how he got it.
Very good. The books address this. Don't try it over 5 times. If you try it 5 times, just go ahead and splint it and take him to a hospital. We need all the help we can get on this. And it really doesn't hurt to call on God to help in these times of stress. It's not going to hurt you. It's going to help you. And even if you're not really sure, even if you're just not really sure, it's still not going to hurt you. A lot of folks think like this about medicine. This came from the U.S. Militiaman's Handbook. It's not exactly what I call it. I'm not sure who wrote it, and I really don't want to ever meet the person. While writing this handbook, I told a longtime friend what I was doing. He said he hoped that I included a first aid kit in the equipment chapter. I replied that I just figured we were all going to die anyway. Becoming a U.S. militiaman is a serious thing. The outline of this book entered my mind. I do not understand why I was chosen to write this handbook.
Neither does anybody else.
These are some of the helpful hints we have out there in wonderful medical land. A man on a mission from God does not want to include a first aid chapter, although he does mention first aid later on, that we should all carry half a roll of toilet paper because it can double as a bandage. I'm not sure what kind of one he's talking about that you want to shove toilet paper in it. I can't really think of them right offhand, but garbage in, garbage out, we really need to stay away from some of these sillier aspects of first aid. I could really go into some good stuff on this one, but I just don't think I want to. I have heard some mighty strange stuff. And in combat medicine, it is thinking on your feet. This right here is the doctor. And this right here, shouldn't always use it. You can't always use it. It is terrible, dirty, horrible. It'll affect you for the rest of your life. The children that you see that are damaged and hurt in warfare is not something that you can lightly dismiss from your brain. Ever. I know very few servicemen who have not been in combat, or who have been in combat, that at one time or another, maybe several times a week, don't wake up in the morning and they'll sit there and tears coming down their face and they're not really sure why. Well, excuse me, I know why. I mean, I've had to deal with people like this. I do it myself on occasion. I can't give you the specifics of why. This is not a pleasant subject. And by the way, my dad, who was a corpsman for 20-something years, see if I can get through this one here. He said, don't let them forget the children. When you see children sitting beside a road with rags around their head, open wounds, they're alive and crying for their mommies, and there's maggots inside of them, you better have an answer. You better have an answer. If you don't have an answer, someone will kill you. And they should. You better at least have something you can say or do for these people. You better have, that's where your heart better come in. You better be able to handle these things, because I would imagine, just from numbers-wise, that for every one of, we'll just call us militia or soldiers, for every combat person killed, you will have anywhere from 4 to 8 civilians killed if we take into areas we shouldn't, and God knows how many wounded of civilians, of people who are not fence sitters. So what? There still are people. And you better know what you're doing. And if you don't have this little honey right here, a bandage, this right here, all the equipment in the world is not going to help you. Nothing is going to help you. You're going to die. You will die. This guy is at least right about that part. You're prepared to die. You should have at least bandage, because this right here is step number 1, and the rest of it all follows.
I'm real curious about, Carolyn brought up, I can use my wife's name because she's part of the mission, on the doctor that worked on this little girl's arm. He tried to set it 5 times with the x-ray and still was not successful. What kind of a chance do we have out there in the field to know where we're at? I mean, it's a Russian roulette guessing game, isn't it?
Maybe. I understand about setting the bone, one of the bones in the arm where this one isn't broken. All right? It's kind of hard to pull this bone and put traction on it when this one's still attached, unless you want to break this one here, which is a possibility, and then traction both of them. It's not a great possibility, but you can do that. And we can traction bones and set bones as well as a doctor. It's just not as easy. And especially in secondary care, after the combat medicine, then we will be able to do really astounding things, because the doctor is essentially a mechanic with a heck of a lot more tools than us. But if you go back 100 years, the 100-year-old doctor on the battlefield and the corpsman of today, or even the doctor of today, we're virtually the same thing, because medicine is not magic. It is not the religion of gods, even though a lot of people try to make it out to be. We're mechanics, and we can do it. We can figure it out. It's essential. If we do not figure it out, here's one of the reasons we can't. If we do not figure it out, they'll wear us down by attrition. So we will have to figure it out. Now, for the ladies present, and this is something that I've tried to impress upon the ladies when we're talking about such a dark subject as this, because no woman, especially, and men too, but I'll just let you watch it out, guys. No woman wants to hear that her children are going to die, or that her husband's going to die, or that her children are going to go into slavery or anything else. I'm here to tell you things are grim. It can get a lot worse, and most likely will. But I can make you a promise. Your children will know liberty. They'll know more liberty than I know. you'll walk streets, and you'll breathe clean air, and it'll be okay. And I might not even do this. You know, it might be your children that do that. We don't have a choice. And it's going to cost. Liberty does cost an awful lot, but it will be okay. And anybody who disagree with that, we can go someplace and I'll talk to you as the only informant you. In a basic Unit 1 kit, first aid kit, it's a trifold pack, or it might be a little box or suitcase. You should have standardized equipment. And this is a rough outline of what you should have, or something approaching this. You have one roll of wire fabric, or a wire splint, same thing. It's a piece of wire that you roll out and it makes it into a splint, and you wrap things around it. You put some padding in the bottom of it first. Okay, 2 bottles of aspirin. Aspirin is a wonder drug. You can't become addicted to it. You can't build up a tolerance to it. It thins your blood. It makes your swelling go down in your body, and it's good for you. Yes?
What if you can't tolerate aspirin?
You have Tylenol does the same thing, only not as well. There are natural medicines that do the same thing. Yes?
So you said thins the blood. How good is that if you're trying to clot a wound?
Okay, after you don't want to give it to someone who has a fresh wound if you have a bleeding problem. However, it will keep your infection down because it does increase your circulation. And now if someone has a real bad bleeder, you don't want the blood thinned too much. But aspirin is a pretty good, it tells you if you've had too much, your ears start ringing. There is a bad side effect, not side effect, there is a bad thing that you have to watch for in aspirin. When it starts smelling real strongly vinegar, that means it's on the edge of going bad, or right there maybe. If it has crystals on it and you take it, and some sort of little crystals gross on it, it's poison, it'll kill you dead, then you won't need the aspirin. All right, aspirin does have that capability to poison you. All right. 3 packs of morphine injectable, quarter grain. You can substitute Demerol, codeine, morphine, Tolwyn, Duragesic patches. That's for long-term care, especially if someone has a broken jaw and they can't eat. You know, Duragesic patches is made of fentanyl, the fentanyl transdermal system, and you put it on. It's like a nicotine patch, and you feel real good for 3 days. Someone, yeah.
What's that 5S there?
5 syrettes. The syrettes are little bitty squeeze tubes. Whatever you got in there for pain, it's best to have injectable because it enters the body right then and does it, but you use what you have on hand. A bottle of tetracaine hydrochloride ophthalmic solution. When you have an injury to the eye, you need to kill the pain in the eye because otherwise, if you don't bandage both eyes, which you usually do, even if you have a wound in one eye, you bandage both eyes. That's to keep it from further damaging this eye because eyes don't move independently of each other. Right? If this eye moves and you have a piece of lead or a stick in this eye, it's going to move around. Then you bandage both eyes. However, if you only want to bandage one eye and say it's just scraped or flashed or whatever, this is a painkiller, localized painkiller. It's kind of like lidocaine, only you can put it in the eye. And it kills. You can actually do operations by putting drops of this and cut somebody's cornea right out because it kills it deadens the skin. It's lidocaine. It's like a dentist on your tooth if they use lidocaine. 3 bottles of Provine iodine solution. The smaller bottles are better. You can carry around big bottles, but best to break your stuff up into small amounts. They even have little glass syrettes, not syrettes, but tubes that you break and you can paint it on the seam. It's a good all-around germ fighter. 2 packs of atropine. I'll go into some of these on the medications, but atropine is another one of our wonder drugs, and it's also good for nerve gas. 2 Muslin muslin triangular bandages. I would carry more than that. I would carry at least 4. 2 medium battle dressings. If you can get them in there, I would carry more than 2. I would carry 4. And your 8 small battle dressings, that's just about right. 8 small battle dressings, you should be carrying that if you have a medical kit, even if you carry it around your car. Now, the roll of adhesive tape, 3 inches by 5 yards. 1 roll is actually okay because you can tear off little pieces of it. You can use it like you do your duct tape. Okay, I want a small piece. We'll just go around like this. Band-Aid, that's an excellent dressing. And it's actually a wound closure. You can use them just like you'd use a Steri-Strip, which you probably won't have, but it's sticky on both. It's sticky on each end, and it actually closes the wound instead of a suture. By the way, tape can do that also. A pair of scissors. You probably have more than 1 pair of scissors in your kit. One of them is maybe something like this right here. And this is one of the best inventions that they ever had. I like it much better than the regular EMT scissors that EMTs carry. It's just, it takes up less room. And this right here is 50 years old, and it's still going pretty strong. Although it doesn't matter what kind of scissors you have, you use them. This is for cutting bandages off, cutting clothing away. A tourniquet, a rubber, long piece, say 6 feet long, rubber band. That makes a good tourniquet. Belt makes a good tourniquet. Straps off your pack makes a good tourniquet. The reason I like rubber bands, like out of a bicycle inner tube, that's a good tourniquet, is you can use them for more than just what they're in your pack for. Everything has to double. Everything in your pack has to double, at least double, if not quadruple. You have to have more than 1 reason for it. Airways, plastic and adult. Plastic, adult, and child. Airways, I'll give you some examples of different type of airways tomorrow. A thermometer is good. I would have a combination of rectal and oral thermometer because there's sometimes you do not want to stick a thermometer in somebody's mouth. One, you'll lose the thermometer. And actually, it's best almost to carry 2, but sometimes you only have 1. Because after you use a rectal thermometer on somebody, then if you have to take somebody's thermometer in their mouth, you don't want to be telling them that, but you do have to clean the thing very thoroughly. And it's almost a class in itself when I was in school on how to clean the thermometer. If you can get 2 thermometers in there, do it. Okay, a card of pins, medium pins. These are safety pins. They're really great in place of tape for putting bandages on. Like when I put on the sling, you have a little tail that comes around like this, and you can use safety pins to close the wound if you have to. It's been done. You can at least get the thing together a lot more than what it is. Safety pins have multiple uses. They take splinters out of your body. Because we don't carry needles that you want to use on somebody to get a splinter out. You want the needle for injections and stuff. You don't want to waste it on somebody's got a splinter in their pinky. So you use a safety pin. And yes, you want to get the splinters out too. Your minor surgical kit, you can get these out of catalogs. I will tell you places that you can get different surgical instruments that will go into your surgical kit. And I will cover more thoroughly your surgical kit when I talk about minor surgery. 2 books of field medical cards. And I haven't the faintest idea what that is. I've seen the medical cards that we use, but I'm not really sure if you even have room to carry something like this in a little bitty...
Well, it's in the book. I'll bring one tomorrow. That one.
Okay.
That's right.
In a combat field situation, you probably won't have time to refer to it. Yes?
Chuck, should it not be mentioned on there that there should be some needle and thread in there?
Yeah, that'll be in your surgical kit. Oh, I see. Okay, I see what you mean. A black pencil, and someone mentioned that
maybe a eyebrow liner, that would be better. A grease pencil, I mean, a ballpoint is acceptable. A lead pencil, you're going to hurt somebody by drawing T's on their forehead or trying to write something on it. However, in a bad situation, you can use their own blood to draw T's on for tourniquet and M for morphine. And 2 packages of roller gauze, 3 inches by 5 yards. I would have more than that because you're going to use a lot of roller gauze out in the field. I would have at least 4 packages, at least.
Another thing that works really good is butterfly bandages.
Yeah, this right here, butterfly bandages, you can buy them already made in the butterfly bandages, but they take up room. And you can do the same thing with a roll of adhesive tape. When I get into minor surgery, I will show you how you make a butterfly bandage. Because the butterfly bandage, sometimes you use that to close the wound, or you might use some hair, you know, the person's own hair to tie and close the wound.
I've seen cuts that were 10 inches long. People use butterfly bandages on them. You never even left the scars.
Sure, yeah, they're better than sutures. Sutures is an invasive type of surgery, and it's nothing to snizzle at and doll, you know, if you're suturing up. No, there are better ways. It depends on even glue, super glue. You can use super glue to close wounds. However, I would usually put another suture in there to help a little bit because you do have a lot of stress on wounds from swelling and just from wound. So, yes, put a ball of super glue in your case. Yes.
What's the name of that thin tape?
Oh, steri strips.
Steri strips.
Yeah. And one other thing that I would carry in this, at the very least, and it works so well, is Melaleuca. Melaleuca, I discovered Melaleuca and I thought, I felt like throwing rocks at myself. Well, why in the world did somebody tell me about this before? This was a major industry in Australia before and during the war, and you even didn't even have to go into service if you made Melaleuca because it is, and I've tested it on myself several times. To me, it far surpasses putting antibiotics in your system. It is a good antibiotic, makes it heal quickly. I don't think it controls the bleeding. Smells like kerosene, but still, it's good stuff. It really is. Yes?
If anybody needs to get a hold of Melaleuca, get a hold of me.
Or me.
I'll get a hold of her. She needs more business than a number. Any other question?
I think I'd probably put a pair of tweezers in there too.
That'll be in your surgical kit. Yeah. Yes.
One quick question, getting to the back to the airways, cannot the bottom of a pen be utilized?
Oh, you betcha.
In emergency, trachea?
That when I go through trachs, I'll show you a pocket knife is a good thing to use for a trach. There's a lot of things you can use for a trach.
Insert is.
No, that's what I mean. I'm talking about you stick the knife in and turn it sideways like that and it opens up the airway. Yeah. There's a lot of things you can use to open up an airway in someone's throat.
IV catheter.
The what?
IV catheter.
Oh, sure. IV catheters, 13 gauge needles, shotgun shells, you know, the little 14s. Oh, I mean an empty one. Okay, all right. There's a lot of things you can use.
fellow Americans, welcome to part 3 in a series of 5 of combat medicine to help our fellow Americans prepare for what's coming, what seems to be the inevitable. We'd like to introduce you to Chuck Fenwick, our guest speaker from Minnesota. Chuck.
In battlefield medicine, you may have to suture up a wound. Mostly what you're going to be suturing are incisions or cuts, or where something has struck the body and separated the skin away, and you have a tear. There are several different types of suture available. I'm here to tell you can use anything to suture up a wound that will close the thing, especially if it's not an internal wound, or it's not exceedingly deep, where you can take the suture back out. Silk is a very strong suture material. However, silk, you get into a condition called spitting, where the body actually rejects it. Not all the time, but a lot of the time. Wire is a very, very good suture material. However, it kinks. Nylon is a good suture material, but when you tie the knots, you have to tie several knots in it because it will come untied. Regular sewing kit thread, cotton, is probably one of your better suture materials because cotton is not easily rejected by the body as something like silk. The least problem you have with rejection, I would say, is steel. I mean, your metal sutures, and next would be your nylon sutures. But everything has drawbacks, and when you have to suture up someone, you'll use whatever looks like a piece of thread. And I do not care what it is, you can do it. Some of the more, we'll just call them primitive, and it's not really primitive, it's what our forefathers used. For suturing up wounds is a needle and thread, and that is what you need. And you don't even have to know how to tie a knot on something like this. If you can make the wound close and stay closed, and you can't remember anything you've ever seen anyplace else, just don't tie bows. That's the only thing that you have to stay away from. And don't worry if you drop a stitch. This needle and thread is excellent, and I'll try to go through this as I go along here. Proper suture material, or suture material that hopefully you can get your hands on, comes in packages like this. This is called Ethlon, or Ethicon, which is a brand of Ethlon, and which is a nice way of saying monofilament, or fishing line, which makes another good suture. And it comes already attached with the needle. However, sometimes needles come by themselves, like this. And this is actually a nice size needle to be using.
What size is it?
Okay, let me get a package over here so I don't make a mistake on this. This is a 3/8 circle, and I tore the rest of the package off. It is a 3/8 circle surgeon's cutting edge, and we're not even going to get into different types of needles that you can use, where one's a cutting edge, or it doesn't matter if the thing's a drill. If you can get a hole in a wound in combat medicine, or next to the wound, you can suture the thing. Right here. Now remember, there's really no sterile technique in the field. However, you are putting suture into a wound, and you do have an open wound. I'm going to put on a set of gloves, a pair of gloves right here, not because it's I'm afraid of getting wound infected. I'm afraid of the wound infecting me. You can use kitchen gloves, you can use any kind of gloves that you want, and there's a proper way to put on gloves, and I don't have time to go through that. I suggest you go down to your hospital and ask a nurse how to put on gloves. And you can tell in the compression here, this is not put on gloves. Depending on where the wound is, you can, you want to try to hold the suture, the needle, inside of your, clamp it in some forceps, like, hemostats like this right here. Now, normally with human skin, it's very tough, and I would probably put the hemostats here, depending on what kind of, if it's very tough like the skin on someone's back, I might put it halfway down, but I'm getting ready to suture up not a human. And the skin on a deer is real tough, but we'll pretend it's a human just with tough skin. He's militia, so he has to have tough skin. So I'm going to grab this up further. Near the edge. And I grab it up near the point of the needle because the needles do bend and break.
The needle is somewhat rounded, isn't it?
This is a cutting edge. Oh yes, these right here are half circles. The needles come straight, that you can bend to whatever shape that you want, or they come in circles. And some needles, depending on the wound you're suturing, you might have to bend that thing into really strange shapes. And they are made to bend. Needles that you use to sew up clothes are really not made to bend, and I'll not try it because they usually break.
I used a rug needle to sew up my horse one time.
You used a rug needle?
Mm-hmm. Upholstery. An upholstery needle. It was shaped like that. But
this is good stuff.
It was heavy duty, and I could stick it through and pull it through with the pliers. She stood right there and cooperated. She ripped open the whole front end of herself.
Yeah. Most humans don't cooperate.
No, we're sensitive.
Yeah. However, when you're suturing on a human, you explain to them that if they are kind of rowdy, that if you make one mistake, you're talking about yourself, they can really be hurting, and they calm down even though it's a lot of pain. You're really into control when you're in medical, and you tell them whatever it takes to get the job done. Now, suturing a wound like this, it's just a straight wound, and this is most of the wounds you're going to run into. I've already made a decision in this to make, I'm not even actually down into the muscle. If I was down into the muscle, I could run separate sutures of what is called catgut. Now, a lot of folks think that catgut are made from cats, and catgut is not made from cat. Oh, okay.
We can do that.
Sure.
Just this one here. This one.
Oh, man, that's got meat on the other side.
Wrap the plastic bag.
That's just get the camera over there next to it. There we go. There. Just get the camera.
This will be okay right now. While I explain it.
That's good. That's good, just like that.
That looks good. Okay. Wounds are messy. Sometimes you have to do it without your gloves. The man may be infected with all manner of diseases. And that's just the way it is. Because if you don't have any gloves, you're still going to have to suture the person up. And especially in this day and age, you are going to run into diseases. Do your best to have gloves on hand. Kitchen gloves are pretty good because you can rewash them, sterilize them, dip them in a bleach solution, dip them in a peroxide solution, wash them down with Lysol. Granted, they may not be sterile, but you don't want infected gloves going back in your Unit 1 or sticking in your pocket or anything else, because your skin is a giant vacuum cleaner and it will absorb whatever's on the gloves. Anyway, sutures, on internal sutures, they use you can get into exotic stuff where it's a synthetic and the body does absorb it, but most of which will be available to you is stuff called catgut. It is not made from cats. Maybe it was 100 years ago. It is made from about the first 8 feet of sheep intestine, and it's the connective tissue that's in the sheep intestine in the first place. It is very absorbable, very strong, and if you're working on any number of denominations that do not want something unclean like fluffy inside them, you might have to assure them that catgut is not made from cats. That is a fact.
Does it have any rejection from the body?
On the internal suture, the body eats it. Okay. It absorbs it, which is what the body is doing. Your body, depending on the chromic content of chromic suture, which is absorbable suture, it depends on the length of time it takes to absorb the catgut. Chromic, or chromic content, it actually has chrome in it. And I'm not sure. This is something you'll have to check up on, but the higher the number of the chromic content, the longer it takes for it to absorb. And it depends on the wound that you're working on. However, we're going to work on this right here. This will be external suturing. Your job is to get this closed, because if you don't get this closed, you will have infections that will enter into the body. This is the filter, the major filter for the body. Infections will enter into the skin. However, if the skin's not there, it won't even slow down. And if you get into the tissue that's in between the outer layer of skin and if you get into this tissue right here, this infection can travel as far as that tissue is. That's perfect. There's no air there. Very little. If you get down in here, it's the same thing. The infections travel like this, and they infiltrate just the same way as an IV would. And all of a sudden, you have a little cut on your hand, and you're out in the woods, and you've been handling all manner of possible dirt, and you have an infection that is not going to go away. It becomes a smoldering infection. You'll have it for the rest of your life. If a wound is already infected, you don't suture it. Don't worry about the scars. Maybe scars will be in vogue one of these days. You don't worry about scarring when you're in combat medicine. That's just the way it goes. Unless, of course, you're working on a face, and there are several reasons for this, but you do your best not to leave scars on the face. Another thing you don't do, you don't shave eyebrows anytime. You might shave somebody's head, you might shave somebody's groin, you might shave their armpit, but you do not shave the eyebrow, because it will not grow back sometimes, or maybe one half it will grow back a different color, or maybe it'll heal and you've got one nice eyebrow on this side and one nice, you have two eyebrows like this. So you do not shave the eyebrow under any circumstances. Never. And, okay, suturing. The rule of thumb for suturing is however far away the needle penetrates from the edge of the incision is roughly the same distance between the sutures. Okay? And on this right here, we'll just say, see how tough this is. You want to go to the bottom of the wound, or as nearly to the bottom of the wound as possible. Let's go this one here first. This is what I'm doing, and roughly this is what I'm doing right now, although it's going down into the fatty tissue. If I were to take this suture and run it, we'll say, a little chop. Instead of down this far, say I ran it down this far, and this was not pulled together sufficiently down here, you can have a blood pocket down in here, which will actually breed infection. And then you have pus pocket, which will cause the temperature to go up. And if you think spitting sutures is bad, well, you spit the whole wound out. And that's if you're lucky. The rest of it will just go into your body. And if it goes down in here, then you're going to work with infections and use up your antibiotics. But this will happen to you. Do your best to try to get it as close to the wound as possible. You don't need to run it under the wound because then you have a pulling up effect like this, but you can get it right down where I have the spurs line drawn, like this. And get it down, and it will close this wound right here. And then this up here will close the top of it. Any questions on that while I'm trying to run this wonderful needle through here? You can tell a location of your needle a lot of times because it hasn't cut through the skin yet, and there'll be a little protrusion there, and you have to do this, but you don't run it through your finger. All right. Normally, I don't know if you can see this properly. Anybody want to?
We can see good back here.
Very good. Normally, you would not. You don't need to if it's just suture like this right here. The deeper the wound, the further out you go. On this right here, you would not run the suture quite this far out. However, I'm working with a very tough-skinned individual, and so this is the way I do it. Now, I can do a double instrument tie, but we really don't have to worry about this. You pull this through right here. So, and then you, I don't believe each other. 1, 2, and then yes. I don't want to waste the suture. All right. I'm going to show you in a minute exactly what I did. And then you go the opposite direction. And if I didn't go the opposite direction, too bad. Now, see how this slipped right here? You have to watch that. Let's do this. Thank you. Nylon is nasty stuff to work with. I took more than one turn them on purpose. You don't want the knot over the incision. You want it to the side of the incision, like this. And you don't want the wound to pucker up too much. Because you have to allow for expansion. You have to, you have a lot of swelling. The tighter you have it, the more you have the vessels that in the healing skin constricted, and put yourself up with problems. All right. Now this is nylon, and normally with something like silk or cotton, you would make a knot that looks something like this. I need to use you for a second, and I'll try not to touch you with my gloves. Go ahead, stick your arm, not stick your arm on here. All right. When you bring your suture up and you tie it, go like this, go like this. That's actually almost like a double granny start here. And you bring it down. Now I might get lucky this time and do a square knot. Then you have the knot on top. thing about tying suture knot. And yes, it's better to get a square knot. But when you tie a knot, it's going to try to come untied on you after you tie the first time. And this is actually a surgeon's knot. And I don't know if you notice on the nylon end, I even took more than 3, like this. Now it's not going to slip as easy. You have no one there, and nor do you want anyone there to put your finger and hold this to keep it from slipping. And the second knot, and especially with nylon, you're going to be tying all day long, trying to keep it from slipping. You might tie 4 or 5 of these things. You're in a hurry, and square knots are important, but your chances of getting one every time and getting the way it's supposed to be done are remote when you're on the battlefield. Just, you're lucky if you don't get a bow out of it. Sometimes you're lucky if you don't untie the knot that you just tied. Because when you're flipping instruments around or doing this, you can actually untie the first knot. You think you did something right. I don't know if anyone's ever tied a knot before, and you go up to do the second one and run something trying to be fancy about it, and all of a sudden you've untied the knot. Okay. Why don't you go wash your arm off? So, I just tied this first of the surgeon's knot, and then I put another one on top. But this is nylon, and nylon slips, and I'm going to do it again. Just a 2. Oops. Now, when you have knots that you've tied and you're just running single sutures across here, you don't want pennants laying around, because these things catch. And you also want, we'll just say about a 1/2 inch, 1/4 inch, whichever you prefer, to leave. I'm going to bring it down about right here. To leave tails on your suture. Because if you don't leave tails on your suture and the knot slips, you lose it. And then you have an open wound and you have to start all over again. Your next suture will be right next to that one, same way. I'm going to try it a little stronger. Try it halfway. Did everyone see how I did this?
We can hear a little.
Did anyone not see how I did this?
You have to wrap the forceps with the suture for the knot, and then you grab the tail. Well,
okay.
It's just not easily seen on the video.
Then let's cut it right here, and you folks come up here and take a look here real quick how I'm going to do this. All right? We'll do this as quickly as possible. We wanted the rest of it touch. It's important that you see it because you are the beginning of a lot of things.
If you guys can do us a favor, they're just going to keep rolling. Just leave this area open so get around whatever you can. So they're laying down as much. This is coming up pretty good.
Yeah, the whole concept of people being up there will be cut out of the film. There will be no faces on the film.
Oh, very good. All right. Yeah.
That's fine. That'll work. That's fine.
All right. Now, this is about.
Speak up, Chuck.
Pardon?
Speak up.
Speak up a little bit. But that's right. Just go ahead. Do what you do.
I'm talking to a deer, so I'll change it over here. As you can see, about this far from where the suture went in, so I'm going to make my next suture just about the same distance around. It almost forms a square, so I'm going to start right out here like this. Take the needle in, and don't worry if you get under that particular little piece of skin there. It's not the best thing to do, but you're in a hurry. You come up here. You see how this needle, you can see it right here? Now, if the bump comes up out here, you're too far away from there, so you can see just about where the needle goes. If you're in a hurry, now we're through. Get very, very careful not to puncture yourself when you're working. puncture yourself. All righty, now comes the fun part, and it looks real hard. You're going to do an instrument tie, and the reason you're going to do an instrument tie is because your fingers are fat, they don't work that well if you're my age, and you've broken them and everything else, and you're not as supple as what you used to be. Not only that, it's easy to contaminate yourself if you don't. So, you take your hemostats, and they're closed, like this, not necessarily snapped, but you have to get used to snapping and unsnapping this thing. And what I'm going to do is, let's just do it like this. 3 wraps this way, where I took the hemostats. I'm going to take this one, this here. Now, I have a knot. However, I probably would have taken another wrap that's in this nylon. Well, let's see if it holds. Actually, mistakes are better. All right, now I'm going to go the opposite direction. We don't have to take 3 wraps on this one here. Okay. There's a problem. This is good. This is good. I'm going to do the nylon here, remember? And I'm taking many turns on this. I reach down and grab the suture material. Grab that myself. The knot here. Nylon, and do it again, opposite direction. Now, I left the tails a little bit too long on this. Actually, they weren't too long. The tails got in the way of this, and the tail from this one right here is caught in the knot on this one here. This is not neat seating that we're working on. Don't worry about it. I also puckered this a little bit too much. However, you know, that happens. And I would probably, well, that's okay, that's fine. This is a little bit, might be a little bit too tight. Depends on how much it cuts down in here. It's hard to see. But did you see the problem with, say for instance, this right here, which is nylon? It comes undone real easy. That you tie it and then it comes undone. No matter how many good knots you have here. All right, now let's do this with our fingers. We're still going to use the hemostats to drive it through, although you can just use your fingers. But you need something like a thimble to help push it through.
I'm not sure if I'm sticky enough, so I'm going to use that.
I may or may not be able to tie this with my hand. All right, suture through. Bring this up like so. All right. Now, the surgeon's knot. See, another thing about an instrument tie, you don't waste as much suture. This is nylon, so I'm going to take another turn here. Well, you don't have to take more than that. If you do get the knot over the wound, don't worry about it. Now, tie another knot. In fact, it won't hurt to take a couple turns around this. And I'm going to do it again. Okay, got your tails off here. in a suture situation, when you're suturing someone, you would not have uneven sutures like this. You have a small gap here and you have a big gap here. If you do, you can't really go back and undo it. I moved out here because it's a lot easier to work with, and I didn't want to get caught in these tails and then have to try to explain that one too. When you're suturing someone, you make them as symmetrical and as even spaced as possible. Okay, if folks, well, you just see these are single sutures. These are not running sutures. And that's what it should look like. It doesn't have to be exactly at this end here, but as close to it as you can possibly get. It smells worse than a patient. And if you have to, you can even draw lines on the thing. Doctors draw lines all over you when they're working on it. Now, when you get to a piece of silk and you're suturing up the skin, that is, well, you can use catgut even on the outside. When you get up a piece of silk and you're working on the skin, it's braided. You only have to tie the thing. You only have to tie the one instrument tie once like this, and then back through again. Now, while I cut this off here, I want someone to ask me some questions.
Why should the knot be over the wound?
One, so you can see it. If the wound swells up and puckers up, which it will swallow the knot. In fact, the skin's going to swallow the knot anyway sometimes, and you have to dig the knot out of the skin. I'd much rather dig it out of the side over here than open up the wound again by digging it out of the suture line. There's all kinds of reasons why you you wouldn't do it. If you get it over the skin, over the suture line, don't worry about it. This is combat medicine, and just like I say, just so long as it's not a bow, that's all that matters. You have questions? Okay. Now, I'm going to show you a running suture. However, let's see what we can do right here. Would someone who has better eyes and idea, would you thread this needle in just about this long right here? And I already touched this. It's not. There's no infection involved. Sure.
Not longer thread on it?
Sure. Just about that long. Something I can work with.
How about my hair?
Your hair?
Yeah, you can straighten my hair.
It depends on if it's going to break or not. You can use hair to suture with. Any kind of thread that's in your clothes, you can suture with. Your button, whatever holds your buttons on, unless it's one of those button ears, you can suture with. You can probably even suture with a button ear if you wanted to. You can use, suture is kind of a broad word here, but you can use these little safety pins to suture with. You can use, in fact, I'm going to take this off. Oh, yeah. I'm really shocked I lost my finger. Those steri strips that you've heard of, they're actually thinner than this right here, but this makes wonderful steri strips. This is suture material. In fact, if I can get this down thinner, it'd be better. The thinner, the narrower the steri strip, or whatever you're going to make, the better off you are. Now normally, well, actually not normally. A lot of times humans don't have quite this much hair on them. Tape does not stick to hair real well. Okay, if you're going to put a Steri-Strip onto a wound, you stick it over here. You'll have to help a little bit. You line it up, and this is not going to stick. Okay. And you close your wound thusly. What I'm doing here, I'm trying to get it held together long enough so I can show you how a Steri-Strip works. You won't be suturing like this. This is called cheating while I put on a butterfly and a Steri-Strip. Okay, this is what would be a Steri-Strip, piece of tape, duct tape, electrical tape. You're going to try to get it as narrow as possible to make a strip of tape narrow. If it'll tear like this, that's fine. This might not tear in a straight line. In fact, I don't think it will. Then you have to take a knife, a scalpel, and cut you off, a section of strip, a strip of tape here, and you can use that. And these are for wounds that are not under great amounts of stress, because tape comes undone. You can tear it. It depends on where the thing is located. You wouldn't use Steri-Strips on a knee unless it's a model. And she wanted not to have giant scars on her because sutures cause scars. And you do have to take sometimes into consideration who you're working on, even in a combat situation. It's kind of hard for someone to understand that maybe a scar will be so devastating to the person that they're working on, so you want to try to reduce as much as possible, especially on the face. Steri-Strip would go thusly to pull the wound close, and I'm just going to hold that. Like that. That's close enough, but that's the way Steri-Strips work. Butterfly, this will work for butterfly. I'm sure most of you, well, I mean, how many of you in here have used butterfly? Okay. Imagine everybody out there uses butterfly also.
Could you use dental floss?
Yes, you can use dental floss. Anything that's a piece of thread, you can use it. It makes no difference. I'm going to make this butterfly large so you can see what I'm talking about. You'd actually want it about 1/2 this width. You can use super glue to close a wound. Super glue does bond the skin. This wonderful new glue that they use to glue wounds is like a cousin of super glue. I talked to a veterinarian, he says, oh, heck, you could actually use super glue if you wanted to, it's a lot cheaper. Of course, I have talked to several veterinarians and some other medical people, and they're pretty much agreed that you also throw a couple stitches in there to help take up some of the tension that's on a wound, because super glue is not been around that long, and the problems with it will show up later. Okay, you make let's draw this out first. A butterfly is just a piece of tape, like this right here, and you cut a gap right here, and a piece out right here. like this. And you fold, you don't cut this right here, you take these and cut like this, and you fold this under to keep the stigma away from the wound. Is a large representation of a butterfly. I would never make it that big. If you need to close a wound that big, you're probably not going to be using butterflies. However, a butterfly doesn't scar as much. You can use a butterfly to hold small bandages underneath, little bitty squares underneath it to protect the wound site. And depending on the tape you use, butterflies don't react near as much as what sutures do, and they pull the wound closed. But you do have to watch them. You might have to run a strip of tape like this, might have to run a strip of tape like this here, especially on a wound that is in a part of the body that is more active. But these butterflies, I don't know how long they've been around, but they have been around for a pretty good while, and in use, because I imagine all it takes is just someone saying, well, this right here would work. Okay, butterflies are something that you can buy, but I would much rather myself just make them and spend the money on something that I can't buy. Steri strips are something that you can make. You can also buy them. That's up to you. If you want to, if you have the money to spend on Steri strips, then by all means spend it. When you work on the face, or you work on a place that you don't want the scarring as bad, the closer you make the sutures together, the less tension there is on the wound, and the less scar that you make, because the scar is oftentimes caused from when the wound swells and it pulls on the sutures, and if you have, say, 50 pounds of pressure on 2 sutures, then you're going to have some scars here. If you have 50 pounds of pressure on 10 sutures, you're not going to have near the scarring. And that's the way it is. There's other things you can do on the face, but that is not combat medicine. You can put grease on top of not grease, but you can put sterile Vaseline on top of the suture line. And if the suture line is exposed to the air or exposed to problems, then you have to watch that things will not catch the sutures and rip the whole mess out. You should bandage your suture line. You may not get a chance to, or it may come to a condition where you want to have it exposed to air or exposed to sunlight. So the bandaging part of the sutures is something that is, we just say fluid. It's a decision. It's a medical decision that you'll have to make in the field. This is the type of suture that I just performed. I didn't have to go down through the fat. All I did was close the surface of the cut. This right here is another type of suture that you might have to perform. This will draw, this cut here is down into the fat. It's not to the muscle. When you get down to the muscle, then you have to go with internal sutures. And, well, I don't want to get off on a tangent here. But you can use one suture to close 2 different types tissue. This type of suture here is something that is both almost like an internal suture and an external suture, only you use the type of suture that like silk, cotton, nylon. If you have to, and you have to use, the only thing you have is internal suture, and you can use it to close this type of wound. What you've done is you've taken your first suture like this, and it goes down deep, right here. I'll start from this end, because I got the knot over here. You can run this here. The wound is not full closed yet. Like this, up out of the skin, back down like this right here, run it real deep, run it back up like this, and then you tension it, and it draws the wound down here and up here together. This type of suturing is if you have plenty of time, or if you're very good at it, and you want to make a nice, strong suture for an area that's under a lot of stress or has to move. Because people who have sutures in them still have to move around. We cannot be laying up in a bed for 2 weeks and watching television and eating our popcorn. We have to be able to be mobile and mobilized. Otherwise, you're going to go into a category that you may not want to go into, which is, excuse me, you're going to die. I don't need to suture anyway. Now, another suture that takes a little longer is called a mattress stitch, or it's a running suture. You don't have to take and cut and tie each individual suture line here. You're going to make the holes in the same place, but you're going to make it where you don't cut this each time. Now, say it takes longer. It depends on who's doing the suturing and how long you've been doing the suturing. You may be so good that it makes no difference if you have a running suture or internal sutures or even this one right here. And getting sidetracked here, this is the needle and thread? All right. We have to be able to suture with almost any material. If this is on a woman's head, man's head, where there's long enough hair to get a hold of, which is sometimes maybe a man, sometimes not, and even for a woman, then you can use the hair to tie knots and tie the wound together. The problem with hair is that it's usually oily and the knot comes untied. It's just like playing around with nylon. What type of knot would you, have you ever sutured with hair where you actually tie the wound closed?
No, I just used heavy thread with it.
Has anyone ever used hair on the head to tie, to suture a wound closed? Where you actually just use the tension from the hair to close the wound? Okay, the hair tends to slip. It's a good idea, and it works, and you probably should use a lot of tape, or you actually need long hair. You can't really do it on a man. There's nothing there to work with. All right, we're going to use a piece of needle and thread here because this is what you may be reduced to when you're using suture. And, you can even put the knot in it like you're going to do clothes. But now, I would probably use a pair of pickups, but we don't have pickups because we have the ultra modern medical situation here. The future medical situation. And a thimble would be good on this. I'm going to pull this through. It's almost too far because I don't want to pull that one out. Now you notice I pulled my gloves off, and the reason I did that is gloves really get in the way. However, if I'm out working on a human or even an animal, I will be wearing gloves. I don't think I'm going to catch AIDS from this deer. Depending on where he's from. Nothing's changed. In fact, you can use the needle to help tie the knot. Now this doesn't slide around the body as easy, and I got the knot right on top of the suture line because this doesn't slide that easy. Work it over here like this. Bring this down. Actually, that looks better than the suture. Now I'll put an extra knot in. I don't know how well the stuff slips. Oh, when you're measuring the length of how you're going to cut, you don't want to be chasing this around. You actually start up here like this and come on down and give it a cut like that, and hopefully it cuts it. There I go. All right, running sutures. Suture removal kit. I have one here somewhere. A suture removal kit is, it does contain some instruments, but all it takes to remove sutures is something sharp to cut the suture and something that you can grab onto the suture with and pull it out. The thing that you have to remember about sutures, and I've had it done to me, and I've probably done it to other people that have had suture lines, is that if the knot's right here, and you cut it right there, logical place to do it, and you grab right here and try to pull this suture out of the body, you're pulling a knot through a wound. And you can do it, probably won't damage the patient, but it hurts when you have a knot that goes through a hole that's already healed up. And it's real easy to do. I've had people drag, in fact, yes, I had to tell the nurse that this was not the thing to do because I had wire sutures in the back of my leg, and she cut the suture line and tried to drag a wire knot through my leg. And I can tough it out sometimes, but that wasn't the way to do it. Just go ahead and cut your suture here and grab the knot and pull the suture out. And it will, or it should, come out. If it stays in the wound, or if something breaks, you can't get a hold of it, it doesn't make any sense to cut the person open chasing down something that's not going to kill them. There are a few more procedures that I'll cover quickly on things that you may run across on a battlefield. There's a procedure called a cut down. I'm sure there's other names for it that's even more complicated than that, but cut down sounds real good to me. If a man's circulatory system has collapsed, granted this is not right then care in a mass casualty situation, but it is definitely secondary care and long-term care because you have to get an IV solution in your patient. If you don't get the IV solution in your patient because their circulatory has collapsed, then they're going to die. Because the reason their circulatory system has collapsed is because they don't have any fluid in there, so you have to get it in. Would you come up here, please? Let's see here. You can accomplish a cut down on a person's arm or on a person's leg where you know that the vein is close to the surface of the skin. You will not be able to see the veins in most cases. If you do, then chances are you can start the IV anyway. I personally am not crazy about starting them up here, but this is better than, if this is your best shot, then go for it. You can start them on the feet. You can either, on the feet or on the ankles, any place where there is a vein. You don't want to start a cut down on an artery. It's, once again, you're going to be putting fluid in the wrong direction of the body. Now, there's no way I can demonstrate a cut down without actually doing it, and I know that he wouldn't like this. However, see if I can get this to Come on, in there. Okay, you know you have some veins here, so we're just going to talk about this one. When you do a cut down, you don't want to do you have to go inside of the body, get a hold of the vein, or isolate the vein where you can actually see it, and then put your IV needle into the vein. Preferably, you're using an intercalf because that's what will stay longest. If you collapse this vein, your chances of ever getting the thing started again, or if you blow the vein up, your chances of ever getting anything started again in that particular section of the body is virtually nil. So this is you don't want to waste your time doing a cut down and then destroy the vein. You don't want to try to cut right on top of the vein. You can do it, but you're not going to be stable. You're not going to be rock solid when you're working on somebody. You're going to be shaking. You're filled with adrenaline. You can cut to the side of where the vein is, where you know it is, and if you're not real sure, cut even further over and go down far enough to where, without cutting through ligaments, actually probably right here would be better on this side of the vein, but don't be cutting through ligaments. Don't be chomping into muscle, because the veins are not down inside the muscle that you want to get a hold of. They're right under the surface of the skin. And what you'll do is make a long enough incision where you can pull the skin over and expose the vein. Then you run a needle with an intercalf. That's like I showed you on this tubing, up inside here. And since it is a situation where you may have to move the patient, you can put a couple of sutures in here to close it back up, trying your best not to run it through the vein. You don't want to suture up the vein, but you have to hold this thing in place. You want to put an arm board on this man to make sure his elbow does not bend. If you have it on the back of the hand, and you can do cut downs back here, you want to immobilize the joint. So you have problems with this even if you have an IV in somebody, much less that you've done an invasive type surgery just to get an IV in them. Remember, you do not want to lose the vein once you get it. And things happen, you may have to go down to the foot. The same procedure works just as well on the foot or any place where there are large veins on the person that you're working on. And you should probably know if you're with a particular team, you will know who has big veins and who doesn't. You know your team pretty well, and you know what to look for. Yes?
Where's the need for doing that as opposed to just other intravenous?
Okay. There are times that you cannot, no matter what you do, for some reason, you cannot find the vein in the needle. It's disappeared. It's flatter than a flitter. And if you try to run a needle into it, all it does is skewer the vein, goes right through the other side. Because the vein is actually pumped up like a pipeline, and the needle goes in and goes inside of it. But if it's flat like this, there's nothing to keep that needle, nothing to help the needle go up and actually come inside a vein. If you cut down to a vein, you'll find that the thing may or may not be flat, but it's a lot easier to watch exactly what you're doing. I mean, this piece of surgical tubing that I used to start the IV on, that is basically what you're doing. You've actually got your vein in your hand, or with your finger under it, or an instrument under it, most likely your fingers under it, and you're cradling it where it can't go anyplace, and then you can put the needle and slide it in, you can feel it, and go into the vein.
Is that usually because they've lost a lot of blood?
Yes.
Dehydration would do it also.
Pardon?
Dehydration.
Dehydration, shock, loss of a lot of blood, the neurogenic shock. What it is that your vein system has collapsed, and you can't get oxygen where it's supposed to go, and you can't get food where it's supposed to go, and the blood is not getting up and not circulating like it's supposed to be, and probably not any place in the whole body. Actually, the closer to the heart you can get your IV in, the better off you are on this one. but that's not always possible either. They even have, I say they, the medical professionals even have to do where you have a subclavian cut down where you actually go under this collarbone and you get the vein in here. But that is beyond our, we can't do that. We have to go with our best guess on this one. And it does not always work. This is a last resort, and where a man usually doesn't have that bad of wounds, but his system has collapsed, and you're going to try to save his life because you know if you can get him pumped back up with fluids or blood, then he will live and be okay. Any other questions on this?
Can you hemostat, like if you had to suture a vein or tie off a vein, do you hemostat both sides of the vein then tie it off? If you had to?
Usually the veins that I've had to tie off, it was the end of the line.
Oh, okay.
And I don't know what reason I would have to tie off a vein right in the middle. On an artery, I wouldn't think about tying off an artery. However, if the artery is not severed, and it has a split down it, is the cut where it's a nick. Even though we're not vascular surgeons, if you have a fine enough needle and a fine enough thread, you can pull that close and possibly save the man's limb and his life. We're not talking about great long pieces here because once the artery is severed, it takes vascular surgeons who are trained and have the equipment to do this to reattach them. And that is beyond me and most people I know. Any other questions? Debridement of wounds. And this is a surgical procedure. When you have a wound, or you're working on someone who has a wound, or even yourself actually, there's much dead tissue from the trauma that's been done to the body. And this is not something that we're not talking about debridement, say 2 weeks from now when you know there's a lot of dead tissue around there, infection. It's right then. Healthy tissue is a pinkish and it bleeds and it has sensation. If it is not pinkish, if it's brown, if it looks like the tissue on this deer leg that I was working on, that tissue is dead. And if you don't get it out of the body, then it will putrefy and infections will set in, and muscle tissue, dead skin tissue, any type of human tissue is a perfect breeding place for all manner of germs. We have many ways to take this bad tissue off there. You don't have to worry about hurting your patient. In fact, that's one way you can tell if the tissue is dead. If it is painful, then the tissue that you're cutting, it is not dead. If it bleeds, most likely it is not dead. It's viable tissue. You want to leave it there. You may have to debride later on and trim it back even further. If the tissue is not painful and not the color of the surrounding tissue, dark, whatever, and it doesn't bleed, no pain sensations, it needs to come out of there. Because you can't even think about closing up a wound. Now there's another method for debriding a wound, and it is probably one of the most unpleasant, but when you have large open wounds, a lot of dead tissue, a lot of scabs, dirt, everything in this, if you can get a hold of some pain medication and give it to the patient, even that is not going to stop the pain, but you take scrub brushes and you scrub the wound out till it looks like hamburger. This hurts. You can give a patient, 2, 3, even 400 milligrams of Demerol, and you're working on his wounds, and believe me, 400 milligrams of Demerol is really up there, and he will feel the pain. And he'll be throwing up. This hurts him. But if that's what it takes to save a patient's life, get someone to help hold him down, but you need to get the wound clean, or you can't even think about closing the thing up later on, you're going to be fighting infections for weeks. That's the last thing you want to do is close up a wound that has an infection, and that's the last thing you want to do is to leave dead tissue in there. You know you're going to get an infection. You have to keep as much healthy tissue exposed or as much healthy tissue away from the dead tissue as possible. And this includes the skin around it. Trauma will kill tissue. Someone punches you in the nose or the face and you get a big bruise there, that's because this tissue where the bruise is not healthy any longer. Now, that's not dead tissue, but if a fist will do that, what would a 308 do? It kills it. It kills the tissue. The last subject that I have that is of particular importance is the removal of bullets and shrapnel. I'll go with shrapnel first. That's one of the easier ones. Shrapnel can be a little piece of metal. It can be this large. It flies through the air like a buzzsaw or flips over like someone flipping a pancake. It hits the body and does massive damage. You're going to have a wound to tend. Plus, the shrapnel could very well be inside the patient. If you do not remove foreign objects from the body, even splinters, they fester and become infected, and you have an abscess, his temperature goes up, plus his body will eventually become poisoned. And it doesn't have to be gangrene to kill you. It can be staph, it can be any infection that there is can eventually kill you. Then you're going to have to be treating, if it's just infection, you're going to treat people for shock and all this. It's best to get any kind, if it's at all possible, to get the foreign object out of the body. Even if the foreign object is sterile, it will still cause a pus pocket or a fluid pocket to form around it. And any kind of abscess, no matter if it's sterile or not, will cause the temperature to go up. In fact, one of the attended procedures on this is that if you do have a pus pocket, lance it. Because if you're in the field, you need to get it out of there. You can stuff gauze inside the wound, and maybe leave a piece of gauze hanging out, and that's your temporary Penrose drain, and it's also a way to get the gauze out of the wound. And then you can stuff it with clean gauze, and the wound will close and granulate, and it'll have to close on its own. And you're not going to be actually suturing up a wound in the field that has ever been infected, unless you know it's just absolutely clean. And this is later on, and you're still going to have scars. And it's like a trade-off. Well, do I suture it up and take a chance on having an infection, a renewal of an infection, or do I leave it open and it takes 5 times longer to heal? These are decisions that you'll have to make. Now, when you come to shrapnel, it doesn't go, most of the time, it does not go as deep as, say, a bullet. And you have to probe, stick something inside the wound, and look for the shrapnel. Fortunately, shrapnel oftentimes lies right near the surface. If a hunk of shrapnel this big, though, passes all the way through the body, you don't have to look for it, but then again, your patient is probably dead, because that's a very big hole to have it somewhere. Shrapnel can enter the body like this, and move all the way up here, and you can actually see something right under the skin. If you have a bump here, you might even see an off color right here that looks like, oh, well, this man has a little splinter in here. He might have a splinter that big, but just that little point of it is going to be showing. You don't have to start from here to go up here to find your shrapnel. If it's right there, that is where you're going to open the body and take the shrapnel out. And you start with the smallest incision that you can, a nice clean incision, and open it up. If that small incision will get the shrapnel out, that's what you do. And if all of a sudden the shrapnel is much bigger than the incision, all you have to do is lengthen the incision. This is not a what you call a major surgical operation. This is actually minor surgery that you have to perform in the field. But whatever it takes to get that piece of shrapnel out of your body, get it out. Then you have to irrigate the wound because the shrapnel is dirty. And then you have to, if the conditions call for it, you can close it, but most likely you'll put a bandage on it and wait and see what happens. 2 or 3 days later, if you don't have an infection, you can close the wound, especially if the situation that you're in calls that you don't want to be running around with a giant bandage on your arm. But most of the time you don't close these type of wounds because they're never clean. They're dirty. Now the second type of wound that you need to do probing is a bullet wound. Most of the time, if a bullet stays whole, or a lot of times if a bullet stays whole, it passes through you. If you have an entrance wound and an exit wound, then most likely all the bullet is gone. However, sometimes a bullet calves. It has a calf. It might have several, and you have pieces of shrapnel up inside the wound. You'll probably never get them all out if the shrapnel from the bullet, or if the bullet has broken into pieces, is in different parts of the body. Unless you have fluoroscopes, which is something we can get if we work on it, because fluoroscopes is they used to have in shoe stores where you can look at your own feet, see the bones in your feet. That will work out in the field. We don't have film, but a fluoroscope would work. And you can locate these foreign objects in the body. They'll show up just like a bright light. Then you know roughly where to go and when you're looking for it. But when you can't see anything and you have a wound in your body like this, an entrance wound, and we'll just say it was real easy. The bullet was a small caliber and it didn't go all the way through. You have to look for it. You can use hemostats to probe for it. And this is painful. But if you're relatively gentle, you'll follow the wound channel. Now if the bullet takes, after it gets down to, say, some sort of connective tissue or a softer layer, it might take a right or left, go down or up. But you still have to try to get the thing out, and you can't do that unless you find it, and to find it you have to look for it. You're probing with your hemostats, or you're probing with anything long like this right here. You're probing with something like this, and you can bend this all over the place to follow the wound channel. You're probing with everything except your finger. Sometimes that's all you have though. But once you find something and it's not a bone, because a bone will feel different than a piece of metal. Now comes the tricky part. If you can grab onto it with a pair of hemostats, you're fortunate, and it works out like that a lot of times. A bullet, you have to get out of somebody. Sometimes you can't, but you're going to have to get it out of it. If you can grab onto the end of the bullet, or the side of the bullet, or anything else with a pair of hemostats, clip it on there, it's probably lead, or something soft enough, whatever's left, to clip onto, then you can pull it out of the wound. If for some reason it slips off on the way out, at least you know it's the same direction of where you went for it the first time. If it's calved and you have different pieces in here, you want to save the bullet when you bring it out and look for the different pieces and try to reconstruct the bullet. This is a best guess here. You might have, okay, this bullet looks like it's half its weight. Well, let's find the other half. There's no way to weigh it, but it's like a jigsaw puzzle. This one here goes together, and this one here goes together. Uh-oh, I've got a big piece still in there, and you have to find it. If you get a hold of a bone, like say you have a bullet somewhere in your wrist, and you try pulling a bone out, it doesn't work, and you're going to be doing some damage. If I had a choice of leaving the bullet in until I could get to and take my time on it, or really damaging someone further by ripping their tendons out, I'm going to leave the bullet in there. The bullet, however, almost invariably has to come out because it will produce, even if it's clean, it will produce a pus pocket. And you will have an elevated temperature, or worse yet, if it's infected, you will lose the use of, say if it gets into the tendons or the veins, or especially the tendons, you'll lose the use of your hand. And you have to take all of this into account and say, okay, what should I do here? I know it's going to hurt the patient. That is not too much of a consideration in combat medicine. You have to just consider, well, is he going to hurt me while I'm trying to work on you? Because you have no defense for yourself. You might have a bigger man come and help you, and because when you're sticking things into a human's body, they don't like it. And it is a good thing to put a towel across their face if it's not going to scare them. Say, this will calm you down a little bit. We'll put a wet towel and make you feel better. Yes?
What about a head wound where bullets in the head were pretty close to the brain? You don't probe it out?
Never. You do not touch a head wound. That is something for secondary medicine or follow-up medicine because the head is going to swell up anyway and crowd out, and the person who has a brain injury is going to have big problems. And if you make it worse by sticking a piece of steel in there looking for a piece of steel, the brain is extremely delicate, and you'll wind up, maybe the patient will live, but he will be good for nothing.
How about the neck?
The neck, you can go after it. If the shrapnel is near your carotid or your jugular, and it's got sharp edges, you better beware, because not only do you have to get it out, but you have to protect these two. You might have to stick a hemostat in the side of these two veins and get them out of the way, or use a retractor to get these veins out of the way so you can work on this, because you have to protect these two veins, or this vein in this artery. Any questions on this?
I have a couple suggestions of things that I've used. I've not removed bullets, but a poultice chewed up by the person that is injured. The best one that I found are raisins. They chew up raisins, they keep them moist. I've removed a needle jabbed up in the foot that would have had to have had surgery. Within 24 hours it pulls it out. A toothpick that went up into a little boy's foot, splintered and turned sideways into the way up high into the foot. Packed it with a raisin poultice that he himself chewed up. The person that you put the poultice on has to be the one that chews it with their own saliva. And within 24 hours, it will pull an impaled object out of the body. It sounds corny, but it works.
You also use it on bullets, correct?
Yes.
If it works, and we have someone here who has actually tried this, and yes, I'm sorry, it does sound corny, but we also have someone who actually, they didn't hear it from somewhere, they've used it, and corny or not, medicine is awful corny too. If raisins will take a foreign object, and it doesn't have to be a bullet, if it will help extract a foreign object from your body, it beats surgery any day. Because your body will try to spit whatever's in the wound. And that's another thing. Hearsay is not something that you can count on. But if someone has actually done something and they are a faithful witness on that account, you better be listening, because I'm not sure how to make a raisin poultice. They just chew it up, and how much?
They chew it up so it's real slimy and sloppy from their saliva.
Okay.
A handful of it. Pack it onto the area where the wound is at. Keep it moist. Say you do this in the morning, do it again at night so that it stays damp. Put a fresh poultice on it. And by the next morning, it should have pulled it out. The toothpick, the glass, the needle will be laying right on top of the poultice. It pulls it right out of the body.
But you should put saran wrap over it so it stays
moist. But by the next morning, When you remove that object that was stuck in the body will be laying in that.
Do you cover it with a bandage after you put the saran wrap on it?
No, I want it to stay moist so that it stays damp.
What if you don't have saran wrap? How would you?
I would just use a damp towel.
Okay.
Something damp, even a sock. If it's in the foot, soak the sock in water, put the chewed up poultice on there, put the sock onto it, or just tie it on there so it stays in place.
If you find that it's getting dried out,
have them chew up another one and put a damp one on there.
Do you actually pack it into the wound, or you leave it on
Nope,
top?
just pack it right on top of it. The body will just suck right in there what it needs, and then the body will work with the raisin juice to expel it back out with their own saliva.
Good deal.
It has to be saliva.
It has to be their own saliva.
Well, you couldn't use.
I've never used it any other way. That's the best way that I found to work on it. I've removed glass, needles, and a wooden toothpick that was up inside the foot and was split in two and turned sideways in the foot.
I can bear witness to that too. In addition to that, honey works also, but not quite as well. You don't have to chew honey, push on everything left.
I've used honey on animals when I treated animals as a child. When we would have a really bad cut, they wouldn't cooperate with stitching. I would just clean the wound and then I'd pack it with honey and wrap a gauze bandage around it, and it would just suck everything back together and heal it.
Okay, that's good. There's another foreign body that we have to deal with on occasion, and it is a foreign body in the eye. And this is, very often you run into this. If you have a foreign body in the eye, you can't get them to take this foreign body out of the eye right that second. You do not patch one eye, you patch both eyes, because if this eye is the one you patch, and you're trying to look around with this eye right here, this eye is moving. You don't want the eyes to move back and forth because it cuts up the inside of the eyelid, or it could take and further damage the eyeball. Now, to get a foreign body out of an eye, we'll say that your eyeball, like this, and you have up in here, if this is punctured, if a foreign body is punctured all the way inside the eye here, and you try to pull the foreign body out, your eyeball will collapse. It's a balloon. Even if it's in here, down inside here, or even inside here, you still have the same problem. Most of the time, or a lot of the times, there's no such thing. A lot of the times, you just have a grazing type, non-deep object. And it's just barely stuck into the cornea. Just barely there, but it's sticking out. Or it can just be laying just under the surface of the skin. And there's two ways that you can take this out, and it's not really a surgical procedure. First of all, if you can anesthetize the patient's eyes with something like tetracaine ophthalmic solution. That's what doctors use when they do eye operations. They deaden the eye, the patient is not under, the patient is wide awake. You can take, if it's steel or something with enough ferrous content in it, you can take a magnet and touch it and pull this object out of the patient's eye. Now there's another way, and this one is if you don't have a magnet, it might be a sliver of glass, it could be a sliver of wood, something in there, and let's say you're shaking too much to use the hemostats to get a hold of it, or tweezers, or something like this, or maybe you don't have them, you can take an object like that has a sharp edge on it, and we'll just call it a needle. This bevel on this needle will catch that object. However, you do not take the needle and try to make the object go in this direction. All right, that will embed it further. I saw a doctor do that, and believe it or not, it's my fault because I told him how to get it out with a needle, and I had no idea the man was a psychiatrist. And working in the emergency room, Air Force medicine, and yes, he's in the Air Force too, and he scraped the cornea off the man's eye and embedded it further, And that was my fault because I was talking to, here's one idiot talking to another. I could have gotten it out myself and there'd been no problem. Anyway, you take the needle and you use the bevel part of it to catch this and pull it out in the direction that it went in. Just like that. You don't want to lever it up, you don't want to lever it down, you want to try to pull it out as best you can. Because if this is already in here and you have no secondary or hospital to go to, it might take this part of the eye and deflate it. It is possible, but the man will still have some sort of sight. However, if you leave this in here, it will eventually bury itself in the eye, and he's going to be blind anyway. It's one of those best you can do situations. Any other questions on the minor surgical?
As I say on the back, to reiterate.
Pardon?
On the back, to reiterate, be very careful. Do not just pull in and dig around.
Yeah.
Well, speaking from experience, be very careful of veins and arteries in there.
Near the spinal cord, what would you do? It's near the spinal column.
The spinal column will protect the spinal cord. If a piece of shrapnel, bullet, or anything has already penetrated the spinal column, you probably have, most likely have damage to that, to the column, I mean to the nerve bundle itself, and pretend you're handling nuclear medicine or nuclear, radioactive isotopes when you're working on it. But if you leave the bullet there, it will definitely pus up and crowd out the man's spinal, his nerve bundle, and or rot it away. Now there's a surgical procedure that I'm not even sure. It's on airways.
It's on the same page as shock.
I was involved in a situation a few months back where a young man accidentally shot himself through the hand and it went into his leg. I found no exit wound on the opposite side and I found no blobbing of blood, so I knew he hadn't hit any main arteries. There was nothing coming out of the top nor anything popping in the back. When they took him into the hospital, the emergency room, they chose to leave the bullet in there. It was a 22. It was in the fatty tissue and they just left it. And he seemed to have had no problems or complications with it. They just felt it was better than going in there and digging.
But that was because they discovered it was a full metal jacket.
Most of the times bullets, 22 is a different story. Even some of your other rounds, even 25s, they are not necessarily calving, falling apart. But when a bullet strikes a bone, you have bone shrapnel all inside, and you have bullet shrapnel all on the side. There are sometimes when you just leave the bullet on the inside of the body. Your job is not out there to be master surgical. And if you have to leave shrapnel, well, not shrapnel so much, but a bullet on the inside of the body for other considerations, especially you can go back in there a year later if the man is not going to cash in his chips right then. And if it does become a problem, all you have to do is follow the pus pocket and you know where the drop problem is. That's an indicator of where the bullet is. If you can't find it, wait a while. Just follow the pus. And it'll take you right to the bullet every time.
To assist in the next part of this combat medicine, we're going to have Micah Schreiner come up and help us. If you'd come up at this time, please. Micah works more on the civilian side and is more well trained in this area. However, we'd like Chuck to stay here with us to translate to the military side of the personnel what this is all about.
Okay, what we're going to be covering right now is thermal injuries. And we're dealing with heat and cold emergencies. And most of your burns out there in the combat setting are going to be done by fire or blast. And dealing with the blast injuries, we've already covered most of the trauma. So you're going to be dealing mostly with those techniques that you learned earlier with amputations and breaks and so forth. And but with fire, you have 3 different classes of burns. You have type 1, type 2, and type 3. And I'm going to see where's the chalk here. Get rid of the eyeball.
I'd like to explain something real quick. A blast is not just compressed air. A blast is a giant ball of fire. And this is why you have burn injuries in a blast.
Okay, what this is demonstrating right here is a skin layer. Like this, use the arm as example. So we've got a layer of skin, we have a layer of subcutaneous tissue, and then we have muscle. All right. The type 1 burn is what we mostly, all of us that experience within the household, hot water burning us. You're spilling coffee on yourself, you feel a lot of pain, it gets red. No real damage. Easy to take care of. A little cool water, maybe to help relieve the pain. There's not much you can really do for a first-degree burn. But on the combat setting, you're going to be encountering mostly second- and third-degree burns. It's going to be caused by gunshot wounds will cause burns around the area, fires, who knows what else you might be exposed to, anything that'll cause extreme heat. Okay, so like I said, first-degree burns deal with pretty much just the top layer of skin. A second-degree burn can be caused from, let's use the example of boiling water. Boiling water, second-degree burn will show itself as it'll be bright red. The guy will be in a lot of pain, and there'll probably be blisters. That's a good indication that's a second-degree burn. They may be open or they may be closed. So second-degree burn is going to go through the skin and it's going to get into the subcutaneous tissue. It is not going to reach to the muscle. Okay, so on top you might have some blisters. It's going to be pretty bright red. Now in treatment of this, if the blisters are closed, you can use water. That'll help cool it. And you can put some, preferably sterile dressings, whatever type of dressing that you have. Go and cover it. Maybe add some water, help relieve some pain. Now if they're open blisters, I really suggest that you don't put water on it, just dry dressings. Because what you're going to do, if you're going to be adding water, especially on the battle setting, you're going to be increasing your risk of infection. It's already open. Let's don't dump more stuff in there. Now, if there's dirt and who knows what other kind of debris in an open wound, it doesn't matter. Get it out of there. The water is a lot less contaminating than dirt and who knows what else is out there. And I want to step back just a little bit and tell you, anybody that has a burn, I don't care if it's first, second, third degree, first thing you need to do is remove all clothing and all jewelry, because the natural body's reaction to a burn is to swell. And if it's a second degree or third degree burn, clothes will stick to that wound. And so later on, after the combat or whatever the emergency situation is over with, you don't have to scrub that clothes off of his arm or his leg or anywhere else, and he's not going to be real happy with you. You're going to have to use something like an SOS pad. It's a very terrible thing. So he's really going to appreciate it if you rip off that clothes, take off that watch, take off the bracelet, wedding rings, whatever. Because if they swell, it's going to stay on there, and it's going to compromise their circulation. Especially if they have a big burn in the hand, you leave that ring on, their fingers are going to swell. That end of that finger is not going to get any circulation, and who knows if that circulation is going to come back or not. So that's the first thing you need to do. Third degree burns. This is where you're going to have a problem. There is a good point about third degree burns. Most people aren't going to have very much pain. It's not going to be very much pain at all. All your nerve endings are dead. you're going to see it's going to be black. There's going to be some red spots, some even white charred spots. And this burn is all the way into the muscle. And this can be caused by blast injuries, fire, someone could fall in a fire, all kinds of stuff. And this is a pretty tough deal. You don't want to use water unless there's debris. Once again, with the infection, you want to cover it with dry dressings. And there's not that much you can do with a third-degree burn.
If I may interject, the pain is like you said, the nerve endings are dead inside of a burn area. The area surrounding the burn, you have the other two classes of burn, and you will have much pain out there. But on the inside of it, there is no pain.
You'll be able to see all classes, most likely in a third-degree burn. You'll be able to see a blackened area, and then you'll get red, and you'll get less as it goes out. So you'll have pretty much all three classes. So it's going to be hurting on the outside, but the worst looking part really isn't going to affect them that bad as far as pain goes. But once again, remove the clothing, remove the jewelry, and the problem that you have to watch for somebody with like a lot of burns is dehydration. Your body sucks a lot of water when you're burned. So this person, if you have access to IV fluid, good time to do it if there's a lot of burns. And one way that you can determine the amount of burns on his body is through what we call the rule of nines. That's pretty standard throughout the civilian aspect and the military aspect. Let me give you a rule. Is there? Oh, there we go. That's right. We do have.
Would you like to
we have
walk
some.
in again? Thank you.
Now it's my turn to take advantage of this gentleman. Okay, I'm using this book for reference. Let's see. Your entire head's composed of 9%. So if his whole head is burned, it's going to be 9%. Now, so you can be able to tell that if just his face is burned, it's going to be 4.5%. Now, this really, in the combat setting, this really doesn't matter. It just really doesn't matter. But if you have the idea of the body being certain percentages, you need to know, does this guy really need to sit down here and drink a lot of water? Or do I need to start an IV? Do I need to take him to a secondary facility? It'll give you some sort of example, so I'm just going to give you these numbers. His head's going to be 9%, each arm's going to be 9%, his chest is going to be 18%, and his back is going to be 18%, his groin area is going to be 1%, each leg is going to be 18%. So you can, like the front of the leg's going to be 9%, the back's going to be 9%, so the entire leg's going to be 18%. And major areas that you need to watch for is when you have any burns to your chest or your throat. He's going to be if something's going to cause that much burn to the throat or the chest, he's going to be inhaling a lot of smoke. So he's going to have a lot of problems breathing. If you have oxygen available, good time to do it. Have him take deep breaths. Keep watching him because he's liable to go out on you. If he has a lot of stuff in his lungs, his body's not oxygenating pretty well. So you got to watch out for that, and then that can get into the crite, especially if his whole airway is burnt. Like I said, when something gets burned, your body swells. So if your whole mouth and the inside and your face is burned, everything's going to swell up. So it's a good time to use the cricothyrotomy technique that he showed you.
Oh, let me interject something here. Sometimes people call it trach, we call it crite. Either one of those, we're talking about a hole in your throat.
This is true, okay. That's about it on that one, but thanks. Okay, we've got the heat. Any questions so far on what we talked about? No, it's kind of, yes sir.
I understand that there's should I say a wives' tale, that you should put butter on them?
No, that goes along with the water. Like, it's going to cause infection. I know a lot of people, I've been to a lot of calls. I am a paramedic, so I'm out there, and a lot of people, that's the first thing they do. They want to throw on margarine. They want to throw on butter. They want to throw on Vaseline. Maybe eggs. I haven't quite seen that one. But you don't want to put anything foreign unless you have to. Only on the first-degree burn, because that's just slightly red, and the water will help relieve the pain. But there's no real risk of infection. But anytime you have a burn with blisters, or it's thoroughly charged and it's open, you really want to keep any foreign objects.
How about aloe vera?
Aloe vera, well, then you wouldn't want to use aloe vera until like you're in a more controlled area, because if you're out there in the battlefield, aloe vera is still going to track debris. It's going to stuff from the air, stuff from the dirt. It's still a foreign object. Yes, aloe vera is a great product. It'll help in healing, it'll help in the scarring, but that's when the wound's clean, you know what you're dealing with, you can put some aloe vera, then you can put your dressings and so forth. But that's after everything, when you're a little bit more calmer. You wouldn't want to do that in the heat of anything.
Micah, I've used aloe vera juice and honey, aloe vera gel and honey mixed together. It seals the wounds, nothing else can get in there. It kills all the pain. I blew all my skin right down to the bone and off my thumbs with a torch. Within 3 days, it was healed back.
But then again, you're not rolling around in the dirt, you're not running around, stuff flying, you were controlled.
I still worked at that point in time, but it sealed everything.
Oh, that's I said, it aids in the healing process and the scarring, but...
Aloe vera is aseptic.
Oh, yes, but it will attract debris that will cause an infection.
No.
That's, that's not, your body doesn't produce aloe vera. So if it's there, it is foreign. If it helps or not, stuff's still going to be attracted to it.
Okay, I have a question. When you have any kind of injury in a battlefield setting, the best thing to do is cover that injury.
That's right.
All right. Now, is there any of these injuries here that would be detrimental, worse to have it covered than uncovered? Because what you should do in any field situation is cover it.
Yeah, if there's anything open, you do want to cover it. But like I said, unless there's debris, don't use water. Cover it dry. Cover it dry, remove the clothing. Any questions on the heat?
When you bandage it up, you bandage it up dry, not wet?
No, you try to bandage it up dry. You want to cover it. You don't want stuff going in there. Then once you get to the controlled setting, then you can use more man-made products or natural products, which are great. That's when you're a little bit controlled, where stuff's not going to be getting in there.
If you've got a bad burn, a blast burn that's burned down into the muscle in a battlefield situation, would you still cover that with a dry bandage?
Oh yes, you don't want stuff getting in there.
When they take one that bandage, stick to that when they...
That's why it's loosely. Put it on there loosely. You don't want it tight, because it will stick. Yes?
Micah, when Della's brother got burned over most of his body, and they took him back down to the hospital, they called, what's the burn center in San Antonio? Brooks?
Yeah.
And the woman doctor up there told him down here, don't touch him. Don't put anything on it. Just put a very loose cover over him, and don't do anything else till I get there. And she immediately flew down in a jet and picked him up.
Yeah, that's usually the standard.
Also, with comment that again is controlled, and we're talking combat.
Right.
Right.
Here's something else you can expect when you have blast injuries, burn injuries in a combat or a hostile, very hostile situation, is if you're wearing a synthetic shirt, uniform, socks, boots, anything like this, it will melt right into your body.
Yeah.
You will have, all of a sudden, you have, instead of a nylon shirt, you have nylon skin. Then you're in big trouble because you can't even get to the wound and you have to rip it off. And yes, scrubbing is one thing. We're talking about ripping everything right off of it. And that is something you might think about when you're buying clothing. I know that some of the clothing is quite nice, but cotton's bad enough just because it burns. But nylon, I don't want nylon on me. I don't know if anybody's ever got any melted rope on them. You can't get away from it. It's there, it sticks to you, you can have a blister. If you can imagine a nylon uniform or a 50-50 or something like that, there is a reason why good uniforms are made of cotton for prolonged use. Cotton does not melt into your system. And if it's 50-50, okay, so you only have 50% of the nylon going into your body. That's still not nice to get out of there. So anything that's on your body, like you said, it needs to come off. But you may not be able to get it off. And then here's a man who's taking your shirt that's melted to your body, and he has a scalpel, and he's doing like this, and he's cutting your shirt off. Because he can't even treat the injury until that shirt comes off. And we're not even talking about underwear. Now I know a burned groin is only counted as 1%, but
It's a pretty important 1%.
It's a very important 1%.
Who set up these figures?
Pardon?
Who set up these figures?
I'm not sure. Maybe someone who's been in a back injury.
Would you suggest then that if a clothing is melted onto the skin, that's best to leave it there until you are controlled?
you betcha.
They'll go ahead and stay there and cover it.
Yeah.
There's not much you can
There's
do.
not much you can do. In fact, a lot of your burn injuries, most of your burn injuries, when they, you can hardly go by the percentages. A lot of your burn injuries are not life-threatening in the very beginning. And in fact, these people can almost be in a category 1, depending on how hostile or how imminent the threat is that you could get overrun. And they can go back online. After a little while, we'll say hour, 2 hours, 3 hours, it depends on the patient. The pain will start getting more severe. The fluid loss will start telling, they'll start going into shock. And most of the time, if the blast injury or the burn injury is severe enough, they're going to be in a category 3, which is one of the last to be treated. And if it isn't severe enough, and we're just talking about pain and discomfort, but it's still a life-threatening injury, they can move for a while with the burn. I've seen people walking down a road that has just their entire body's burned. I mean, not their head and what have you, but that usually takes out your eyes. But it takes a while for the shock to catch up with you, especially when you're talking about third-degree burns, because you don't even know. You can't feel it, except around the edge of the burn. And depending on the hostile situation, they might even go back online. These are decisions that actually I would almost leave up to the patient on that one there. I'm not that in need, and none of us should be that in need of cannon fodder. However, if I had a choice between going online or being a category 3 patient, I would be cannon fodder. That's just my way of thinking on that one. Go ahead.
Any other questions on heat emergencies?
Treatment on battlefield, would you give the patient lots of water?
No, not at the time. Not at the time. If you can start an IV, I would. But I wouldn't really give them fluids because, like you said, shock, you're going to feel like vomiting. So that's more of a controlled area. If you can start an IV, I suggest you go ahead and do it then, because if they go into shock, you're going to have a hard time starting an IV, especially if the burns are on the arms and on the legs. Do it when you can. So.
In second-degree burn or a third-degree burn, where the area around the unfeeling part, the charred part, is you're experiencing a lot of pain, but you do think you can save this patient. You would expend some sort of painkiller on him because the pain would drive him into shock, and it doesn't hurt to give people like this morphine. I mean, these people need morphine. These people need codeine. These people need any other kind of pain medication you can come up with.
What kind of shock would that be?
That'd be along the lines of hypovolemic shock, because your body's retracting fluid from itself. So the cells are being depleted of fluid, just like if you're just bleeding out. It's along the same lines. So. Any other questions before we go on to cold emergencies? All right, cold emergencies. On the battlefield setting, most of your emergencies are going to be dealing with your hands and your feet. There's different types of cold emergencies, type 1, 2, and 3 also, as in burns. Type 1 is, like, say, example, your foot, it's cold. If you have a good pulse, your circulation's fine. It's just cold. All of us have been out there in the snow making snowballs. Your hand gets numb. You're like, well, I'm going to go inside and warm up. You can still move it. It's just a little bit numb. It's not too bad. There's not much you can do about that, so just warm it up. Put your hands in your pockets. Hold your hands together. If your hand's really cold, put it in your armpit. Something along those lines. So type 1 isn't really anything to worry about, at least especially on the battlefield setting. Type 2 is your foot's cold, you're feeling a little bit of pain, your pulse is probably a little bit slower, all your vessels are contracting, so your pulse is a little bit slower, Do you guys remember the capillary refill? That'll work on the nail beds, the toes also. See if it's delayed past 2 seconds, which will probably be. In that kind of situation, you need to go ahead and warm it up. Hold it with your hands. Bundle up with wool. Whatever's out there, just put some heat on it. Somebody else can hold that foot. So type 2 isn't really. It's getting close. You don't want it. You need to remove it from whatever's making it cold. Warm it up. It's type 3 that you got to worry about. That is a real hypothermic emergency. You probably won't feel much, except for the area where it's warm and it meets the cold area. You probably won't feel anything. You might not be able to feel a pulse, and you won't be able to detect much circulation from the nail beds of the toes. In this situation, you need to warm it up with water. You do not want to rub it. You do not want to hold it. You do not want to rub it, because what's going on here is your cells are almost all water. The water in your cells are frozen. That means they're pretty much ice crystals in there. So if you're going to sit there and rub that foot with ice crystals in your cells, you're going to be doing tissue damage. Your tissue and your skin and your cells, it's water. So just imagine, ice crystals are sharp. So you're going to be doing a lot of neurological damage if you sit there and you rub. So that's not something you want to do. What you want to do is start off with cool water. Put that foot in cool water. You don't want a big shock. And slowly, a little bit at a time, keep adding warmer and warmer and warmer water. You never want to get really hot. You just want to slowly get the foot, or whatever extremity it is, to its normal temperature. But this needs to be done slowly. And if it's too severe, you're just not going to get back any circulation or any use. If it's too bad, if it's been prolonged too long. So, it
hurts.
Oh yes. You all know how type 1 is. When it starts tingling, it starts hurting. But you smack your knuckles when your hands are cold. It hurts. Type 2 is really going to hurt. That's when everything's starting to slow down. You're starting to get too close, and that's the part that hurts. It's when it's starting to hurt, and then you haven't warmed it up, but now it's not hurting anymore. That's when you need to start worrying. So, on the battlefield, a lot of stuff going on. Try not to let yourself get that cold. It's not like a burn where you really don't have that much of an option. It just happens to you. Cold, it's not an instant thing.
But the cold too is real sneaky. You get your feet, they'll start hurting. Now, this has happened to me many times. They'll hurt. Then pretty soon the hurt goes away, and you don't even know it.
Especially
then
if there's
you
no
come in
stuff
and
on
start warming up, and the pain just about drives you through the ceiling. You've caught it in time yet then.
Right.
But you can fool yourself. You can stay out there and freeze yourself right solid.
Especially when your mind's going a million different directions, especially in a combat area. You're worried about saving your head sometimes more than your cold feet. So it's a real tough one.
If you have a frostbite situation, where it's really gotten frozen extremities, fingers or feet, whatever it is, what are the 1, 2, 3, 4? What would be the best ways to treat it in the field in a temporary situation until you can get to a secondary repair center?
I can tell you I'm frozen. If you have frozen toes and frozen fingers, you're going to lose them, because there's no sense even trying to save them. What they used to do would let them, this person's out of action. If he has frozen toes, sometimes he might get away and the toe will just fall off by itself and he'll just keep right on going. And this happens. I know men in Korea that had been in Korea and they're missing some toes, but it didn't put them in the hospital because they knew that going in the hospital was probably even worse because they picked up all kinds of infections there. But the toe turns black. We had training films on it. I've not seen that type of freezing injuries, but the toes lose all their circulation. They lose all their sense of pain. They turn black. They're brittle, and you can reach up with a pair of pliers, hemostats, or whatever, and break them off, just like they're made of wax. And it goes right down to healthy tissue, and it's not necessarily gangrenous. It's dead. That's how you remove warts from a body. rather than taking a scalpel and cutting in and having some sort of invasive surgery, you can take liquid nitrogen, you can reduce scars with it, take the mold and warts completely away. You just take a Q-tip, dip it in liquid nitrogen, touch it to the wart, and the wart freezes, and then the wart sloughs off. However, there might be some more under there, so you, the next week, or maybe 2 weeks later, it takes a while for this to fall off, 2 weeks, then you do it again. And this is, if we can get a hold of liquid nitrogen, I'm not sure of all the uses for it, but this is a good treatment for certain conditions, skin conditions especially. But that is what your toes do and your fingers do. It doesn't necessarily go gangrenous. That is a distinct possibility, but it doesn't necessarily go gangrenous.
What is the difference between frostbite and freezing?
Well, not much difference at all. But there's different levels of freezing. We went over different stages. Once it gets to a type 3, like you mentioned, it's not a real high likelihood that you can save your toes especially, but you can at least try by slow rewarming. And that's once you're out of whatever situation you're in. This is nothing you're going to do out there. But that's a chance to possibly save something or a few toes.
You have to take,
Once upon a time, I knew a guy that got pretty drunk and lost his shoes and had to do a bunch of walking in the middle of winter. He got some severe frostbite across the bottom of his feet to where he had blisters everywhere. But he still kept his feet and his toes.
Probably got those blisters by those crystals rubbing the muscles and everything. They swell and they're causing blisters.
I changed, it was about 40, 50 below, and the diesel fuel in my truck gelled. And I changed the filter on that diesel truck, and my hands blistered just like I'd stuck them in a fire. My whole palm.
There's hardly any difference between those two types of
And it felt like a burn.
But luckily your hands, and you work with them a lot. They're thicker, they're calloused, so and it hurt.
There's nothing more painful than something froze and starts to thaw out. It like your toes or your hands, it feels just like somebody's pulling your fingernails out. It hurts so bad. It hurts.
This brings up a good point when you're talking about fun things like this. Is unlike blast injuries and these type of burn injuries, cold injuries can almost always be avoided. Have yourself some warm shoes and socks. If someone's feet are starting to get frostbitten or that you're losing sensation, they're just flat cold, they hurt. I'm glad they still hurt because your feet still work. You can take your shoe off and your sock off and stick it in your buddy's jacket up against the skin. Hot pack. Warming up, putting a hot pack around the ankle so it goes all the way through the foot if you don't have a big enough hot pack. Human bodies will warm up someone who is suffering from cold injuries or just cold hypothermia, anything like that, probably faster than just about anything. We don't have warm water enemas to put them into or warm wax or anything else. And I'm not going to... Anyway, 2 warm, naked bodies will warm up another naked body. And this is not something that's funny, and it's something that you have
reality.
to... yeah, it's reality. And yes, the guy will have to suffer jokes for the rest of his life, depending on who it was that warmed him up, but this is the way you save people's lives. I say it's not funny, excuse me, it is.
One thing to prevent frostbite in cold weather, I went through cold weather survival twice in the Marine Corps, is to keep dry. And they made us change our socks about every 3 hours, whether they were wet or not. You take the socks you took off, you take them and pin them under your clothing, and that'll dry them out. And then you don't smell very good after a while, but it works. It keeps you dry. If you're not wet,
all moisture water is a great conductor of cold.
Yeah.
Really a great conductor.
Stay dry.
This is something I noticed people worry about having dry socks to wear through the boonies somewhere when they're going through swamp water. Okay, you put on dry socks and you still have wet boots, it didn't do you any good. You're better off not even having socks. Where you need socks, dry socks, of all places in cold weather. Because your feet sweat.
Another rule of thumb, guys, so you don't have to go through all the frostbite and all that stuff, is always wear loose clothing and multiple layers of clothing.
Absolutely.
Get one size too large boot, wear 2 socks. You don't have to go through that. Dress accordingly, and don't get synthetic stuff.
Old-fashioned wool.
Yeah.
Wool will insulate later you if it's soaking wet.
Ma'am, you had a question earlier.
Well, I was going to say, I don't know if this applies to up here because I was raised in Texas, but in the wintertime my legs would get real cold and I would start having cramps real bad. And when I was a little girl, and my dad always took kerosene and rubbed on my legs, and almost instantly they began to warm up and the pains would go. So I don't know if that would work up here. Like I said.
That warming's probably you're feeling it just on the outside of your skin.
Minnesota will use cayenne pepper.
But it worked.
That would warm up just about any part of your body.
You can take cayenne pepper actually internally, and
As long as it works.
this is not something I've done before, but I've talked to people that have done it before.
What's that?
And cayenne pepper taken internally, either in capsules or if you're real brave, a spoonful of it. It increases your circulation and will provide better circulation to your extremities, and it's actually been used in cold injuries. Yes.
I know people that have had circulation problems in their legs, and what they've done is put their, like say, from the knee down into a 5-gallon bucket of water, and it's about as hot as they can stand it, and leave it in there. Now this is in the home. Leave it in there until everything is dilated a little bit, and pull it back out and wrap it in a piece of like that brown paper we had laying on the table with the deer leg on. This with no ink print on it. Wet the paper. Sprinkle cayenne pepper on it, spread it out evenly, and wrap it around the lake, and put a towel around there. And after about 15 minutes, you're going to go through the biggest heat process you've ever felt. But it starts making your blood circulate again, and it brings your childish pink skin back to where you had problems in the past.
Is the cayenne pepper next to the skin?
Right on the skin.
Right on the skin. And so you take cayenne pepper, put it on the skin, and then put the wet paper on top of that?
Wet the paper down, put the cayenne pepper on the paper so it sticks, just a light coating of it, wrap that around on the skin, and then put a towel around that to hold the heat in.
What he just described will also remove fat in case you want to get rid of your tires.
Better than liposuction.
Yeah.
Another thing you have to watch in extreme cold, you might not have to worry about it here, but in Minnesota where it gets down to 40 and 50 below, you got to watch your lungs. If you run and start, you freeze your lungs and you'll go down right now. You gotta watch that.
You can spit and it will freeze before it hits the ground.
Yeah, so you gotta put something over your mouth if you run. For you're not sucking that, you put a scarf or something over your mouth if you're running. You suck in that cold and you run.
Can't feel it. You really can't understand the cold because there is no moisture. There is no such thing as snowballs in Minnesota, or even up here in certain areas of this, I'm sure, where I would think that the snow is so dry, you pick up and try to, it's like sand. And you pour it right out of your hand. It's dry.
Another thing that happens too is cayenne pepper inside socks. I don't care if you get your socks wet, your feet are going to stay warm.
Keeping off that 1%.
Well, when we're talking about a solution like that, how much cayenne pepper are we talking about on the inside?
Just a touch.
Well, like a tablespoon per each sock?
No, just so you barely see it on the sock.
Like
It doesn't take hardly
No, not much at all. Not much at all. What that does is it cultivates the nerve ends and attracts additional circulation to the area that's been in contact with.
How long
That's what
does
that
that
does.
Oh.
I know guys that had it on out hunting all day and still complain about it when they come back at night, their feet are still hot.
But get used to the taste because a few minutes after you put it on your feet, you'll taste it.
Well done. Any other questions on actual physical injuries of heat or cold? So I'm going to delve a little bit into the other symptoms. of heat and cold. Since we're on cold, hypothermia. If you have a type 3 cold injury, you might be experiencing what's called hypothermia. By the stage your friends or yourself will notice it, you're going to feel pretty drunk. You're going to be in sort of a drunken stupor. You're going to have a real staggering gait. You're going to be walking kind of funny. In that situation, it's usually when you're wet. Like you had said, you need to watch the moisture. Most people that get hypothermia in the cold, they are wet. So if somebody is wet, only thing to do is get off that wet clothing and warm them up, pretty much like you would the extremities. Or you can try this cayenne. I really don't know much about that, but I definitely understand the principle and I see how it could work. Heat emergencies. This is what you'll experience a lot. This gentleman's been in enough places where he can tell you about heat emergencies. But like you said earlier, you need those salt tablets. When you start getting those cramps, your body's begging for that sodium. It really is. And I hope get rid of a lot of cramps, a lot of intake of fluids, constant intake of fluids. Yeah.
Do people, when they get hypothermia, think they're warm? We had last winter we had 3 young men, they were in their 20s, walked out in the woods. Only 2 of them come out. When they found the 3rd one, all he had on was his shorts. They say, you think you're getting hot. He peeled off all his clothes. They found him dead, and all he had on was his shorts.
You get confused when your brain is cold, you're confused.
So you're like in a drunken stupor. You really don't know what's going on. Your coordination's gone. Your normal thought processes are gone.
They do a lot of weird things and take their clothes off.
Yeah, he took his clothes off for him. Only he pulled his clothes off and found him in his shorts, dead.
Yeah, and that's another indicator that someone is having problems. When you have a lowering of your body temperature, your brain is not working the way it should, and you have problems. You're confused. Your brain doesn't work right. I've had a nice touch of hypothermia one time because I stayed in the water too long trying to raise a boat, and I couldn't count. I was very stupid, or stupider. My brain didn't work. It just quit working. All I knew is I could stand there and shake a lot. Yes.
Are you saying that if I get leg cramps a lot unless I take a lot of calcium, if I take salt tablets, that they would take care of the cramps?
That might not necessarily be a problem, especially if you've not been out in the heat. If you've been out walking around in the heat, working a lot, then might be able to tell you that. But if you're not in that kind of setting, I really wouldn't know what to tell you.
I get them mostly at night when I've been asleep and my legs get cold. Even in the summertime, if they get cold, I get cramps.
You can get cramps from a variety of reasons. As you get older, you can get cramps. You overstrain a muscle. Your diet isn't what it should be. Your muscles are crying out for something that you're not getting. You could be letting off the salt because of, say, a heart condition, and your muscles still need the salt. And sometimes it's a trade-off. As far as heat problems go, it's best to avoid these before you even get to them. If anyone, but especially a corpsman, should carry salt tablets with him. If he doesn't have salt tablets, a bag of salt. He should have a canteen with at least a tablespoon of salt dissolved in it. You don't want it so salty that when you give it to the person, they vomit. However, someone that is starved for salt, their body will absorb it, and the salt water will be a sweet thing to them. And it's really grand. Now, when you get down to ocean water, then you're getting awful salty. But even that, if that's the only thing you have, we really don't have to worry about that here. But preventive medicine in heat exhaustion, heat stroke, heat cramps, principally it's if the head is red, raise the head. If the man quits sweating, then he needs to have some water on him to replace the sweat, because your body has over-controlled and you can dump some water on him. But salt water you should always carry a canteen of salt water, and you should take salt tablets. And if you don't have salt tablets, just shake you out a little bit in your hand and eat it. It's not pleasant, but it will keep you from coming down with cramps, stroke, and heat exhaustion. If a man has heat stroke, then that's just about the last stage before death, and his body's worn out from trying to get something that just isn't there, which is fluid. And he's already sweated all his fluid out. His temperature is 104, 105, 106.
Maybe causing brain damage.
Oh yeah, he's already cooked.
Well, all you can do in that situation to try is to remove all of his clothing. The best way to do is hose him down with water, a good wet sheet on top of him with a lot of wind going or fans going. It's about your only hope.
What do you say if the head is red, Noah? If the head is red, this is any kind of shock treatment, and a heat condition is a type, we'll just call it a type of shock, because your body is not doing what it's trying to compensate and get something that it needs, and you've deprived it, which is salt, water, whatever you happen to be doing, heat, cold. If the head is red, raise the head. It might be just sitting, here's a man, he's laying down, here's his feet out here, raise his head up just a little bit. You might want to flex his knee. This is just to get the man comfortable where he has circulation again, but if the head is red, you want to get the blood away from the head. If the head is pale, raise the tail. If a man's face is pale, then he doesn't have enough blood in it. I don't know if you ever see anybody pass out, but they don't turn red. So you don't have to worry about me passing out. They turn pale. And then their body says, I think I'll go someplace where I can get what I need, which is on the floor. This is the way the body, it does everything it does, on purpose. It's not an accident. It's designed to work that way. And your job is to help the body
help itself.
Help itself. Yeah, you are a mechanic. That's all you are. You're not going to save anybody's life.
Good well done. Pick up, elevate the legs, maybe 45-degree angle.
Sure.
Easiest way to do it.
Yeah.
I would like to add one thing. I need to backtrack a little bit. Let's lay some confusion around here. Back on the hypothermia, something real important. Do not give any alcohol or sedatives to somebody in hypothermia, because that's going to depress everything that's already depressed in the poor person's body. So a lot of people say, here, relax, let's heat up some, here's a warm shot of whiskey or something, let's help them out. That's not going to be helping them out.
So the guy that's caught up in the avalanche in the chalet doesn't need the St. Bernard coming with it?
No, that is a big falsity. No, you do not want to do that. Hypothermia is depressing your respiratory system, and that's what alcohol and sedatives do. Is you can just totally put them out. Unless you don't like the guy, and then go ahead and give alcohol and sedatives. Any questions over everything?
What about for hypothermia?
Hyperthermia?
That's the heat.
That's the heat. That's what we talked about.
Hyper means over, hypo means under.
What's that?
Give them some whiskey?
No.
Oh, I see what you mean.
It's true.
Okay. Oh, excuse me, go ahead.
No, that's not any more questions.
All right.
Yeah, from here, huh?
I tell you what, I'm going to talk real quickly on stress, because you'll run into that. And would you look through these three books and find something on phosphorus, white phosphorus? Yeah. You can probably start with the Green Beret manual, the green one on the bottom, right there first, and find something on white phosphorus, because white phosphorus problems, I'm just going to read it to you. The chances of you having to go through the long process of treating white phosphorus burns on the field and trying to keep from burning yourself up is pretty remote. You might get white phosphorus. One thing that you will find on any battlefield is stress. We're not talking about I'm nervous. We're talking about the kind of stress that makes men kill their buddies. We're talking about the kind of stress that will make a man kill himself. or a man get very upset and go running right straight into the jaws of the enemy. Or a man will actually go into a type of shock. He will withdraw. He will lay down and shut his whole system down, and he just wants out. He's not a coward. He's had too much. Artillery will do that to you. It will pound you silly. Even your own artillery hitting way out here someplace, it will pound you silly, overload your stress system, and shut you down. Now, some of the ways that you deal with stress is, the best way is get the man out of the situation. If you don't know anything else, you can't figure out how to get this guy back online, you can't figure out how to get him from doing the weird things he's doing. He might be eating dirt. He might be running around looking for ants. He might be anything. It's some of the squirreliest stuff you ever saw. Stress will do anything and everything to you. He might be hyper. And we're not talking about a little bit hyper. He'll be vibrating like a banjo string. Standing in front of you going like this right here and won't tell you about the U.S. Constitution when you've got bullets flying all around you, and he's standing up there and bullets are going past him and you're down on your knees or on your stomach going, I really don't care about this right now. But this is a type of stress. Another type of stress which you will probably have to deal with if you have a triage situation, mass casualties. You're taking wounded or you've already taken them. There's a good chance you could be overrun if you don't keep as many people online as possible. And a man drags in his buddy. He shouldn't even be dragging in his buddy, but he drags in his buddy. There's nothing wrong with him. He should be back out there on the line. He comes in, gives you his buddy, and he says, Doc, treat him. I will. Okay, I want you to take and go ahead and get on out here because there's a lot of people running around. No, I want you to treat him right now. Okay, I'll treat him right now, but I want you to get on out of here because you're in my way. Doc, I'm going to stay here until you treat this man. No, you don't understand. I want you to go from here and get out of here. You're in my way, and if you don't do that, the man's going to die because you're in my way and you're disturbing me. And he might be dying right now, so get out of here. But this man wants you to work on his buddy. What you haven't told him is his buddy is either dead or he's in a Category 3, and you want him out of sight and back online where he can do the job that he's supposed to do, which is protecting you and himself and all of his other friends. What do you do with a situation like that? If you're fortunate, you can have someone or a couple people bigger than he is that will subdue him until you can slap some sense into him, and literally slap some sense into him, because he's not in his right frame of mind either. You don't want to be transporting him any place because, one, you can't afford to have him lose transporting himself, and you can't afford to spend even a walking wounded transporting someone who's a time bomb on the inside. If you cannot get him back out on the line, and you cannot get something into him like Thorazine or something to calm him down as quickly as possible and get him out of the way, because he will be okay after a while. If he is not taken care of, and I'm going to let you come to the conclusion on this one, if this man is not dealt with immediately, not only is his buddy going to die, I mean that's a foregone conclusion anyway, but you might lose yourself about 10 patients, or you might lose all of them because you're the only corpsman, he's going to kill you. About the only thing you can do on something like that is, if you can't subdue him, you have to kill him. And his buddy, which is Category 3, still goes in Category 3. You're not going to try to save his buddy just to make yourself feel good because you just killed a man that you had no business doing that in the first place. Your security, and you should have security on any type of triage, should have taken care of that, but sometimes you are security. Remember, you carry a rifle. So that is some of the stress, and that is some of the stress that gets you killed if you don't deal with it right then and there. Stress is one of the oddest things. Sometimes it shows up 10 years later or 20 years later. I know a lot of people that have delayed stress. And they're not super dingy, they don't dig in foxholes or anything, you know. Although when they first get into the first stages of it, they're like that. But that is not combat medicine. The stress you have to deal with on a battlefield is even more pronounced and more profound than that. Do you have any questions on stress? I'm going to read you the section on white phosphorus out of this Corpsman's Manual, and you can tell that it's not a whole bunch, meaning that there's not much you can do. These are white phosphorus burns. A special category of burns that may affect military personnel in a wartime or training situation is that caused by exposure of white phosphorus, WP Willie Peter. First aid for this type of burn is complicated by the fact that white phosphorus particles ignite upon contact with air. They catch on fire. You put them out. You take the covering, or however you smothered the white phosphorus, and you take it away from the white phosphorus. If air touches it, it catches on fire again. Superficial burns caused by simple skin contact or burning clothes should be flushed with water and treated like thermal burns. Partially embedded white phosphorus particles must be continuously flushed with water while the first aid provider removes them with whatever tools are available: tweezers, pliers, forceps. Do this quickly but gently. That is one place where a stream would come in very handy. You do not have enough canteens to keep running water on a lot of white phosphorus burns. Firmly or deeply embedded particles that cannot be removed by the first aid provider or corpsman must be covered with a saline-soaked dressing. This is a dressing that has salty water on it, the same kind that comes out of your IV solution, which must be kept wet until the victim reaches a medical treatment facility. The wounds containing embedded phosphorus particles may then be rinsed with a dilute 1% freshly mixed solution of copper sulfate. This solution combines with phosphorus on the surface of the particles to form a blue-black cupric phosphite and phosphite covering, which both impedes further oxidation and facilitates identification of retained particles. Under no circumstances should the copper sulfate solution be applied as a wet dressing. Wounds must be flushed thoroughly with a saline solution following the copper sulfate rinse to prevent absorption of excessive amounts of copper. Since copper has been associated with extensive intravascular hemolysis. An adjunct to the management of phosphorus burn injuries, is the identification of the retained phosphorescent particles in a darkened room during debridement. Note, combustion of white phosphorus results in the formation of a severe pulmonary irritant. The ignition of phosphorus in a closed space, such as a battalion aid station, sick bay, ambulance, may result in the development of irritant concentrations sufficient to cause acute inflammatory changes in the entire windpipe system. The effects of this gas, especially during debridement, can be minimized by placing a moist cloth over the nose and mouth to inactivate the gas and by ventilating the tent. What this means is, if you have white phosphorus get on you, say you even touch you, you have to get the thing away from the air. There are several ways that a person may think they can do that, but if they say that you should use water, that is the best way. If you're using Vaseline or something like this, which people have used before, and the white phosphorus becomes exposed to air, then you have yourself more than a white phosphorus fire. Now, do we have questions on white phosphorus from what I read here that you may not have understood? This is one of these situations that we better be thinking about other ways to do it, because this is the best they have.
And there are a lot of white phosphorus used in battle.
You betcha.
Artillery
Weather beater
shells.
grenades, that's another thing, white phosphorus in CS grenades, the gas combines. That's bad news, that'll kill you.
If a person got hit with white phosphorus and jumped into the stream, say he stayed in that stream for an hour, if he come out, it would still ignite?
Yeah. If he stayed in there for a year, if he comes back out, it'll still ignite. Yes, absolutely. Yes.
The copper sulfate, when I was really young, I had psoriasis really bad. And a lady in her 80s came to my home, and she said, does Carolyn have psoriasis? Because it covered from my knees to my ankles on both legs. It covered different portions of my body. And my mother said yes. And this lady said, well, I had an old German doctor tell me how to create copper sulfate. You take the old pennies that dated back before 1950s, when they were pure copper, put them in a quart jar, a dozen of them, to a tablespoon of vinegar, and fill it up with water. Let it set for a week, week and a half, and it begins to pull the copper. It turns a green color. That creates the copper sulfate. I treated my psoriasis and cured it with that. Now, is that the copper sulfate that you're talking about?
If it's copper sulfate, yes. Now, when you say it turned the pennies green, how did you treat the...
Did you use the liquid?
I took the liquid from that was in
okay.
that had come from the vinegar and the water, removing the copper from the pennies, and I bathed my wounds, my psoriasis with it. It covered my elbows, and in like 6 weeks it was totally gone. Went back to the medical doctors that I had been seeing, and they said they started giving it as a prescription to take the copper off the pennies, because they use copper as one of the treatments for psoriasis, but they'd never ever seen it done that way. And so this doctor in Missoula was prescribing it to all of his patients that had psoriasis. But I had forgotten to tell him that we had to use the old pennies. And if you use the new pennies that have copper and I believe it's nickel mixed into it, it burns your flesh. It will just eat holes into it. So you have to use the old pennies with the wheat on them or whatever it is. It's just
I imagine you could use copper tubing, couldn't you?
something that's pure copper. Put it in a jar with vinegar, and the vinegar will suck the copper off of the whatever item you're using into the water, and you use that liquid to put onto your skin.
That would take care of a lot of problems right there. Copper sulfate is not something I've even ever thought about buying. If you could make it, which would be a lot easier. And you might want to run this formula again one more time.
Okay, you take a dozen pennies, the old pure copper pennies,
Okay.
put them into a quart jar, fill it up with water, and add 1 tablespoon of vinegar. The vinegar removes the copper off the pennies, blends it with the water, and it'll turn it kind of a greenish color.
Turn what, the pennies or the
water.
Okay.
It'll turn it a color. And you take that and you bath wherever the area is, and that puts the copper into your skin that's needed.
Very good.
Can you only use those pennies once? Nope. You can use them again, as long as you use the old ones. Do not use the pennies that came after 1960 or when they quit making the pure copper. You have to use the pure copper pennies.
Find the same weight in copper tubing, soft copper tubing.
Copper tubing.
Yeah, soft copper tubing, and do the same thing.
Yep.
And then you'll have your copper sulfate. There might be other things you can use copper sulfate for, yes?
I believe they use that in farming also to prevent diseases on certain plants.
Perhaps, yes.
So in other words, what you're saying is, if you got white phosphorus on you, then you could bath it in water.
Until you have a chance to take it out.
Okay, then you can take it out, and if it's embedded on you, embedded within the tissue,
Yeah, it'll burn itself into the tissue.
oh, immediately it starts burning into the tissue.
Yeah,
So
phosphorus is,
it's
you have a
great, off you,
bomb,
it's gonna-
a hand bomb that has white phosphorus in it. This is what they, it's extremely deadly explosive. It's also a psychological weapon. And it explodes, burning white phosphorus goes every place. It's on fire, it sticks to you, it burns its way into your body, might even go right into your bone, who knows. It is not, this is really, yeah, it just keeps right on going. And if you're fortunate, it passes through your body. If you're not fortunate, it embeds itself in your body where it can't get air, it quits burning, and you can, what you need to do is, one, keep the patient from being further burned up by smothering with water. And if you can haul them down to a stream, and you should be in an area where you can get to water, that's what you do. And when it gets dark, you don't have to be in a dark room, white phosphorus does glow, and you can find it.
And I'll guarantee you.
And if you miss any,
Yep, take it out.
and if you miss any, you'll find that too, because the patient will tell you exactly where it is.
I'll guarantee you, if you're dug out in the mountains here someplace and they want to get you out, that's what you'll be attacked with, either that or napalm, because it has a psychological effect.
Oh, yeah, by far.
It scares the hell out of you.
Airways are very easy to check. If the man's breathing and he may be in a little distress, but if he's getting air into his lungs, his chest will be moving up and down, and you can hear him breathing, and that's an open airway. Now, there are crushing injuries to the face. A man's jaw may be missing, and a surgical technique that needs to be covered is called we just call it a tracheotomy. May I have you for a second? A true trach is down in here. You cannot do this on the battlefield. You should not do it on the battlefield. It's too close to veins and arteries. And someone's whipping around, and you stick a scalpel in there, you will cut his throat. I mean, the part that bleeds, and that's not what you're there for. You're there to try to get air into the man's lungs. He may have his jaw shot away. He may have tons of garbage inside his mouth. You can't get it all out. He's swallowed his tongue. You've tried different things to clear his mouth up in here. Lord knows what this man has wrong with him, but he can't get air into his lungs. All right. Now, on men, their larynx is pretty prominent, and I'm not supposed to call it a gollywhopper, so I won't. However, this is what most people call an Adam's apple, and you have ridges like this in your throat. Can this be seen? All right. Now, under this right here. Now, everyone reach up and grab your throat. Right under this box that protects things. Like this. You have a gap right here. It's the first one down from this little armored unit that protects your voice box. You have a gap right here. This is where you insert, or you may not have a gap. Seals usually don't have gaps there. However, they have a big giant neck. No, you will run into this problem where it's very hard to find this gap. But you have to feel for it, and you just have a very few seconds to do it. You run your hand down, and your finger down until you find this gap, like this. Now, there's several different procedures you can use, but what you want is a hole in this piece of skin that will expose the cartilage underneath here that runs in between these two, we'll just call them sections of bone. You can feel the gap here. You want to put a hole from here into your airway. And you can use a scalpel to open the hole and insert anything from a barrel of a pen to, let's see, this thing right here actually makes a pretty good airway. If you had to, what I would do was cut it off where it's open. See this? The black part of your ink pen that contains the inside there. Now, you can pull that out, carry that with you. That's an airway if this is open right here. You can put this right in the hole, and granted, it's not as big as this throat or anything, but at least you got air going into the man's lungs. You can take a pocket knife and make your incision and stick this pocket knife in far enough to puncture your way into the airway and then turn it like this, and that opens up the airway. And you know that you've done the right job when there's a great inrush of air and a man is not nearly as much in distress as what he was. And now you have time to find out the problem why his airway is really plugged up. If you can cure that, that's very easy to close right there. He's not going to have to walk around with a tube sticking out for the rest of his life. But your primary job right then is to get air in it. He may have nothing wrong with him other than a mouthful of mud, and you just can't get it out. Open up your airway, then you can work on the rest of it. Do you have anything to add to this one? Or have you ever done this?
No, I have done tricks. IV catheters is what I've used.
Pardon?
How do you close it?
Close it with suture.
The larynx and...
The what now?
The larynx and the outside of the skin.
Okay, they talk about excising the piece of cartilage that covers up, that goes in this gap which is under the skin. And we're talking about a hospital situation here, and I am not sure on the growth time of anything growing back and even recovering. I do not want to take anything out of the throat and toss it, because I don't know how long it's going to take to grow back. And it might just take a few seconds, and if you have a permanent hole in a man's throat, then you have a permanent hole in there. And I don't know, I'm not a master surgeon or even a minor surgeon. You do not want to take something away from the body unless you absolutely have to, because you do not know closure times on this, and he does not need two airways other than his nose and mouth. This is an unnatural airway. You want this closed as soon as possible. And all you have to do is suture it up. You can put a airtight dressing across it if you don't have suture, whatever it takes. However, if you have no suture and you still can't get the mud out, then you will keep this open as much as you can with some sort of airway.
Do you do suture up the windpipe itself, or just the skin?
No. You really can't get into that kind of surgery. This is intricate stuff in there, and you really don't have to.
You don't have to.
You haven't. It should close by itself. If not, people in secondary care and mobile surgical will. You're not concerned with that anyway. People in secondary care and mobile surgical, they'll either know what to do or have to learn what to do. Because combat medicine, you're not concerned with the great amount of finesse. It's definitely mechanic work. Anything else? I'm going to go ahead and discuss an aspect of battlefield medicine, combat medicine, that's called triage. Triage is, in a combat situation, triage usually means you're faced with the threat of being overwhelmed by the enemy. An overwhelming force is going to run right through you, and you have to keep men and women on the line or at work. Oklahoma City, what happened at Oklahoma City is a good example of triage. However, they had it made because they had alternative hospital ambulances, and the only aspect of triage that they really incorporated was right on the spot surgery to get some of the people out of the rubble. And I applaud the way they did it. Some of the things I don't applaud about it because I don't understand why they would have everybody run away, bomb threat or not, when you're right there getting ready to grab a human being out of the rubble. There's something wrong, because somebody, I don't know, maybe they didn't want to, maybe they weren't, we don't want to get sued for this, we'll just let the person already there die, and these guys can run away. And I'm not sure what the reasoning was. It's a pacifistic approach. Someone forgot somewhere that medical people, let's put it in a grandiose term here. Medical people are a living sacrifice to the people they serve. That's what you do. We try our best to protect ourselves from disease, but good chance we're going to come down with something. We try to keep ourselves from doing something dumb like rolling on a grenade, but that happens. In World War II, there were 15 Congressional Medals of Honor issued to naval enlisted personnel. 7 of them were corpsmen. In Korea, there was a total of 7 congressionals issued. 5 of them were corpsmen. In all of Vietnam, I'm not positive about the numbers on this one, I think there was just a total of everybody getting congressionals, only 6 people. 3 of them were corpsmen. Our death rate, our casualty rates, always exceeded that of the Marines percentage-wise, and sometimes number-wise. It depends on who you were with. We had our first congressional before 1900. This is not a wussy outfit to be messing with. I served with a man before I even went to Vietnam. I'm not going to tell you his name, but his unit that he's with, he was a corpsman, had been attacked. Everybody was down, hurt, wounded, and of course they took their toll on the enemy. But the enemy waited there all night, laying out there. Some of them wounded too. They were hurt, but they wait for the sun to come up. Now, number one rule in medicine, and it should always be like this, is you never ever mess with a corpsman. It's not that he's a godlike creature. He's not a happy person to begin with. And you never mess with his people. I mean, I've never seen so many confused Marines as when I got in a fight with another corpsman. They didn't know what to do. If it had been some Marine getting in a fight with me, they'd probably killed the Marine, but I got in a fight with another corpsman, so this is confusing. This is bred into them. You do not mess with a corpsman. Well, anyway, the man that was wounded, the corpsman that was wounded, crawled around all night because someone had messed with his people, and he felt the people's faces. Now, he'd borrowed a .45 pistol from somebody, and he was wounded himself, and he shot, I'm not sure, it's either 11 or 14 men, Viet Cong, during the night to protect his own people. I grew up with heroes, and I served with them, and it's really a grand tradition, but it will milk you of everything that's inside your body too at the same time. It's not a fun deal. We're faced with a monumental undertaking if we go at this without proper medical, combat medicine, secondary medicine, mobile surgical. We can be depleted of our resources by treating the wrong people. I mean, if you have someone that's damaged where you have to use 6 times the normal amount of antibiotics on them, and when you could be using them on 6 guys instead of just 1, wrong decision. That's triage. If you don't approach this is very important, you can win all the battles and lose the war. They did it at Gettysburg. The South won Gettysburg. And they lost the war because of Gettysburg. Oh, that's a great win. I sure like things like that. So it comes down to triage. Your job as a medical person, even if you're not a medical person and you're caught in this mess, to be in triage is to keep as many people online so they can get killed good and proper, is to get them back online as quickly as possible. You have, we'll say 3 categories. Even that is fluid. You might have 5. But we'll just say 3 categories. You have category 1, which is the ones that come in with broken finger, maybe a bullet hole through the palm. He's not going to die. He can get a lot worse, but you fix him up right then, get him right back out in the field. or maybe someone else that you just fixed up, he's getting ready to go back out in the field, but he's cross-trained. We'll have him work on the man with the sight in his hand. You know, let's fix this up. Get him back out in the field. That's category 1. It covers a lot of things. It covers a lot of wounds that you just have to think about it. Now you got category 2. Those are people that if you can get them to a medical establishment, they have hope. And they're going to live. Okay, category 3 are the people who have no hope. They're going to die. They are the last people that you ever treat. They're in a category all by themselves. You got them laying over here. They're still alive, but they're going to die. And you don't expend your time or resources on category 3, because this is a heartbreaker. There's no way to get around it. You do not expend your time or resources on these people right here until you get through with these people right here in categories 1 and 2. And then you go back and you treat the perforated gut wounds and the place where or the man where his whole face is missing, or the man is missing 2 legs. Who knows? You might find somebody to live through this. So that's your last resort. And this is also like, wow, I found one. He's going to live. Oh, great. And it's a fine thing, but you have to be very cold about it. That's another reason corpsmen aren't happy. And EMT, if you ever get involved in a bad situation, this is not a good thing. Any medical people know this. This is terrible. This is unspeakably wicked what you have to go through. However, life is not fair. No one says it is. Someone says, oh, that's not fair. I don't care. It's not fair. So what? Who says it has to be? Now, we come to the problem, which is category 2. I don't know if anybody caught it, but I says, these people who have hope if you can get them to a medical establishment. Well, there is no medical establishment. So what do you do about category 2? You can't transport them to a hospital. You can't land a helicopter. We don't have helicopters. If you're in a situation where you can transport, then fine, you got a category 2. But if you're in a situation where you don't have, and that's principally what this class is about, if you don't have that, there is no medevac, no ER, no OR, no hospital, no ambulances, not even a rubber ducky to get them down the river. You're right there, and you plan for a category 2, and there's no such animal. You got category 1, that's easy. In category 3, you're going to let them die. So what do? Move all these people down to category 3? Well, sometimes you just may have to do that. Category 2, as I said, is fluid, and it depends on the situation that you're in. You may have to take, and in category 2, because category 3, you're not going to worry about that one. Category 1, you already took care of. Now you're going to go through category 2, and you realize that you have no medevac. Maybe it went down in the hills, or the school bus that you're going to use for it broke down or ran out of gas, whatever. You have category 2, and you can subdivide category 2. You can subdivide them, and if you do have a secondary care that is further away from the danger zone, or you find something like mobile surgical. Mobile surgical is still a type of combat medicine, but you at least have surgical procedures there that you cannot perform in the field right then. You have to be able to either turn category 2, some of the patients, into a category 1, and select some of them to go into category 3. And if you do have any kind of transport, whether it be hauling 2 sticks on your shoulder, you need to get them from here over to there. In transport, in combat medicine, you cannot have 4 men on a stretcher, because that's 4 men out of the field. Otherwise, you waste your time with category 1. You can't even have 2 men on a stretcher. Why do that when 1 man can haul either someone on his back, just pick the biggest guy you got, one man on his back, or put people on a travoy, a drag, and they'll haul a patient. You might not even be able to do that much. You might have to subdivide these people into Category 3 and Category 1. And you're going to have some very hurting people in Category 1, but they don't have much of a choice. They can either go up in Category 1 and be in pain, or they can go down in Category 3 and wait to die, because they're going to know what's going on. They're going to understand this. And you'd be surprised how healthy that makes somebody feel when they have that kind of choice. Now, I would appreciate some comments on tourniquets. There's not a whole bunch of hashing out to do on this one, but some comments. If we keep it in the vein that there is no transport. Does anyone have any comments or questions? Silly questions. It makes no difference to me.
One thing that we dealt with was there's an unwritten rule in our platoon that if someone were to be hurt, like when I was hurt, it was understood that if there's an overwhelming force, I'm done. That's all there is to it. Unless I'm ambulatory or partially ambulatory and able to fight on. I think people have to ingrain that in themselves. That it's not something they're going to like. It's going to be a big pill to swallow. But this is hard times. You can't be, well, I'm worse off than him. Because he's saying, well, I'm worse off than him. There's an internal battle going on. So people have to get down to the bare fact that, okay, if I'm ambulatory or partially ambulatory, it's my duty to help someone else. To take care of myself and help someone else. If it's to the point where I'm not ambulatory and I'm going to be a detriment, I help as much as I can and just accept that it's not going to go well.
That comes into triage, because you can use some of your patients to help with the triage as you get them healthy, even some of the Category 2. But you did bring up an interesting point that I want to bring out, and has to do with morale purposes, is that I would never have been in the unit that I was in, and if that anyone had suggested that we leave the wounded behind. Nothing will make you live longer and feel and give you hope to know that if you're laying out there, that these people are actually willing to expend lives just to get to you. You do not leave your wounded. Therefore, it helps your ability to resist overwhelming problems to such a degree that the esprit de corps is what drives the Marines. We lost several men, more than this, several men trying to extract 3 men that most likely were dead. I know that's a bad trade-off, but excuse me, I know that if I was out there, that they probably wouldn't have to lose that many to get to me, but they would haul me out. And I know sometimes we didn't even leave our dead, but there are some times when absolute statements like that are nonsense, because eventually we had to leave the 3 men, but we sure tried, and gladly. You know, it's all, you mean I got to go out and do that? No, let's go. Let's do it. Because you know, your job is to take care of the other person, not to take care of yourself. I mean, you just don't do that. Any other questions, comments on triage? There are 5 classes of shock: hypovolemic, neurogenic, cardiogenic, septic, and anaphylactic. All of these have virtually the same symptoms. Primarily what you're going to be concerned with is the hypovolemic shock. Hypovolemic shock is another way of saying that you've lost too much fluid, and that's all it is. Your neurogenic and your cardiogenic shock. Your cardiogenic shock is there's something wrong, we'll just say something wrong with your heart, and that you really can't deal with in a combat medicine situation. This is a secondary care and long-term care. And neurogenic, the symptoms are the same, and usually when you have, in combat medicine, if you have a neurogenic shock, in other words, you've had a shock to the nervous system, you've lost a leg, you also have the blood loss too. So we're going to get right down to just some simple symptoms of shock. In your eyes, they'll be dull or lackluster, and your pupils will be dilated. Sometimes they in shock, they might be uneven. This pupil will be like this size, and this pupil will be like this size in comparison. That's also indicative that there's a problem with the man's brain. Your breathing will be shallow. You'll be breathing from the top of your lungs like this. It'll be labored. It could be labored where it's very difficult to breathe for this patient. He might not even know it, but you can watch him. Or it might be like a panting dog, where he's actually flooding his system, trying to flood his system with oxygen. The skin will be pale to bluish complexion, cold, clammy, and a lot of sweating. There are different races in the world, and you have to think about this for a second. A man that is very black, he's not going to have pale skin. It'll be lighter in color, but if you don't know what he looked like to begin with, you're going to have to look at other symptoms. A lot of thirst. He needs fluid back in his body. Nausea, vomiting. Unfortunately, on the thirst, if a man is thirsty and he's going into shock, he's had wounds, probably one of the last things you want to give him is something to go into his, like water or anything like this. Because if a man's thirsty, you give him water, he's going to vomit it back up. He can't hold it down. If you have two symptoms, one of them is thirst and another one's vomiting, he can drink the water and satisfy his thirst for a few seconds, but he's going to throw it back up. Another thing, when you have massive wounds of the intestines, anything like this, you don't want to be giving somebody food, water, anything that will stimulate the bowels. Because we discussed yesterday, the bowels, especially if they're outside the body, they're always working. It's called peristalsis. It's where you take the waste material and the rings or the inside of the intestine is squeezing the waste on down the body. So the bowels have to move all the time. And if you give somebody water or Gatorade or something along these lines, it's going to make the bowels work harder. And maybe you don't want them working harder. Your pulse is going to be weak and rapid, thready, intermittent. This man is a sick fellow, so what do you do about it? It depends on what you have on hand. But there's a good rule of thumb that you can use and put it in your mind. And if you can't remember this one, this is what was taught to me in core school. If the head is pale, raise the tail. If the man is pale, get him where you get the blood from the feet and this area to go back up toward his head. And if his head is red, this will be in a different type of situation with, say, heat exhaustion, heat stroke, things like this. Then raise his head. Head's red, raise the head. Head's pale, raise the tail. The best position for shock, position and the way you do this is called Okay, it's called the Trendelenburg position. It's where you have, if the man's, would you hold that computer for a second? Just hold on to it. You might have a hill like this here. You might have a stretcher. You might have anything. The man's head is right here, and the Trendelenburg position is like this. You don't want it up too much because then you overload the brain system and then the heart system, and the man can have heart attacks and everything. But you want it raised up. We'll just say, what's a good?
This is really very. You don't want it too much. But yeah, about like you said.
Yeah, 8 inches.
Normal pillow.
Pardon?
Normal pillow height is about right.
Yeah. And I just didn't want to slash. Okay. Man needs to be. You need to keep them warm. Now I say man. I'm talking about any human. You need to keep them warm. You need to watch over them. If you can get fluids in them from an IV solution, you want to do this, and I'll get into that in a second. There are different. This is something that we discussed yesterday. There are different ways to get the blood from your lower extremities to your upper extremities. We do not have shock suits. A shock suit is it's like a pair of breeches, but it's air filled, and it pumps the blood from your lower extremities. You're laying down, and it forces it up into here. That's what your body's trying to do. It's trying to pool the blood and the fluid up into what counts the most.
Like a G-suit.
Pardon?
Like a G-suit.
Yeah, well, it's G-suit, shock suits, G-suits for pilots. That keeps them from passing out, keeps blood up in their brain, and works most of the time. Sometimes it doesn't, and that's when Coleman comes in handy. This is an aspect of combat medicine that it gets into really strange areas because we have to come up with other ways of treating shock. Here's the problem I see with shock suits. One, you can't carry them around in the field. It'll be secondary treatment or long-term treatment. If you can get them, that's really great. However, it takes special special instruction just to operate one, and just to take one of them off.
Yeah, you can.
2 to 3 hours to take one off.
Sure, this is not a. To me, it's not a good thing because if you have someone that can operate a shock suit, this is fine stuff. However, a shock suit forces the fluid up into the body, and if you take the shock suit off for whatever reason, and you do it suddenly, and suddenly can be 30 minutes instead of however long it takes, you have to watch blood pressure and everything else. And let's face it, you can't do that in combat medicine, but you take it off, all of a sudden all the fluid drops right out. It's like if your blood pressure's low in the morning and you stand up, you fall down. Your body's trying to get the blood where it should be. Well, a shock suit, if you have this up here, even any kind of shock therapy, and the fluid goes back down, you go into even worse shock. And shock is funny. It's and I don't mean ha-ha funny. You spiral down. You can watch someone go down, and they get down about right here, and pretty soon you can't reverse the shock. They're going to die. I could probably spend several days on different aspects of shock, but that's not combat medicine. In fact, even in general anesthesia, you go through several stages, and the last one where they work on you, that's the stage right next to death. Anesthesia is not something that oh yeah, that's real easy. You're that close to death when you're on general anesthesia. Whoever's working on you, if they, maybe just mind wanders a little bit, and you go down just a little bit farther, you are. If you're fortunate, they will not revive you because you're dead, and you have brain damage, and it's the same thing with shock.
you want to, the best way to prevent shock, or the best way to treat shock, is to prevent it. Right then and there, you have the person that's injured, and it doesn't even matter if it's a thumb wound. You're working on them, lay them down, watch them, talk to them, keep them calm, keep them talking. If they're shocky anyway, and you can keep them up to the surface, and they can fight it. Not fight it, they can actually fight this thing. And even when they start slipping under and going to a coma, you keep on talking to the patient because they can't hear you. Don't call it, well, you might want to call them names, get them angry. And they'll remember, and then apologize profusely when they wake back up and they're okay. I can give you all kinds of examples of where people have, a corpsman has walked past an operating table, looked down at a patient, and maybe he's a field corpsman, maybe he's an idiot, who knows. And he looks down and here's a patient laying there with his groin shot away, and the corpsman says, I might even told you about this. Or maybe he says, oh, the man's leg, look at that guy, he's got his leg blown off. And the man that's in the coma will raise up, take a look, and lay back down and die. That's another reason you don't let people look at their wounds, and you don't actually tell them what's wrong with them. Honesty's fine. Being frank is fine. However, a skunk is quite frank. I mean, you know exactly where he's coming from. And it's not a good deal. And being honest, straightforward, yes, mister, you have lost your leg forever. Maybe we can save the other one. It is not a way to approach patient care, even in combat medicine. I don't care how tough the guy is. If he says, do I still have my crotch? And this is very important to a man. And I don't care if he's 90 years old. Do I still have my crotch? Yeah, don't worry about it. I'll take care of it. Just have a little nick down there. He may have nothing down there. And that happens. You don't want to tell this man that. It'll kill him right on the spot. You can send this patient into shock just like that, because a lot of it is psychological. Your body's trying to repair itself. That's why it's pooling the blood up in here, and it takes every bit of brain power that you have, if you're by yourself, to pull your own self out of shock. Now, shock is not an unusual condition because it is quite natural, and it does help you heal. Unfortunately, the body gets to a point where it can no longer control itself. It's just like an elevated temperature. 103 temperature taken orally, that is not a bad temperature, because that means your internal temperature is somewhere around 104, and most of your germs that attack the body, your body understands this, are killed at around 104 tenths. That's why when they do the thing with the milk, pasteurization, they pasteurize it at 104 degrees. I'm not trying to say we should pasteurize milk or not, yes or no, but your body is actually pasteurizing, your temperature is actually pasteurizing your body. And the same with any kind of condition like shock. Your body is trying to repair itself. However, when you get up just like a temperature, if you get up around 106, the body goes berserk. You better be doing something about the temperature, or 105, or even 104. When you get into shock, your body is spiraling down, still working fairly good. The lower it goes, the worse it works, and you do have to have all your faculties in your brain, but your brain doesn't start, it is not working good. You're delirious. You might be talking to your pet dog. You hear unusual things come out of a patient's mouth. And these are indications. You have to watch and listen all the time. And if the body over-controls or under-controls, then it's up to you to take the place of the body's defense mechanism. Keep the patient warm. Keep his feet elevated. Might want to look for other injuries. Maybe you missed something. You might want to get into heroic life-saving measures if you have the time, and try things you've never tried before. Just, if you're thinking correctly, you can. I've heard of people packing sand around a shock victim and working it up like this, where they work the fluid up into the body. I don't know why it wouldn't work. I mean, it's better than a dead man. Did you have a question?
No.
We'll get into IV therapy here in a second. There's aspects to shock that have to be approached in a logical type order. You know, you even if there's a hint that the man is going to be in shock, the first thing you do is two things you do quickly is get him warm and elevate him. Sometimes you can't get him warm right away. There's no way to get him warm, or you have wounds to work on. But get the man's feet elevated. The more gear you have, the better off you are. Let's have some questions and some comments on shock.
Well, I just,
Correct.
because I'm not battle trained. There's actually 9 kinds of shock. And how I remember it is I remember the term shrimp can. It's septic, hypovolemic, respiratory, insulin, metabolic, psychogenetic, cardiogenic, anaphylactic, and neurogenic.
Okay. Well, all of our reference material, we usually just go with 5 types of shock because the symptoms are roughly the same. But thank you. I could probably think up 3 or 4 more.
Yeah.
A new baby coming into the world. Well, that'll get you. All right.
Thanks a lot.
Yeah. I always speak from a daddy position. Okay? All right.
That's for Gordon's benefit.
Yes. Okay, yes. Yes.
What can a person do without any equipment to a patient that's going into a severe anaphylactic shock?
Yeah, but if we don't have any equipment, anaphylactic shock is where, we'll just say you're allergic to something. You've had a snake bite, or someone's giving you penicillin, and you're allergic to it. You've got a hold of some sort of poison in your system, or you have some sort of infection. Now, that's the only thing I can think of, say, for infections, is you're looking for an abscess. Man's temperature will be up, and we had a good example, a man on the ward, had a temperature all the time. We looked for everything. We had IV antibiotics going in him, and maybe we thought it was this. Of course, he had a missing leg from about right here on down. Couldn't understand it. Didn't have any boils, didn't have any open wounds, no decubitus ulcers. However, looking on the end of the stump, it looked just a little bit unusual. And it was hard to spot because the man was black. And he had an abscess. Abscess was killing him. And he was shocky. On something like that, you make an incision and let the pus run out. That is one type of anaphylactic shock. Natural herbs and medicine can cover some of those, and I'm not that well acquainted with it. I would treat the patient for shock and talk to them, keep them awake, and let them fight it. If they can't fight it, they're going to die. If all your life-saving measures don't work, they're going to die. There's not many things you can do. If you're fortunate, he has a bee sting and he goes into some sort of anaphylactic shock from that, and you do have some Benadryl. Benadryl's wonderful stuff. Give them some Benadryl. If you don't have Benadryl and you have stuff called pyrobenzamine, that's a good antihistamine. If you don't have any of that, try anything. Actifed is an antihistamine. Yeah, sure. Anything like that, any kind of cold medicine, it is better than dying. That's some of the ways you can treat anaphylactic shock. And granted, it's crude, but it's, like I say, it's better than burying somebody. Another question.
Chuck, about 30 miles south of us here, there was a dog that got bit right on the end of his nose with a rattlesnake. Mm-hmm. And when the owner came upon him, the dog was kind of limp and just non-responsive. So he and his friend threw the dog up on the fender of the truck, and stuck a spark plug wire on his nose and cranked the truck up. Within a half an hour, that dog was just fine.
Absolutely. Yes. Okay, I'm not going to get into, I'm not going to get into other things you can do with spark plugs. However, what an electric current does, when you run it through, especially a spark, when you run it through a poison, we'll just keep it simple here. It rearranges the molecules, and sometimes it reverses, the poison. It borders on magic sometimes, some of the things that people discover. I mean, how did they know? How did the people that developed this little gizmo that looks like a body shocker that the police use to take down drunks, how did they figure out that, oh yes, I'll stick this on a snake bite and it'll work real good? Yet, they make special little gizmos that have the frequency that they've determined that will help insect bites, snake bites, and things like this, and they put it across the wound, if they can catch it early enough, before it's systemic, and it rearranges the molecules, and it will change the poison where it's not, including insect bites, snake bites. Who knows what all it'll work on, and who knows what all that they've made these type of let's try it on infection. I don't know about the infection part of it, but how can we adapt to things like this? A spark plug on the nose, even though it sounds kind of strange, that if it helped the dog, chances are it just may help the human. Any kind of sparking outfit, a capacitor does produce electricity. Maybe it won't work, but what if it does work and you don't try it? The man's going to die. Like I told some nursing people one time in a nursing home, had a friend who's 97 years old, old man, and he was going to be dying, and they didn't want me to give him salt because it wasn't good for him. And I said, what's it going to do, kill him? He's 97 years old. He's got cancer. If you don't, you have to use your brain. I don't care if it's not good for him, a shocker. The man's dying of shock. I don't care if it's going to mess with his heart. I really don't. If you take a police shocker, who knows? It may alter the medicine, the poison just enough to save the person's life. Because we can't carry around antivenom or any of these other exotic things. If we got them, that's fine, but we just don't. A shocker, I imagine there's people in this room that have shockers. Yes, ma'am.
I've just been reading up on some new medical technology that they've been working on, and they've been doing some testing because they had a couple of cases where people with severe cases of cerebral palsy and MS, multiple sclerosis, were, like one gal, she was hit by lightning. She was in a wheelchair, and she got zapped by lightning, and she no longer has MS.
Yeah.
And so now, and there were several some cases like that where people have gotten shocked, and so now they're starting to do some testing to find out, hey, this is maybe a real possibility because it rearranged the electrical impulses that were sent.
It's amazing what is discovered by accident, or if it works. Go for it. There's nothing. A TENS unit is a little battery-driven shocker that you put on your body, and it puts in a mild shock. No sparks. It blocks pain. Now, I don't know what it would do placed over a poison, because I think it's probably of a frequency that wouldn't do anything. I don't know. But if I had a TENS unit, I would turn that thing all the way up and go for the poison. Who knows, it might work. And that's another thing. Any kind of painkiller will work and help with a shock condition. A TENS unit, if you have a man down here in terrible pain, burned hand or something like that, and the only thing he has is a TENS unit, it's something that's like about this size right here, and it has a couple leads come off of it, and you can set it and put it on each side of the body, each side of like this. You want to just put a block. What it does, it blocks the pain signal from here to here, plus it stimulates the endomorphin system, which is a natural painkiller inside of the brain, which is more powerful than morphine or anything else. So a TENS unit, you have to think on your feet. A TENS unit will help you in a shock situation. You have to, a man is going into shock. If a man is in shock, you don't want to give him painkillers because it will kill him. If he is in a distressful type shock, and he has everything from what looks like Cheyne-Stokes respiration to the O sign. O sign is where your mouth forms an O. That means the man is on his way out. He's going to die. And well, a Q sign is when his tongue is hanging out, and that means he's dead. But that's really, you have to look at things like that. If this is a symptom, if a man is in deep respiratory distress, you cannot give him painkillers because it will cause further distress to the respiratory system, and he's probably not feeling any pain anyway. I've been in a position where I was injured quite badly, and I was at a point, I did not want any painkillers because I wanted to keep a straight head. The pain was good because I knew there was danger. I wanted to know there was danger. I didn't want to be smoothed down in. And we got into an even more dangerous situation, and but I started going into shock. I knew I had symptoms, the profuse sweating, cold, clammy skin. I was getting shocky, and I thought, well, I can go into shock and die, not be of any use, and maybe I'm fortunate I caught it in time, and I had the people with me give me a shot of morphine, and that cured my pain, because I was going in shock not because of blood loss, but because of pain, and that cured the pain. If I'd have been losing a lot of blood and not been in pain, I wouldn't have had them giving me morphine. I just wouldn't have done it. And I would have gone into shock and took my chances with that one rather than kill myself with a painkiller. More questions? Anyway, okay.
You want to tag that as more information?
Pardon?
I've been doing some reading on this too, just because I like to read on all this stuff. But in Europe, they've been doing some experimenting with people that have heart attacks, or the body tries to compensate when you have shock. And I've been trying to think, okay, now if I was out in the mountains and I had a heart attack, or if I started going to shock, how can I stop it, or stop it on my comrade? They've been doing this, starting to look at this in Europe for heart attack victims, and what they're finding is that if they can drop the body temperature, it's like you hear stories where people have fallen into cold water,
sure,
and then been revived a half an hour later. Well, what happens is it slows the metabolic rate and the heart rate. It slows it all down so that you're actually buying time for the person that's, say, having a heart attack. And so I was thinking about, well, now, if it's going to slow the heart rate down, that's going to slow the blood flow down. So if you've got somebody that's in hypothalamic shock or hemorrhage shock, then why wouldn't that work also? That might help. That might be a method, say, if you've got a cold stream or something, where you might be able, or even cold pack.
Here's where, this is a double-edged sword you're talking about here. If someone is bleeding profusely, they are going to go into shock. If you have no way to stop the bleeding, then you could cool them down, pack them in ice, because that will slow down the bleeding if you have no bandages. However, once someone starts into shock, and you put them in cold water, you stop the bleeding, you put them in cold water, you're defeating the body's defense mechanism, because they're trying to get this blood up here and keep it warm and make everything work right. If you cannot stop the bleeding, there is nothing wrong with putting ice on somebody. but one of the principal precepts of shock is to keep the patient warm. I don't know if you've ever jumped in cold water before, but it's not a fun thing. And if you're a patient and you're sick, yes.
Well, the main problem I see with that, if someone's in hypovolemic shock, the last thing you would want to do is slow their heart rate.
Right.
Because the body is trying to oxygenate.
Yeah.
So that's why the heart's beating faster, your pulse rate's faster, it's faint because you're losing blood.
Right.
Your body's working hard to oxygenate. Now, if you're losing blood and you throw them in a cold river to slow the heart rate, then they're already lacking oxygen, and now the heart's not going to be pumping very fast, so you're going to kill them if you put them in cold water. You're going to totally wipe out their oxygen supply to the body, and they're going to die in that river.
Yeah.
So,
Well, yeah, that makes sense. You can use ice and what have you to control bleeding. Water is not a good thing. Yet these are things that we need to discuss because we have to think constantly what would work better. What can we use instead of this? And yeah, water would probably not be a good thing.
A lady asked me to define each one of these definitions, the 5 definitions of shock, and I'm sure there's more than that. And so I'll read out of the book here. Hypovolemic shock, or loss of body fluids. This condition is also known as oleogenic, well, that's a close one, or hematogenic shock. The essential feature of all forms of hypovolemic shock is loss of fluid from the circulating blood volume, so that adequate circulation cannot be maintained to all parts of the body. If you lose fluid out of your cooling system and out of your oxygenating system, then you will go into shock if it is enough of it. And it could be as little as half a pint. It could be sweat. You can go into shock from that. If you lose fluid out of your body, this is too much fluid out of your body, this is an unnatural condition. In fact, if someone has a full bladder and they come in the morning and they go to the bathroom and they're standing up, they have passed out because it's a sudden loss of fluid and they get dizzy and they go down. You have to watch for things like that in the hospital. You have to tell men, no, sit down to go to the bathroom. Because this is a type of shock, or a shock reaction, is when you lose body fluid, you get dizzy, your body says, oh, I'd do much better off laying down. So you pass out. That's a normal and natural reaction. Your body's a wonderful mechanism. All right. Neurogenic shock, sometimes called, I'll just call it shock, results from the disruption of the autonomic nervous system control over vasoconstriction. Under normal conditions, the autonomic nervous system keeps the muscles of the veins and arteries partially contracted. At the onset of most forms of shock, further constriction is signaled. However, the vascular muscles cannot maintain this constriction indefinitely. A number of factors, including increased fluid loss, central nervous system trauma, or emotional shock, can override the autonomic nervous system control. The veins and arteries immediately dilate, drastically expanding the volume of the circulatory system with a corresponding reduction in blood pressure. If you have a pipe that's this big and it's got a pint of fluid in it, and you make the same length of pipe this big, it still has a pint of fluid in it, but it's just not the way it's designed to do. And if you have a major artery down here that is not constricted and it should be constricted, remember shock is a natural state, and then you have the blood that should be up in here trying to help repair you go back down to this larger area, because water does try to seep a more comfortable position or sink its own level, or fluid does. So this is a neurogenic shock, and it's actually where the nerves, where this nerve response that keeps these veins constricted or dilated, whatever, that you have that controls the size of the veins, quits working. The symptoms for the shock are virtually the same, and I really couldn't get into diagnosing which one's which. In a hospital, different story. Cardiogenic shock is caused by inadequate functioning of the heart, not by loss of circulatory blood volume. If the heart muscle is weakened by disease or damaged by trauma or lack of oxygen, as in cases of pulmonary disease, suffocation, myocardial infarction, the heart will no longer be able to maintain adequate circulatory pressure, even though the volume of the fluid is unchanged. Shock will develop as the pressure falls. Heart attack is an extreme medical emergency all corpsmen must be ready to handle. It will be discussed in greater detail, etc. You do have great shock to the body anytime there's massive trauma such as explosions or someone just hauls off and punches you in the heart. You go down on the ground. The symptoms of shock for something like this will develop virtually the same. You can't treat someone for a heart attack in combat medicine. They're category 3, they're probably going to die. For a great blow to the system where there's just a stunning effect, you do have a few minutes to get the person back in order, and that is it's like stunning, it's like being knocked out or something. You can revive someone like this. It's not a hopeless situation on a stern or someone that's had a great blow to the body, unless of course you have a lot of broken bones and wounds, attendant wounds, then you have some problems. Anyone have any comments on that particular part? Okay. Septic shock. Septic shock usually does not develop for 2 to 5 days after an injury, and the corpsman will not often see it in his first aid situation. This is, it may be caused, it may appear during the course of peritonitis caused by internal infection, where you have a punctured valve and you have fecal material inside the body inside the body, however, not inside the place it's supposed to be, which is the valve. It can result from gross wound contamination, rupture of an ulcer, certain types of pneumonia. It's a poison in your system. Your system can't really handle it that well. This is actually not a combat situation. Although if you have a man in combat and he doesn't know that he has this poison inside of his body, and he starts going into shock, you don't really know. You're still treating for shock. It's shock. You treat the person for shock. Anaphylactic shock. Now, you will run into this quite a bit. This is a body's reaction to an outside, let's put it, this type of shock occurs when an individual is exposed to a substance to which his body is particularly sensitive. In other words, you're allergic to it. I have personally seen, where give someone a shot of penicillin. Fortunately, I wasn't doing it. It probably would have scared me real bad. And all I had was just a little bit of penicillin on the end of the needle. And they gave a man a shot in the buttocks. They didn't even inject it. As soon as that drop hit his system, boom, he went into anaphylactic shock. They had to give him something that counteracts this. I think it would be called penicillinase. But he was dead. Now, this anaphylactic shock can be very serious. Sometimes it takes the course of an insect bites you and you're dead. It's sudden, quite pronounced. If you're allergic to bee stings, if you're allergic to penicillin, if you're allergic to tetracycline, these things are very sudden. Your system just rebels at this, and there's nothing that really you can do about this unless you can, I'm talking about finding out if someone's allergic to these type of things. I always ask, what are you allergic to? Do you know anything you're allergic to? Or does such and such make you itch? Or if you're allergic to penicillin, chances are you're going to be allergic to, you could be allergic to anything that ends in a cillin. If you're allergic to tetracycline, chances are you can be allergic to anything that has cycline on the end of it. So this is like anaphylactic shock. Now, a snake bite is a type of anaphylactic shock, but it's not, most of the time it's not as sudden as this. And we've already discussed that there are ways to treat that. Good medication to always have on hand for, if you can have nothing else, Benadryl takes care of a lot of different types of poisons that enter into your body. Atropine is a super medication to carry with you. It's very difficult to obtain, and just for anyone out there listening, it's not something you go down and get from your local drugstore in a timely fashion. And however, you might want to think about it, because there are ways you can get atropine. What other, right.
For anaphylaxis, epinephrine. Now there's two different concentrations of epinephrine. There's a 1 in 10,000 solution, and that's not really applicable for this, but there's a 1 in 1,000 solution of epinephrine. And you can give 0.5 milligrams, and that'll really take care of your anaphylaxis. And that's probably the best drug there is for anaphylaxis. But like he said, it's pretty hard to get a hold of atropine and epinephrine. But if you can get a hold of it, it's a good deal. The best form that everybody here will probably be familiar with is, everybody's heard of those little bee pins. You know, everybody that's allergic, that some people carry those bee pins. Now all that's epinephrine. So if you can acquire a whole bunch of these pins that I'm sure are easily accessible for people who are allergic to bee stings, that'll work for all forms of anaphylactic shock. So that's something that everybody can get hold of.
Adrenaline.
Yeah, that's all it is.
It's a natural chemical that's in the body. Benadryl, you can buy right off the shelf now. You don't have to go to the doctor to get Benadryl. Granted, most of your Benadryl is 50 milligrams when it comes from a doctor, so you take 2 25s.
Well, it's abbreviated EPI. That's this epi. And that's anywhere you buy it. You can just ask for an EpiPen, and most pharmacists, I don't know if you can get it over the counter.
N or the N?
EPI.
There are all kinds of places on the body to start an IV, or to put something into a vein. Back of the hand, those are veins. The crook of the arm, those are veins. You can actually, you can actually put them in places you wouldn't even think of, but you really have to understand your physiology to do that, and I don't have the time nor the inclination to go into more exotic places and put IVs or any kind of solution. You can start at the top of the foot, places like this right here. If a man's in shock, though, it's not a good idea to put your fluids down in here. If you're trying to, well, I take it back. It depends. If you're trying to build up his blood volume, then I guess it would be acceptable if he doesn't have any arms up in here to put your solution down in there. Just a second. Okay. If you have a shock suit or a homemade shock suit on, it makes sense you can't get fluid from here if you've got the fluid constricted in here. The veins are constricted in here. Most of the time, the two places that you could start it, I would actually prefer, especially if the patient's going to be long-term care, you start it in the hand, because you damage the veins when you stick needles in them, and they collapse after a while. It's called infiltration, or you didn't do it right, and it swelled up, and then you go, oh, let's put it out, check another vein, and you always work your way up. If you start right here, and sometimes you do, that's the only place you can start, but if you start right here, and you blow out these veins here, then you have no recourse but to go down to other places like the back of the knee, even under the tongue if you have to, but any place where there's a vein at the surface. All right. When you get ready to, a man's in shock, he's lost a lot of body fluid, and you want to start an IV. And considering these are gold, I'm not even going to take this out of the bag. We're just going to proceed on this one because, granted, I should take it out and make you feel better if you can actually see all this stuff hanging up here. But we ought to start right now pretending when you get to something like this, this is gold. That's all it is. This is one of the most important things. This is the exotic stuff that we come across out in the field, an IV bag. If you want to start an IV on someone, you have to expose the vein first. And this is not always as easy as what you think it is. You can put one of these things around it right here. And let's have you sit up on the edge of the table. The purpose of this right here is not the same purpose as a tourniquet. You don't want to tie off all the blood flow. You want the arteries, which are deeper, to keep on flowing, which will fill up the veins. So you put it on lightly, like this. And what this does, this allows these veins right here to start filling up. You can actually force it up. I don't know if you can see it on camera, but this vein is actually getting larger right here. If you still can't get it up, you do little things like, this is why junkies do that. They want the veins to come up. Yeah, he makes a fist, blood bank, you know, they go like this. I don't know if everybody's been poor, but you go down to the blood bank and you give it this, well, do this right here, and start pumping. And just make the veins come up. You got veins all over here that you can use. Back of the hand, start here, going on up like this right here, even up in here. If you blow these out, you can work up in here. Now, veins are kind of strange. I'll do this before you get used to it. Okay, veins are kind of strange, and are different on each person. Sometimes they're big, sometimes they're little. I've got large veins. I've really never had that many IVs in me. My veins don't roll. That's another thing you have to look for when you're starting IVs. You find yourself chasing this vein all over the place. You got the needle in the man, you had it in the right place, you think it's okay, and you stick the needle in and the vein goes this way. It's almost like it's alive. And so you're trying to chase it around, you're doing all kinds of damage in there. So you need to look for veins that don't roll, something that stays in the same place all the time, or as close to it as you can get. However you can catch a rolling vein, you trap it, and then you run your needle into it, usually from the side. But if you can, start here. If a man's going into shock, he's not going to have much stuff in here, and you're probably going to have to start up like this. But IV therapy, some guys, even if they're in shock or going into shock, they still have nice veins. Men, especially, have huge veins sometimes, and this is really a lot of fun because you say, "Oh, thank you, I've got something I can hit." And the best people in the world at starting IVs will maybe try to start one 5 or 6 times. There's just no accounting for veins. You may take someone, and here's a nurse in here. She's the IV nurse, and she's got this stuff, and she's looking around like this, and this guy's got holes all in him. He's mad. He's looking for a pistol. He's going to shoot this nurse. He's already got her address. It hurts. You know, he's got all these holes in him, and this poor nurse, even though she knows her business, she just can't do it. Here walks somebody, a corpsman, who's never, well, maybe started IVs a few times. He may be able to do it. He may just get lucky. It's really amazing that, I mean, it's like, okay, you need some help there? And a nurse, if she's having problems at the vein, yes, I do, because now she might be a little bit flustered, and you go ahead and start the IV. When you're in the field, that's another reason to do your best to start from here up, because you're going to be shaky. You have adrenaline flowing through you like crazy. And hitting a vein is not always easy, especially if the vein is collapsed. So you try to get the needle in, and this is a... No, oh, I'm sorry. Okay. All right, no. All right, yeah, don't worry. This is a needle. This is also actually an intercap. This is an intercap. But needles from here up usually look the same. And most likely in the field, what you're going to have is maybe a needle that came off a syringe, or it should be going on a syringe, or you'll have what is called a butterfly needle. I'll be drawing pictures on the board here. And that's another thing I'm not going to be breaking out as terms of different types of needles, and this is a 23 and this is an 18. If you have a 13 gauge needle, you have a cannon, and if you have a 23 gauge needle, it's a little bitty thing. You don't want to give somebody a shot in the buttocks with a 23 gauge needle, and you don't want to give somebody a shot even with a 13 gauge needle, 18, 20, something around there. And with IVs, actually the smaller needle you can get away with, unless you're trying to pump a lot of fluid real fast into their body. What would you say would be a just all around?
18 gauge is the all around standard needle.
Yeah. You don't want to try to run a 13 gauge needle into someone's vein. All right, you can actually use those for a trade. However, you'll probably have access to butterfly needles, and if you have no other needle, a 23 or even a 26 gauge needle will work. You might have to put pressure on the bag to help the bag along. A needle is built like this. The base is down here. This needle is hollow, and it's beveled right here. They actually got the design from needles from vipers. I mean, okay, if a snake can inject poison into you, why can't we inject good stuff into you? And this was the idea for needles. At least that's the way I studied it. When you start an IV on someone, there's a right way and a wrong way. Hold this for a second. This is actually an intercap needle, and I'll go over the way you use one of these, but any kind of needle will work. Butterfly needle, which will look like you'll have your needle here, and then you'll have a couple of tabs on it, like this. Of course, the butter will come out here, and the IV tubing will go in this.
Good for children.
Yeah, good for children. They use them in hospitals. They're great for children. You use these tabs right here. It's a good thing to hold on to, and you can tape them to the body to keep the needle from flopping around, which will damage the vein and cause it to infiltrate. When it infiltrates, the fluid keeps on going to the body and everything swells up. The important thing to remember about a needle, and when you're starting an IV, this bevel, here's the arm, and your veins down in here. You've got to get to that vein. Your needle comes down like this. Actually, it may or may not be at that angle. You're going to have to, it depends on how deep the vein is. The bevel, this part right here, goes up. And there's a very good reason for this, because if the bevel is down, you can cut a nice piece of a piece of skin out, and it'll plug the needle. Right? I'm not sure the mechanics of why it doesn't do it in this direction, but it doesn't do it in this direction here, most of the time. This is one of those points where it's not an absolute deal. And the bevel always goes up. And another important thing to remember, when you start an IV on somebody, you don't go this direction, you go this direction. Your body radiates away from the heart, and that's the direction that you want to put the needle in. You don't want to put it in going the other way. You get all kinds of funny things that happen inside the system. We'll say there's a lot of current in your system, and you want the, because you're going to be starting in the vein, you want the fluid at least to have a chance to be hit in the right direction without changing direction inside of your body. Okay, the needle goes in. When there's no way I can actually show you on a human being without getting in trouble with that human being. So it comes down to pretend time. I can't even show you on an animal because there's some strange people out there that don't want you doing things like that. You might distress that poor little animal and it won't give milk. You want to hold this vein? We can do it the other way if you want to. And just lay down on the table. This is the inside of a man's arm. I mean, this is a man's arm right here. Just like this. Can the camera even pick that up? Okay. Rolling veins are like this. You go to stick the needle in. Here's your needle. Here's a better needle. Here's your needle, and you go stick it right in on top of this vein, like this, and this vein goes over here. And there's no way you can get it in. Or you stick it on the skin, and the pressure on the top of the skin, as soon as you touch the skin, which is up here, this vein goes over here like this. Or it goes over here like this. So you have to chase it down. Now there are ways that you can trap this vein, and if you can trap a rolling vein, then you can start any idea. You can put pressure over here, you can stretch it out like this, right on top of the skin, where you give it one of these right here. It's much easier to catch. And actually on a rolling vein, what the IVs that I started in hospitals and on the field, when you have a rolling vein, it's easier to start it from the side. You go down into the skin, and then you stick the vein from the side. But if you have to start many IVs, it's whatever works to get the needle inside of the vein. That's one of the reasons you start from here, if you possibly can, and work your way up. Then you take a needle, like so, bevel up, like this, and you have a trapped vein. And it's good to trap even a vein that doesn't roll, like this right here. You have a tourniquet, not a tourniquet, a tourniquet. Something to stop the blood flow on the man's arm. And you stick the needle in, like so, inside the vein. Feel it go in. Now you come to a point where you're inside the vein, maybe even halfway inside there. Sometimes, if that was real good, and let's go a little bit better, and let's get that thing all the way through there, and what you do is you have a situation come up like this, it keeps right on going and goes to the other side of the vein. Now you have to start all over, or you can actually pull this out here, and now you have infiltration into the tissue. You've ruined your vein. If this is the best you can do with the needle halfway in, then that is what you do. Now this here is an inner cap, and you can actually pull the needle out. This is your needle, the one that you saw go in, and this right here is not going to puncture the vein, or it shouldn't. And you don't have to worry about the thing flopping around and tearing things up. This is actually an elastic type of tube that's in the vein. This is probably the best thing you can use. However, we don't have the best thing we can use. We're not going to be reduced to using rattlesnake heat, but this right here is by far superior. Something like this. If you can get away with using a regular needle, do it, because you're not going to have long-term care to get a man out of shock if all he needs is 500 cc's of fluid. And this is great for long-term care because you don't have the type of reactions that you would with a needle, and you don't have type of complications where someone gives one of these when you're not looking, they have their arm tied to a board, and maybe he doesn't like that arm tied to a board, so he takes the tape off and goes, oh, this feels better, and then you have to start an IV over again. Comments on this?
You might want to mention the flashback, because I didn't know what.
Oh, okay.
And the
yeah, I'll get
description
to
of
that.
the infiltration.
Yeah. Now, you have the needle in the patient. This all happens within seconds here. You can't, the needle has to fill up to here, and it'll come up. You'll get the red stuff coming out. That's another way you know that you're in the vein. The blood comes out, and it'll come up to the end of the needle, and actually it'll start dripping out. Depends on if you don't have the rest of your gear set up, and you get things kind of backwards. All right, now, I've got it backwards right now, but that's all right. You have an IV bag here that is, yes sir. Okay, maybe we should just go ahead and take this apart. It's leaking. Yeah. Or maybe that's my water. Okay, never mind, I'm not going to take this apart. All right, you have an IV bag here, and you have this is your, I'll take this off. IV bag, IV bottle. Bottles, or actually, bottles that look like this right here. We'll just say it looks like that. That's our IV bottle is made of glass. It's not the best thing to carry out in the field. It breaks. That's all she wrote. A bag is easy to carry. It's lighter. And this is the bag right here. Now, on the bottom of your bag, you have a couple of tubes coming down like this. Your IV tubing, I'm going to have to take this apart. Your IV tubing, you pull this off. Your IV tubing, we'll just say this is your IV tubing. It has already been plugged in here. You let this right here fill up with the, you let this right here fill up with the fluid. You don't want air bubbles in it. And it's ready for injection. It's not going to be squirting out because your bag will be laying down. You'll lift it up long enough to let the fluid fill up the tubing. You can lay it down. You don't want this flopping around in dirt. This is a sterile situation here. IV tubings are made where you can fill them up and they're not going to squirt the rest of the tubing, the rest of the fluid out all over the place. This is full of water, full of IV fluid, and you have your needles in here. Everything this is ready to go first. This is the way you get your IV bag ready to go first. You put this in, the needle into the vein like this, and you hook up your IV tubing, because you had to let the blood back up to here. Hook up your IV tubing, and then you can take your we'll call it tourniquet off, and you're allowed the fluid is allowed to flow. This is correct?
Yeah, all tubing will have a little thing you can spin, and you can let the fluid slow down or speed up. So
you'll have a drip chamber.
Right, but
you'll have a drip chamber.
You need to squeeze that drip chamber to get it. You need to squeeze it a few times to get the fluid down.
Yeah. You can control the rate of flow on an IV from a drip chamber. We're not going to have machines that'll do it for us. I don't even trust machines that well because they do go gazage. A drip chamber is a clear plastic tube that almost looks like this right here. And it's filled with water right down to here. And you have a small needle that comes out at the bottom of this right here. Excuse me, it's inside the drip chamber. And there's drops that come out one at a time. And this is how you time your fluid. If it's coming out like a garden hose, it's coming out too fast.
What is it? Is there a good basic count that you can do for the amount of drips? So
about 1 every 2
fairly accurate, or what's best?
Well, About 1 every 2 seconds will keep the vein open. Anything less than that, the vein's going to
not
close.
enough.
So it needs to be at least 1 every 2 seconds.
Keep the vein open situation so you can get them to a different place, because they're going to have extensive IV therapy, and maybe IV therapy from fluids and IV therapy from drugs. In a shock type situation, you want to have, I don't know, what would be
the rule of thumb is for every milliliter or cc of blood lost, you need to replace it with 3 milliliters of fluid.
Talking about the drip rate on that.
Oh,
If you did 1 second, would that be fairly good?
yeah, right. Now, if somebody's just bleeding out, you really need to give them fluid, then you can turn it what's called wide open. You can just open up that valve and just let it pour. Just let it pour. But you always got to be constantly watching that site, because if there starts to be a ball forming or starts turning blue and you see it spreading, well, you need to take out
infiltration. Infiltration is one of the biggest problems with IV, is because for no reason at all, maybe 10 minutes after you started the IV, it blows on you, and then you have wasted the fluid, and you can pump a bag of fluid into someone's wrist, and it's not even in the vein. And yeah, the body might eventually absorb it, but the object is to make the blood volume get bigger, blood volume expander. And you can use this with whole blood, which we won't have in the field because you have to keep it refrigerated. But there are ways you can get around that, and I'll get to that. Your drip chamber, you can time it, and I would anywhere from keep the vein open to, we'll say, 120. 120. You're not an IV therapist, and 120 drops per minute, that's 2 a second. You use your watch to time it, count it for 15 seconds and multiply by 4, count it for 30 seconds, multiply by 2. You hold your watch right up behind the drip chamber, and you're counting the drips and watching the second hand go around. Yes?
How serious is it if you get air in the vein?
It can be quite serious. It's not like you get a little bitty air bubble in and the person dies. Now, he's going to have air in his veins anyway. He's got an open wound, and just the action of the system can suck air into the body. I've heard all kinds of, you had an air bubble and the man died. It killed him right just dead. And that is not so. It can cause a clot, and the clot will kill you. But it takes several cc's of air. What were you
It takes about a completely empty line, about that big, to really cause any damage. Your body's not as sensitive to air as people sound, but yes, you can. It's called air embolism, but it takes quite a bit of that IV tubing. And you really have to try to do it on purpose.
The only accurate thing that I ever saw about air going in was on a movie, and a man wanted to kill himself. He was kind of dingy, and he had an IV bag, and he pulled the tubing out, squirted the water out. They didn't show how he got air back into the bag, but he plugged it back in with a full bag of air, and he reached up and went like this and squeezed it. That killed him. And 250, 500 cc's of air into his body, and your body is made to use blood for a circulatory problem. And granted, the blood goes through your lungs to pick up air, but that is not the way it's done. So if you have air into your system, in a great amount, an IV tubing, I forget exactly what, 10 cc's, 20 cc's, you don't want to inject somebody with air, but an air bubble, we have air bubbles all the time in IV tubing. If you're worried about it, just start tapping on it and run it up, back up to the IV tip.
In a combat situation, just because of gravity, don't you have to have the bag above the patient?
Oh, absolutely. In any situation, you have to have the bag elevated.
Well, for a tactical end, wouldn't a small handheld volumetric infusion pump be a better solution?
I think just grabbing a stick in the woods and hanging it on a
perhaps.
stick would work.
What I would rather have is an ER on my back. But an IV bag is what we're going to have. I'm serious, really. We're going to have IV bags. And I can't express enough that we are not. If we do, great. I'm happy if someone walks in. I've got a Bennett at home. I bought it for $25. Lord knows how much that thing is worth. It's a pressurized breather. That is great stuff. I can't pack that on my bag. You got out in the field. You got to plug it in someplace. But I have it there. You know, I might be able to use it. But we are gizmo-oriented society. And the gizmos are going to be killing us, and we're going to be try to save our life with gizmos, and we're not going to have the gizmos, so we throw up our hands and say, oh, let's just go suck on the barrel of a gun. That's a gizmo enough for me. We have to improvise, and this is just saying, yeah, this is all you're going to have. In fact, if you only have one thing to carry, and there's different type of IV solutions. There's D5-and-W, D10-and-W, Ringer's lactated, all Super Witch's brews, all kinds of things to carry. If you're going to carry something, carry whatever you got, but just normal saline. This is the salinity of your blood. It has probably a longer shelf life than a lot of them. But if you only have Ringer's lactated, carry Ringer's lactated. If you only have D5-and-W, carry D5-and-W. D5-and-W means dextrose, 5%, and water. The 5% dextrose, it has all kinds of different therapeutic actions. Ringer's lactated, I'd almost have to read a label and go through all the different chemicals it has in that. It's for certain different types of things that go wrong with the body that they use in hospitals. However, it is a good blood volume expander, and it's not going to kill you. Normal saline is probably about the best we can do. And this covers everything. This is it. And a 1,000 cc bag is not that's great for hospitals, but it's not a good thing to carry in the field. If you have to put 1,000 cc's in a man, and say you had to use 2 of these bags, that's 1,000 cc's. Now you've got none of the 1,000 cc bags, or 1,000 milliliter. Excuse me, I'm from the old school. cc's. Cubic centimeters. If you have 1,000 cc bag and you put it through this man here and you need some more, you're going to have to use another 1,000 cc bag. This is gold, 500 cc's. That might pull him out of it. That's all you want to put in the fellow. Because even if you only use 200 cc's out of this, this is gone. It's history. And I would rather save the 1,000 cc bags for something else. If that's the only thing you can get, the only thing you can carry a 1,000 cc bag. And if it's, that goes without saying. Yeah.
How many different types of IV solutions are there, and what would be the types that we should try and obtain if we can get this?
I have no idea how many different IV solutions that there are. And you should try to obtain mostly what you can get, because even if you don't want to use it in a combat situation, an IV solution is gold, and you might have the situation comes up where that particular IV solution is the only one that's going to work. But normal saline, which is 0.9% salt, and the rest of it's water, it's salty water, that's all it is. This is what you get. If you have Ringer's lactated, get that. Any of your D5-and-W, D10-and-W, that's dextrose, sugar, and water. One's 5%, one's 10%. Get that. Yes?
You mentioned shelf life. What is the shelf life on?
I have the faintest idea what the shelf life is on this. This is July 96 right here.
Yeah, they last about 3 years.
Yeah.
Most of them. And the best fluid that's easily accessible, it's going to be 0.9% sodium chloride. So if that's the fluid you're looking for, that's probably the best all-around fluid.
And
0.9.
That's what they put in animals.
But even if it has an expiration on it, don't be concerned about it.
Yeah.
We'll look at the bag.
Yeah, this has an expiration date, July 96. In August 97, if I had this IV bag here and I've got someone who's dying, what am I going to do? Kill him? I'm going to give them this. Even if it's 10 years old, this is what I'm going to give them. This expiration date on this is to cover their tails, and that's exactly what it is. If it's sterile, if it's sealed and it's sterile for, because this is just salt water in here, if this is sterile for a year, It could very well be still for 100 years. If the bugs can't get in to make it unsterile in a year, the chances are 100 years down the road. Now, when you get into IVs that have other medications in them, the shelf life on the medications that's in there, let's face it, water is good for a jillion years. It doesn't do anything, it just lays there. It doesn't, if you want electricity to it, you can have hydrogen and oxygen out of it, but that's just about it. Even if it comes out of a toilet, a used toilet, you can take that water and make it clean again, and keep it clean forever. I'm not saying you make IVs out of toilet water. You want to try to get a hold of this stuff here. Yes?
I think one thing we should keep in mind is that this is atomic medicine.
Absolutely.
The key to KISS system is the utmost.
Yes.
And that you have to keep in mind at the beginning, you're in a combat situation, you may have egress at any time. And if you're in the middle of, when I had my AV done, they were running.
Yeah. Oh, sure.
And you have to have people that know, like I had to trust my teammates. Because if I didn't trust my teammates, I'd be beating the bejesus out of the corner with my weapon.
Yeah.
Keep in mind that, okay, you've got to have confidence in yourself and get practice on tubing. Just get it done.
Yeah.
You know, if you have to prepare it later, but not too much later. Just get out of that zone. Fire. Time. You can't get too intricate, is I guess what I'm saying. If you have an infusion pump, super wazoo, but you're probably a mobile station.
Yeah, I'll translate here in a second. Go ahead.
Kids keep it simple, stupid.
Yeah.
But what I was going to ask is, if you can't get that saline solution, can you make it?
You can make the saline solution. The sodium chloride or salt that goes into it has to be sterile, or you can sterilize the solution after you put after you make the solution. It's 0.9%. That's normal saline. That's the salinity of your body. However, how do you get a sterile solution into something like this? Now, we may be reduced, and we have to figure out how to do this.
You got the additional port right there if worse comes to worse.
Yeah, this right here is for adding medications, and I don't know what you can do.
Oh, you can do all kinds of stuff.
Yeah, but this right here has this right here has an additional port, and it has a little piece of rubber across the top of it, and you can add medications to the inside of this bag. That's why it doesn't really matter what kind of IV solution you have. You can make your own up inside the bag. However, John's question, and which has crossed my mind more than once, is how do you make an IV bag and an IV bottle in the first place? We can use water bottles, we can use pop bottles, we can use all kinds of things. I would suggest staying away from plastic pop bottles. They're, the big 2-liter thingies. This is going inside your body. It's bypassing every single filter that there is in your system. If you put something that's an infection, that is carrying an infection, even a mild one, into a human, it becomes systemic right then, and you have a good chance you have killed them, or you're going to use up terrible amounts of medications trying to undo the damage that you've done. If we can develop IV bags, I would be one happy corner. But this is something that I'm not even sure I want to speculate on this, because I don't want someone going out there and, oh yeah, this worked, Fluffy didn't die. Well, we're not talking about Fluffy here. We're talking about humans. And this is something that the audience that I talked to a while ago could help up. We need some ideas on just how to make IV bags, on just how to fill them up. Bottles, glass is a great stuff, glass bottles, a glass IV bottle is not the greatest thing to carry in the field, although they did carry them. They didn't have plastic bags like this in World War II in Korea. Well, I don't know about Korea, but I know they didn't have World War II. They had these things right here. And you can carry them. You can carry anything you want to.
Yes.
Only you have the glass bottles as opposed to the bags, the bottles have the vents somehow, do they not?
Yeah, they have an intake valve on them that lets them fill it with air, and the bags just collapse. It's like these Playtex nurseries, as opposed to a regular glass baby bottle. You have to have air that goes into the system.
You may just hit something there, fellow.
Yeah.
Latex nurses might be means to do.
Sure, this is
small.
Yeah, we have to use them
a third of the size of that, but those Playtex nurses with the caps, bottles, and everything, one full set of them might be neat.
Those
Because they don't take up much space.
Those can be refilled and they can be boiled and sterilized. That plastic's not going to melt.
We're trying to do some experimenting with microwave. Just about everybody has a microwave. Unfortunately, I sold mine because I have other ways to do, cook food. But microwave is a good way to sterilize something. I mean, you can't sterilize metal instruments in a microwave. I guess you could. It's not good for the microwave. But a microwave will sterilize something. I personally don't think it's good for food because it destroys a lot of things it shouldn't destroy, and you're actually eating for nothing. However, when it comes to sterilization, I want it to destroy things. But then again, you have to worry about will it destroy the bag. Depending on what kind of solution you have in here, is it going to change the solution? Because you're hitting it with something that is one of these science fiction deals. That's why they call it nuking. You're hitting with microwaves, and microwaves are used for all kinds of things. And some of them quite nefarious things, good words you came up with, unspeakably wicked. Yes?
What's the temperature on that? Can it freeze? With the salt in it, it won't.
I imagine it's not enough salt. I imagine it freeze.
It would freeze?
Yeah. You have to, in a cold weather situation, you have to watch all your medications and all your things like this.
So that'd be something
you
you have to
you
wear
can
next to
carry
your
your
body.
IVs next to your bodies, and that's what I would do anyway. And if you have enough IVs, I would actually split them up and don't not put all your eggs in one basket. And because I let my Marines carry a bag or two, and granted I carried my medical gear, but you can never have enough. Yes.
Will it hurt if it does freeze?
I wouldn't think so. I might break the bag, but the bag is pretty much,
Off the bag.
Or what kind of solutions do you think it would hurt if it froze? Would it hurt ringers?
No, and I don't think it'll affect the bag. There's enough air in there.
Yeah.
And those bags are pretty flexible.
Yeah.
So unless there's a leak, if there's a leak, don't use the bag.
But it will expand if it freezes.
Right, but there's enough.
Yeah, this is flexible. It will push out and
maybe pass it around and get fuel.
as far as catching it someplace, you need to get down below the frost line where it doesn't freeze. You may not have IVs in the field, and worse yet, you may need to give the patient whole blood. We can't carry whole blood around with us. And there are principally 4 types of blood, A, B, yes. Okay. Anyway, these do not mix together. Blood from one type will not mix with another. And so if I just walk up and I say, let's take this man here, I'm going to take his blood and put it in this man here, I don't know, I probably have a 20% chance of getting it right. I don't know. And if I'm in that kind of situation, I just won't do it. Because if you have to give blood to someone, that is actually something that you have to take the time and the care to do. And doing it when you're under fire is not possible anyway.
What happens I'm more positive what happens if I gave blood to him.
It'd be great. You're the man that medics would be looking for. You can give to anybody. Yeah. But the problem is you can only receive from somebody that's an O negative.
Yeah.
So you have the problem if you're bleeding. It's going to be real hard to find somebody you can take blood, but you can give to anybody.
Yeah. O is a universal donor. And the
Well,
universal
that's
receiver
to
is B.
equipment or whatever you're involved with, whoever's in charge with the medical aspect. That you need to tell them, hey,
I can give to anybody, but I can't receive from
From just anybody.
Exactly.
And a B can get from anybody. So if you have a patient you're working on and he's B, oh boy, this is going to be easy. Let's go find an O. or we can find, actually anybody. So if you have an O and a B and well, the B is not that important. If you have, I'd rather have a whole platoon full of O's than I would anything else. However, even if you have dog tags,
AB is your common receiver.
AB is your common receiver?
AB.
Well,
It can take from A, B, and O.
Okay.
Well, what happens, what would happen if...
I'm getting ready to go into that here. Okay, let's not get sidetracked here. I'm gonna AB. Anytime you give blood from one person to another, it has to match, or it has to be compatible. And by compatible, I mean it doesn't turn to cottage cheese in your system, or you don't go into some sort of reaction and die. If you absolutely can't tell, and there's just no way you can do any kind of test, but I'm going to show you a test, or I'm going to explain to you a test, and it's definitely proved, then I would actually take the chance if it was going to ruin your life if I didn't. However, this is not the proper way to do things. And another thing you cannot count on is that you say you have O negative blood, O positive blood. I don't know that, and you don't know that, because I carried around dog tags that said that I was AB negative, and my dad carried around dog tags that said he was AB positive, and my blood type is A negative, and so is his. Because dog tags don't tell the truth. They have humans making these things out. Or maybe somebody told you what your blood type was, and you were 3 sheets in the wind, and oh yeah, it's a Z. You don't know what it is. You really can't count on that. It'd be nice, and I would take a chance if someone knows what their blood type is, but you can't know for sure. Now, typing and cross-matching in the field is possible. However, typing in the field is you have to have almost like a portable laboratory. I don't know of any easy way or even a hard way to do typing. You can find it in a book called a Merck Manual. It tells you how to type and cross-match. All right? And this is a good book to carry. This is one of the best books you can have. This is what the doctor says. He asks you a bunch of questions, he goes like this, and he doesn't want you to see what he's doing. He's looking up to see what's wrong with you. All right. But in combat medicine, there is a way you can tell if someone has compatible blood. I want to put this man's blood into this man's body. I take a glass slide, a mirror, glass is best, and I set it right here, make sure it's nice and clean, irrigated off, whatever. You don't want other substances on it. And you lay it down right here, and then I take a syringe, and I draw some blood from you, and I take another syringe, and I draw some blood from you. I take this syringe, and I put out a few drops of blood on this plate, on this glass plate. And I take this syringe and I put a few drops of blood on top of it. What's the coagulation time of blood?
Depends on
Well, I mean, outside the body, how long does it take? I'm trying to give them a rule of thumb here.
inside the body?
No, outside the body.
Outside. I would say.
Okay. You put the drop of this man is going to receive on this plate. The drop the man is going to give right here. Within, we'll just say 5 minutes. In battlefield medicine, 5 minutes is a long time, but that's a nice, safe time to wait. If it is not compatible, you have red cottage cheese. If it's compatible, you still have blood. It'll start drying, it'll start clotting and what have you, but if it is compatible, it is like pouring lemon juice in milk. It just doesn't work. And that is not typing. and which is a completely different story, but it will save your life. Because you're not going to be putting 2 gallons out of this man into your body. You're going to be putting small amounts. And you really can't trust completely if he has the type of blood that you can receive. And if you're going to go to all the trouble to save somebody's life by transferring blood from there to there, it doesn't hurt to have a second opinion, which is this little glass plate here. And anyone can do that. If you don't have syringes to draw it out, or a glass plate, you probably don't have IV here, or you don't have a blood pump, or you don't have things like this, so it's not that critical anyway. You can actually get the blood from the end of the finger. Makes no difference where the blood comes from. I say this, maybe you wouldn't want to waste a syringe. Now we get into let's see, field cross matching. Whole blood transfers. How would you get blood from this man to this man? You can't put it in a bottle because you can't even put IVs. You can't even make IVs, but you have to get blood from here to here. If you have some chalk, if you have anything of IV tubing that we have an attachment that looks like this right here, a T, you're doing real good. But you don't even have to have this. And I'm going to explain to you what happens and then show you the way to do it even without the T. Here's a man, and here's a man. You cross-matched him in the field. You have a reasonable assumption that you're not going to be killing this man here. And that is only a reasonable assumption, but it should be based on whether this man's going to die in the first place. So that is an acceptable risk, and I don't even like those kind of terms, but that is an acceptable risk. Now, you want to get blood from this man to this man. You know they match up, everything's fine. Your IV tubing goes into this man here. This IV tubing goes into this man here. The shorter the IV tubing, the better. Right next to him is fine. And right here, you put a syringe, preferably a 50 cc syringe. And this is not a 50 cc syringe. Yeah, you can. Okay. This will go up in here like this. Now, you're going from here to here. The first thing you want to do is get blood out of this man. If you have some sort of petcock up here, that's fine, but that's not going to happen. You take a pair of hemostats and you clip off right here. Now, this one is open. You draw the blood, 50 cc's, like this, and it's still attached to this T, or actually to a piece of tubing that's out here a little way, so you don't have to fill it with some other. Or you can just attach it to the tubing like this. Then you clip off this one here with your hemostat and unclip this one. Now, when you push on the syringe, slowly, it puts the blood in this man here. And you do that as many times as how many cc's you want to get in. If you have to use a 10 cc syringe and you want to put 500 cc's of blood, which is a lot of blood, a whole blood into a man, then 10 cc's times, you're going to do this roughly 50 times. We're not going to worry about the volume of the tubing. If you have a 50 cc syringe, then you only have to do it 10 times. You have to have sterile gear to do this. You cannot use the syringe that you've used on Bossy, unless, of course, you sterilize, but even that's not good. You need some sort of good medical gear. And by the way, the best syringes, if you can find them, and they last forever, are the old-time glass syringes. You can re-sterilize them. I do have some. They're usually 2.5 cc syringes, 5 cc syringes. And you have to be careful. If you see some in a hot shop someplace, don't just pick up the pieces and think you have something because they're numbered. If there's no rubber in them, it fits so perfect that is the seal. And you might have, if you have a 047 out here and a 238 here, they're not going to fit. They're made exactly. It's one of the best precision instruments you can get. But this is how you transfer blood from one patient to another. It works. It's not the best way to do it, but it's the only way we're going to have to do it that I can think of. Yes, I know that we can, there's different gizmos that we can come up with, but if you have one syringe and some IV tubing, just some IV tubing, you can make a blood pump. Now, if you don't have one of these T's, which you probably won't have, you have IV tubing going in this man here. This is clipped off. You don't want him leaking. IV tubing going in this man right here. And this is clipped off. You don't want him leaking. And by the way, when you clip off one of these tubings right here, you need to have a pair of hemostats that's been sprung. Or is made especially for that, because it will crush the IV tubing and you can't even get into the tubing. And what we used to do was take and put something in between the hemostat jaws. I might even have a pair to do this too. If you don't have the proper gear, which you won't, put something in between the hemostat jaws and bend it forcefully, with trying your best not to break it. The longer these things, the better off you are. Sometimes these are brittle and they'll go ahead and break anyway. And then we take just some IV tubing and slip over this to where it's padded. It's armored, like armored binoculars, only this is soft, so it doesn't crush things. And you can, if you don't have a pair that are sprung, and you go down like this, it'll crush the tubing. However, you can bend it like this and put a rubber band around it, and that'll hold the tubing too. Anyway, I'll just use these things here for demonstration. You've got hemostats right here like this. This keeps the man that you're giving the blood to make sure he doesn't leak out anymore, and the man you're getting the blood from not being a patient. But all you have is IV tubing going in here that you've rigged up, and rigged in there, and you do have a syringe. What you can do is, it's much slower, but it does work, is attach your syringe, unclamp this, take 50 cc's out, clamp it back off, come over here, put your syringe in, unclamp this, put your 50 cc's into this guy right here, keep a count, one, because this is a longer count. You may have to, for some reason, you may have to go 5 or 10 feet just to do this each time. That's really, you want your patient as close to the work as possible, but this may not be possible. You need to make a count because you want to give him exactly what you think he should have, 500 cc's or 250 cc's or 1,000 cc's is not a good idea. And repeat this process each time. It doesn't hurt to have someone there reminding you when you forget a step or you make a mistake. You have to keep this clean and sterile. You have to find someone to keep it off the ground. Cover it with something which is sterile. You have bandages that are sterile. You better have bandages. You have bandages that are sterile. You can set your IV tubing on the bandage and have another one here. It doesn't hurt to expend bandages for something like that. And if you do it right, you can still use them. But you have to think of what you're doing right then. And transferring blood from one patient to another is very dangerous, but it's something that you will have to do. Anyone have anything to add to this, or have an idea of maybe even another way to do it?
There is possibly another way to give blood. If you happen to have an IV bag, such as that one, the set, what you can do is take the donor, start an IV on him. Well, actually let a lot of the fluid run out like a 500 ml bag. Get down to about 20 milliliters at the very bottom of the empty bag. Go ahead and start the IV on. Let the man sit up, the donor, put the bag on the floor, or like way low, and that blood's gonna back up, and then you can measure exactly how much your fluid you're getting through that bag. So when that bag starts filling up with blood, discontinue, probably wipe it with alcohol at the tip, then start an IV on the person, the receiver, start that IV and run it through. Because it's sterile, it's in the tube, it's aseptic, and it might be a little bit easier than running back and forth. But that's only if you have IV.
However, when you do have a problem with this right here, and this is something you have to watch for, because you can use that, and this is the way they do it in plasma centers and blood banks and all of this. When you run blood into a bag like this, it can start clotting on you, and then you're putting clots into a human. And it also takes a while to get the blood out. And that was one of the reasons I asked you about, clotting time. And you have to keep the bag moving like this, or it will start clotting around the edges and work its way to the middle. And then you're putting clots into a human, and that will kill them. If it is possible that you can put a little heparin, warfarin, something that will thin the blood, into the bag. We're talking about a minute amount, and that will give you more time to put it to the patient. These are heroic measures here we're talking about, and the reason the blood pump is probably the best method in a combat medicine situation is you can do this laying on the ground. Nobody has to sit up or stand up, and guarantee you, if someone's shooting at you, you're sucking dirt. That's the way it is. Because you do IV therapy, bandage therapy, all this stuff on the run, in holes, you live in a foxhole for days, and your helmet is your bathroom, pour it out of the hole. You're in a terrible situation. That's in combat. In a natural disaster or a national disaster or anything along those lines, you can come across the same problems. If they had some of these roving gangs in L.A., Kansas City, Minneapolis, decided that they are very hungry, and they should be because they haven't had anything to eat, and I don't blame them. They're going to come looking for you, and guess what? You're in a combat situation. They're not up there to bite off of you or ask you, and they will kill you even if you give it to them. These are animals. So this is an excellent way of doing this. In fact, you could probably refill 500 cc bags in an IV solution, and that's how you can make that. If you got 2 of your 500 cc bags for normal saline, you got a 1,000 cc bag. I'd rather have 2 of them than 1,000 any day. And we would have to find some way where the blood doesn't clot. But then again, this is a combat situation. That's the only way you have to do it.
I mean, you don't have to be sitting up as long as the bag's lower in your heart, so you can be laying down. But like you said, if you're going to give it to the receiver, you're not going to be squeezing that bag. You have to have that valve wide open and just sit there.
Yeah.
Forcing that bag.
Blood pressure cuff will do it, push or something like that.
Yeah, you can build blood pressure cuff.
And one point on this right here, this is not shooting this idea down. Excuse me, you might not have a 50 cc syringe, you might only have a 2.5 cc syringe, and I'm not going to sit there and do that. I'm not going to get math on that one, I'll lose myself. I'm not going to do that. That is an excellent idea. That's perfect idea. I would go with the blood pump, and it just depends on the situation. We can't make up reserve blood, though, by putting it into bags, because you still have to keep it refrigerated, cool. And even then, even frozen, it only lasts so long. Yes?
If you were in a situation where you're going to transfuse into a bag for, say, in the next couple hours.
What now? I'm sorry, I missed that.
Okay, like you were saying, if you're going to transfuse into an empty bag or just empty IV bag for an exact amount or close to exact amount, couldn't you take in that IV tubing a junction and inject your heparin into that?
Yeah, this IV bag has a...
Yeah, it has a junction.
Yeah, this is, in fact, that's what that's for. Okay. That and antibiotics and what have you. That's what that's for. Yes,
On the donor, do you use venous blood or arterial blood?
you use venous blood.
Oh, you do. It's under pressure.
Any other questions?
How do you know how much? How do you know how much to take from someone? How do you know how much to give to someone else?
When a man, okay, you're really not sure how much to give to this other person. Anything helps. And it depends on your, if you have a casualty and he has some terrible wounds, you want to save his life, you're going to expend the time, energy, and resources to save this man's life, then you're going to go for pro. All right. Now I don't want to we have soldiers out in the field, we have people out in the field, and I slip on occasion, and I do not want to take, we'll say, over 500 cc's out of this man right here. So if I have to, I'll get more than one person to give. On this man here, you give him blood. If 500 cc's gives his symptoms back up to where they're manageable, then you give him 500 cc's. If you really want to go for it, and you have tremendous blood loss, but you know you can save his life, this is George Washington laying here, and you're gonna do your best, and I know that all of us in the same boat together, but yeah, we're gonna work hard for old George. And you might want to, because he's got blood flowing out, he's got blood going here, you don't know where it all is, he's got blood coming out of his ears, his nose, his rear end, his mouth, under his fingernails, he's gonna need a lot of blood, so you'll get blood from donors that you can until you run out of donors. You're not gonna strip a man dry and kill him just for this man here. I don't care who it is. However, when the symptoms start changing, you know you're doing okay. You know you're doing right. If you give him 3 gallons of blood and the symptoms don't change, you got a big problem. But blood contains oxygen, food, and it restores the circulation system. And it's 10 times better than the That's what the natural stuff is. And if a man is in a shock condition, then his symptoms will start to reverse. And he will become coherent. He will, his blood pressure will change. Although that's difficult to take in a combat situation. Blood pressure is not something that's easily done. Any kind. Yes?
I'm still not clear about the types that you can do this and do that with. We have O positive or negative. Does the positive and negative not matter?
The positive and negative matters. It's called the RH, I guess it'd be the RH factor. You probably understand IVs better than I do. Would you want to go ahead and explain that? I understand IVs about starting them, but I think this man knows a little bit better, and we need to get out the best guess here.
And his exact question was what, if the negative and positive?
Well, right on the board. I was going to say, right on the board, the actual one that can receive from anybody.
Give us
Put
a
that
blood
on the
lesson
board,
here. Do we want this? You want this on camera?
Do that.
Do you want this on camera? It's up to you.
I don't care. That's part of the tape, so we can show
That doesn't matter at all.
the universal recipient and the one that absolutely will not receive from whom.
You give us a lesson in blood.
Okay, well, you have a type A, you have a type B, you have a type AB, and you have a type O. And you have negatives and you have positives with all of these. Okay, type O is the universal donor. Hope I don't do a vice president potato thing. This is the universal
We'll understand your medical
receiver. Okay, so this can receive from anybody. Okay, and O can give to anybody. If you're type A, you can only receive from a type A. If you're type B, you can only receive from a type B. If you're type AB, you can receive from anybody. So it's really good if you're type AB. And AB can also give to A or B without a problem. So this guy can give to A and B, but he can't give O. O can't receive from anybody except for O.
Okay, so where does the positive and negative come in? Or
Positive, negative, I don't want to be quite quoted on this. I may be wrong, but if my memory serves me correctly,
the body can compensate the negative with the positive. So I believe if I'm type A negative and he's type A positive, I believe my body's system can overcome that. It's not the best thing, but it's oxygenating. I'll figure into that.
So O can receive only O.
O, yeah, that's right. O can receive only O, and anybody can receive from O.
Okay.
And it's best if children are involved that they would receive O no matter what.
Oh, you are screwed.
Oh, that's right. It's pretty much it.
Wouldn't it be, you know, under a combat situation, everybody could be sweating a lot and dehydrated, which would mean their blood would be thickened. Wouldn't you want to give a donor, you know, have them drink water?
Well, not really water. If you have oxygen available, that'd be the best thing. But water, it's going to take a long time for your body to digest the water, and it really won't do much good. Oxygen's the only thing that could help.
Oxygen.
Just like a lot of Olympic athletes, they'll withdraw blood from themselves into a bag when they're in super good shape, like they'll train in the mountains, and so their blood's in really good shape. And then so when they go down to a lower level before a tournament or something, they'll put that additional blood into them that has that high oxygenation level since when they were in shape. So their body's overloaded, and it's all in good shape, and they can perform better. So, yeah, oxygen's the best thing, best drug there is.
But you still have to replace the fluids that were removed.
Oh yes. You lose something, your body needs to replace it, or it needs to be replaced artificially through somebody or through some type of fluid.
Are you talking about that you would have to give
You're talking about for the
blood,
giving,
an IV?
the person is the donor. He's talking about giving some kind of fluid
Right,
along
but
with oxygen.
if you only donate a certain amount of blood, you might be a little lightheaded. You might need to eat something. That's the best thing, but you're not going to give,
the
2,000
if you're
cc's
50 cc, I mean, if you're 500 cc low on blood, it will not hurt you that much. It's a happy trade-off. This man may be 1,500 cc's low on blood. Down to that, he's in shock, has massive wounds. Cellular dizzy or upset or sick to your stomach. And you do not have to replace the blood that you take out of the system with another IV solution. This would be counterproductive. You can have him drink water.
The best
salt
boost,
water.
and the best boost actually quickest is actually oxygen if it's
Oxygen is the
available
best deal.
to the giving party.
to both parties. They're both. Yeah.
Your body replaces the fluid that you lose from, say, 500 cc's probably within about 8 hours.
Because your body's going to get rid of this. This is artificial. This does not stay in your system very long. This is temporary. You're going to urinate this out before too long.
Chuck, I hate to disrupt this for you. We've got so much further to go. I'd like to thank you so much for all that you've done for us. Now this, ladies and gentlemen, is an example of what Americans are supposed to do for others. This man took up his time, left his family at home, traveled 1,300 miles or 1,200 and some miles across the country over here to share this with us so we could put it together and share it with other Americans. Now this is just the medical profession. This is just a tiny part of that profession. We've got all kinds of professionals that exceed way beyond his capabilities in any given area, except for where he's had experience in the military. I mean, to shame you, Chuck. I'm not trying to do that at all. But there's people out there that need to be rooted out of their secure little cozy homes and showing how serious our country is. It's about to go down the tubes, folks. That doesn't apply just to the medical. That applies to the judicial system. You attorneys out there, you better damn well wake up now, and you judges, because you're about to lose your plush homes and your pools in your backyard, to say nothing of your Porsche in the front. You won't even have a bucket of grain for your families if you don't wake up and grow up. We need participation from every single American. If you want peace, prepare for war. And it's gone so far now that we have to prepare for war in this mode as though they're going to come to kill us. Is this pathetic or what? That's why I'm trying to promote a book called The Art of War. Folks, if you don't know what this is about, you better get in tune. There's not much time left. We'd love to have you with us when the lightning hits the latrine. We want to all make it through this. If we're not selfish enough to do just for ourselves, but we care for others, there's a chance we'll make it through what's coming. Those that are selfish don't deserve to make it through anyway. I'll warn them once. I'm not going to lead them by the hand. If they're going to spend their money on booze and drugs and gambling, to hell with them. I'm not going to help them, because that's not the kind of people I want with me when things turn over in our land. We better put it together. I'd like to thank each one of you so very, very much. It's been a wonderful experience for me, and I know that a lot of you have really enjoyed it, sitting on the edge of your chairs, participating with questions. I appreciate it very much. Let's not let the ball stop here. Let's keep making it roll forward as though this is just the bare beginning, because it is. We have a long, long way to go. Thank you so much.
I'd like to thank just a couple people, if I may. I'd like to thank my wife. She puts up with an awful lot. And I'd like to thank the friends in my own outfit, Rahab and his wife, Arkansas Bill, many people I can't even begin to name. And I'd like to especially thank all the Common Cause militias of Minnesota. And I would like to especially thank the state of Minnesota for just putting up with me up in that area, because if I hadn't picked there to move, then this probably wouldn't even happen. And I would like to thank all of you for participating, because I couldn't have done it without you, and that's a fact. And thank you very much.
Thanks again, Chuck. Appreciate it.